थोडंसं मागे बस थँक्यू. शशांक भाई सर को पूछो ना, सर को पूछो चालू करेंगे.
Yes, good morning. Good morning, everyone. Namaskar. Jai Maharashtra. Jai Jinendra. Jai Sri Krishna. Salam. Sat Shri Akal. Dear friends and respected senior colleagues, इंतजार की घड़ियां खत्म हुई. इंतजार की घड़ियां खत्म हुई. जिसका इंतजार 12 मुल्कों की डॉक्टर फैटर्निटी कर रही थी वो लम्हा आ गया है. Presenting most awaited academic event of the year and most appreciated academic feast of the year, Dr. G.P. Ratnaparki's Guru Krupa Heart Foundation present 7 CardioCon. This is our successfully 7th year. Same venue we are running four with Medical Club of Ville Parle, Andheri Medical Association. As a trustee of Guru Krupa Heart Foundation and Charitable Trust, and behalf of Chairman Guru Krupa Heart Foundation, Dr. G.P. Ratnaparki sir, Dr. Smruti ma'am, trustee of Guru Krupa Heart Foundation, I welcome to you all. This mega event, now CardioCon is not a Mumbai conference. Now, this is a Maharashtra state level conference because a lot of doctors came from Ratnagiri, Aurangabad, Jalna, Akola, Nagpur. So this credit goes to our dynamic, our Guru Bhai, pillar of foundation, chairman Dr. G.P. Ratnaparki sir and Smruti madam. There is a 10 international speakers. Great academic discussion of the day-to-day patient management. Grand inauguration function will be there. 2 MMC point, and that is a 5-star venue, the Lalit. We are giving gift more than 7,000, early bird to more than 2,000. And this is a unique conference with concept of conference of the doctor friends, by the doctor friends, for the doctor friends. With warm regards, Dr. G.P. Ratnaparki, Dr. Smruti Ratnaparki, Dr. Shashank Bhai Shah, Medical Club of Ville Parle President, Dr. Ashok Singh, Andheri Medical Association, and entire team of AMA, MCVP and team Guru Krupa. I welcome to you all again in this Maharashtra Wild CardioCon conference. Now I call upon today's convener, Dr. Tejaswini Pandre. She is a skin specialist practicing at Jaslok Hospital. Please welcome on dais.
कसं काय मुंबई? I couldn't hear it. कसं काय मुंबई? How's the Josh? I couldn't hear it. How's the Josh? How's the Josh? Very good. Good morning, all of you. I, Dr. Tejaswini Ratnaparki Pandre, welcome you all on the behalf of Guru Krupa Heart Foundation and Charitable Trust for this blockbuster CardioCon. I promise you this day will be full of academic fest, mouth-watering delicacies, and lots of gifts, and of course with lots of memories. Hope you all enjoy this day. So keep your mobile, so no if and but, keep your mobile shut. Thank you. And now I call upon Dr. Ashwini Chauhan for Dhanvantari Savan.
Thank you, Dr. Tejaswini. Good morning, all of you. May I request all of you, all the dignitaries, Dr. G.P. Ratnaparki sir, Dr. Shashank Shah, Dr. Ram Chavan, Dr. Ashok Singh, Dr. Praveen Soni sir, Dr. Smruti Ratnaparki ma'am, Dr. Rajesh Ghatkar sir. Hello. Please, I am requesting all of you to come forward for Dhanvantari Deep Prajwalan. And also I am requesting our speaker, Dr. Anil Sharma sir, Dr. Raj Brahma Bhatt sir, Dr. Darshan Jhala sir, for Deep Prajwalan for Dhanvantari Stavan, Dhanvantari Puja.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योति.
Thank you to all the dignitaries. Now I request our delegates to please stand up for Dhanvantari Stavan.
शङ्खं चक्रं जलौकां दधतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिहृदयां शुकपरिविलसन मौलिमं भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं
कटितट विलसन चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवना प्रौढदावाग्निनिलं प्रौढदावाग्निनिलम् ॐ. Thank you. You all can be seated.
Thank you, Doctor. Hello. Thank you, Dr. Ashwini. Now I call upon Dr. Mona Gandhi, General Practitioner at DN Nagar, Andheri. She is the first MOC of our conference.
Thank you, Dr. Tejaswini. Good morning, everyone. Good morning, myself, Dr. Mona Gandhi. Welcome all the esteemed doctors present here on behalf of Guru Krupa Heart Foundation and Charitable Trust. Today, we gather here in large numbers with great excitement and anticipation for one of the most prestigious events of the year, 7th CardioCon 2024, held at the Lalit, led by the visionary Dr. Ratnaparki Sir and Team CardioCon. I take the opportunity to thank Dr. Ratnaparki Sir, Dr. Smruti Ma'am, Dr. Ram Chavan and team for placing their trust in me and granting me the privilege as today's MOC for this monumental occasion. Adding to the significance of today, we also celebrate World Heart Health Day, making this gathering even more inspiring as we join hands in the global mission to improve the heart health. Despite his hectic schedule, Dr. Ratnaparki Sir has diligently attended to every detail to ensure the 7th CardioCon a resounding success. Dr. Ratnaparki Sir has thoughtfully refined our workflow and a smooth transition from planning to execution, making a keen focus on perfection. We proceed to our first speaker today of the CardioCon, Dr. Anil Sharma. Dr. Anil Sharma is a professor and head department of cardiology. Sir is one of the few Indian cardiologists who advanced fellowship in complex angioplasty from Italy. Dr. Anil has done more than 25,000 procedures in last 27 years, which includes coronary angiographies, angioplasties, and non-coronary interventions. Today's topic is high-dose statins sufficient for Indian dyslipidemia. Do we really require newer drugs? And insight of aggressive lipid management. So please welcome on the dais our first speaker of the CardioCon, Dr. Anil Sharma.
Thank you, Dr. Mona. Thanks, Dr. Gajanan, for inviting me such a big audience on Sunday morning. It's very difficult to see nowadays. I wish you all good luck today. Today is World Heart Day, and the theme is use action, use heart for action. So we are going to discuss today about insight of aggressive lipid lowering. Why we want to lower the lipid? ASCVD, what is ASCVD? Atherosclerotic cardiovascular disease, which includes coronary artery disease, means stable angina, unstable angina, ST elevation MI, non-ST elevation MI, and peripheral artery disease. We see a lot of gangrenes, peripheral ischemia, then atherosclerotic aortic aneurysms, transient ischemic attack, and stroke. Heart disease are number one killer. 33% people die because of this reason. Commonest being the coronary. What is the cause? The biggest risk factor. Wonderful article in Lancet by Dr. Salim Yusuf. About 50% patient has problem because of the lipid. It is the single most modifiable factor. What is lipid? It is one of the three things like carbohydrate and fat. It is the energy source. What is lipid? Lipid mostly is triglyceride and cholesterol. Triglyceride means glycerol plus 3 fatty acid, that is source of energy used by cell. Cholesterol is used for many functions like cell membranes, lot of hormones, and then bile acids. It has a function, definitely. Cholesterol is not always bad, but it cannot dissolve in the water, so it requires some association with the protein, so that we call lipoprotein. Apolipoprotein, so lipid, that is a triglyceride, cholesterol ester, phospholipid, free cholesterol, and the apolipoprotein is the carrier, so it travels into the body. There are two ways. One is the exogenous, we eat lipids, fat, and there is a liver forms the lipid. There are two ways. What we go from the liver is made is VLDL, very low density lipoprotein. It is lipid plus protein. It goes to the whole body, triglyceride, triglyceride, and then body there is a hormone comes, that is a lipoprotein lipase. It remove the triglyceride, free fatty acid is used, and then it is a less triglyceride, it goes further. So very low density protein, this size becomes smaller and known as a VLDL remnant or intermediate density lipoprotein. Again it travel, some more triglyceride is taken, so cholesterol percentage increases, then is known as low density lipoprotein. So this IDL or VLDL remnant and LDL are villains. VLDL remnants remain for 6 hours in the body, while LDL remains in 48 hours for body. So the most important villain is the LDL. It carries the ApoB protein. Triglyceride is ugly cholesterol, LDL is bad cholesterol, HDL is good cholesterol. HDL higher, it takes the LDL which is deposited into the cells and bring it and deposit to the liver. So HDL is good cholesterol. There were medicines to increase the HDL, but it did not reduce the event. So they say HDL is a risk marker, not the risk factor. Triglyceride again, there was some trials with the fibrate. I think Dr. Darshan is going to speak on that. LDL is the real villain. But how does triglyceride affect it? Triglyceride reduces the size of the LDL, so LDL can be deposited. So any molecule, whether it is VLDL remnant or LDL, less than 70 nanometer, it deposits into the cell, gradual deposition, atherosclerosis, and then it can lead to the, as we said, ASCVD. So lower the better. N number of trial, the first trial was 4S, about the simvastatin, 4,444 patients in 1980s. It showed 35% reduction in the LDL in the ACS patients. N number of slides are there. Different molecules, different doses reduces the LDL in different form. Like statin, moderate dose 30%, high intense dose 50%. Ezetimibe around 15 to 25%, bempedoic acid 15 to 25%. Then the two things which work on the PCSK, that reduces around 50 to 60%. Various combination we can use. The question is how low we should go. When we are born, our LDL is around 25, and Dr. Michael Brown and Joseph Goldstein got the Nobel Prize for this information. So up till 25 there is no problem. Even the trials have shown that even it goes to the 15 or 10, it does not harm anything. And earlier we said that statins are good, they have pleiotropic effect. Now we say though it has a pleiotropic effect, but ultimately any drug which reduces the LDL, it benefits. So lower the benefit. There are 4 things which we consider before starting medicine. What is the basal level? Higher the starting level, somebody's LDL is 200, he has more risk than somebody who has a 100 level. So basal level. Then what is the risk? Somebody who is just smoker, other person who already has some heart attack, diabetic, smoker, hypertensive, so he has a more risk. So ASCVD risk calculator, what is the risk of 5-year, 10-year, 40-year, we have different formulas to calculate. So higher is the risk, more aggressive we have to be. Higher the basal LDL level, more benefit we have. Stronger the dose, stronger the molecule, more benefit we have. And longer we give, more we have benefit. So these are the 4 things which helps in deciding what is to be given. What is this 40% reduction? Many times pharma people comes to you. 40% reduction means if like somebody has a 10% risk, means if for 10 years, if you give medicine, there will be 6 events. If you don't give medicine, there will be 10 events. So medicine reduces the 4 events. 10 होने वाली थी, अब 6 हुई यानी 4 रोकी, 10 में से 4 रोकी यानी 40% रिडक्शन हुआ. 90% लोगों को दवाई दो या ना दो फर्क नहीं पड़ेगा. If somebody has a 20% risk means 80% को कुछ नहीं होने वाला. So it is not in 0 or 100, it is the probability which is more important. So these are the basic 5 medicines. Other thing is EPA and bile acid sequestrant. Bile acid is only role mostly in the pregnancy because statin was contraindicated. Last 2 years as statin has been removed from the contraindication. It can be given if there is a very high risk of MI. They work differently. Like statin is a HMG coenzyme reductase inhibitor. In the hepatocyte, just before that, there is a medicine bempedoic acid. The advantage of bempedoic acid here is that it is activated in the liver only, so it is less likely to cause muscle spasm, which can be a side effect of statin. But statin has the highest data of the showing the events. One thing is ezetimibe, that is it prevents the absorption of the cholesterol in the gut, so that is absorption. 2 are in the liver. Other 2 medications, that is working on the PCSK9. What is PCSK9? They work on the LDL receptor. LDL receptor take the LDL and deposit into the liver, and then again it goes back, take more LDL, goes into the cell. This is LDL receptor is cycled. PCSK9 damages that LDL receptor. So if we can stop this PCK working, we can increase the LDL receptor, we can reduce the LDL. There are 2 ways to stop PCSK9 inhibitor. One is antibodies, they are known as PCSK9 inhibitors, 2 molecules we will see. And the another latest thing is that is the inclisiran. It does not allow synthesis of PCSK9. It works with the messenger RNA. So there are different ways. So we are talking about the moderate and low dose, moderate dose and high dose. So atorvastatin and rosuvastatin are one of the most commonly used and most strong statins. Higher the dose, more is the benefit. It is not moving. Can somebody help? ये भी थक गया. So higher the better, definitely higher dose. As I said, moderate dose statin 30% reduction roughly, high dose it is a 50%. Again there is some problem, same problem. You want to do from that side? Because in the 2020 era, the time is 30 minutes, but Dr. Gajanan told me to finish in 25 minutes. Okay? Sorry, it is moving. Okay. But there is a problem with the statin. What are the problems with the statin? It is underutilized. There are 30 to 50% patients are not on statin. Why not on statin? Doctors have not advised. Doctors have advised, but patients are not taking. That is adherence. Some take it irregularly. Some people, I know one of the cardiologists when I joined 27 years back, my teacher, when he used to eat samosa, he used to take atorvastatin. But that is... And one of my cousin who was an IPS officer, Used to say, I am not feeling well today, so I will take atorvastatin today. So these are not the scientific way of taking. So one is the adherence. Regular taking is medicine is very, very important in the prescribed dose. So adherence is very important. Those who are high intensity statin taken irregularly, other group moderate intensity, so low dose but regularly. So those who are regular is better. That we learn Kachua Khargosh ki kahani. The slow and steady wins the race. So we not only have to be stronger molecule, we have to be consistent. And 50% are not on the target. They don't take it. Hyporesponders, they are taking medications but they are not effective. And somebody has a side effects. Rarely it can cause diabetes, it can cause stroke, but benefits are more than the harm. Clearly, if you say for 100 new diabetes because of this medication, you can see here there are 1,000 people are, so 10 times more benefit than the risk. There is still residual risk in spite of the statin or all the groups, but there are other factors also from the lipid profile like diabetes, obesity, inflammation, lipoprotein A. As I said, lipoprotein A, some 2 trials are going on which will be published in 26 and 27. Whether it reduces the event or not, we do not know. There are drugs which reduces the lipoprotein, but it helps heart or not, we do not know. So after the statin, this drug came in agitimib. This is the IMPROVE-IT trial. Further there was a 2% absolute risk reduction, but it found that it is more useful in those patients who have multiple risk factors. They kept this, you can see here, 9 risk factors here. Just a minute, control L. So these are the 9 risk factors you can see here. So depending on this risk factor, age, heart failure, diabetes, all these things, more the risk factor is there, more is the benefit of adding this medication. Another trial, this is published recently, this compared rosuvastatin 20 milligram versus rosuvastatin 10 milligram plus agitimib. It showed that rosuvastatin 10 plus agitimib, there was a less discontinuation and less new onset diabetic. So it is a safer, more adherent, better. Another molecule, that is a bempedoic acid, it reduces the LDL from 15 to 25%. Patients on statin, it at 25%, alone it is 25%, with the statin it is 15% reduces. But the problem, little bit problem is with bempedoic, it increases the uric acid, so it can cause gout, it can cause tender rupture. So those who are on fluoroquinolones, on steroid, elderly, and there is a little problem of the prostate and the atrial fibrillation. So be careful, nothing comes free. So we have to be careful, this medication, the risk, benefit and cost, RBC, not red blood corpuscles. Before prescribing any medication, you should see RBC, risk, benefit, cost. Other thing is ESC, efficacy, safety and cost. So this is a clear outcome trial that showed that definite benefit of the heart. Those who cannot tolerate statin or cannot tolerate the high statin, then agitimib plus bempedoic acid can be taken. Both combines around 36% reduction in the LDL. And apart from the LDL, there is a reduction in the hsCRP, that is a marker of inflammation. So lowering statin, lowering the inflammation. So these are the 2 molecules which is working on the PCSK9. You can see here, this is LDL receptor, take the LDL in the cell, it is recycled, and this recycling is taught by PCSK9. So PCSK9 is just like a traffic havaldar or traffic signal which does not allow, it is a red signal. So it goes inside, it does not allow this LDL receptor to come back. So if we stop this PCSK9, antibody against it, the recycling of the LDL receptor, so LDL will be low. It reduces, there are 2 trials, 2 molecules are there, Fourier trial in the ACS patients with evolocumab and ODC trial in the stable patient with the ACS about the alirocumab. So this is about the antibody, and there are now more advances like genetics we are moving. This is the new molecule. This is what a small interfering double-stranded RNA which does not allow this to be formed. It reduces the more than 50% LDL reduction, and whether it reduces the event, in next couple of years we'll come to know. So these is from the 1994 from the 4S trial, simvastatin, 4,444 patients, 4444 to now there's so many trials, 5 molecules are there. What guideline says? Guideline says, again depending on the levels, there are 4 groups. One is secondary prevention, those already have ASCVD. 3 primary groups, those who are diabetics, those who are LDL is very high, that is more than 190. A third is what is the high risk, that is more than 20% definitely, less than 20% depending on the various factors you discuss with the patient, may or may not be given. So this is 70 they kept is the threshold, Americans in 18. In 19, European made it is 55, more stringent. And then Indian have 2 guidelines. One is the CSI that says in ACVD it has to be 55 because we are more prone. Why we are more prone? We have high triglyceride, low HDL, LDL is small size, so atherogenic lipidemia more than Western world. Plus our lifestyle cooking pattern, we eat more carbohydrate and we cook reheating of the oil and high temperature heating and diet. So these are the factors. We have a younger age disease at a younger age, more riskier as compared to the Western world. 50% of the patient has LDL, the population have LDL more than 100. So 19 ESC said reduce the LDL to the 55 with the statin. If not possible, add additive every 4 to 6 weeks, then add PCSK9 inhibitor. And then 2022, they changed this more aggressive. If those who are on the high risk, start a statin plus agitamib, and those who are very high risk, like multiple factors, we discussed the 9 factors in this trial, multiple factors are there, recurrent events are there, then right from the beginning give statin, agitamib and bempedoic acid, and see after 4 to 6 weeks, if it cannot be reduced, within 3 months, you must start some injections. So we are moving. This is again international lipoprotein, the same thing. If the LDL is 110 to 116, give 2 medications, statin plus agitamib. If underlying is more than 160 basal statin, right from the beginning start with the 3 medications, then add medications. If statin cannot be tolerated or partially tolerated with the lowest, highest tolerable statin, add agitamib and bempedoic acid, and then add the PCSK9 inhibitors or inclisiran. So this is how the targets ASC 70, ESC and CSI 55, and there is the most stringent by the Lipid Association of India. It says keep it less than 40. So depending on that, you can see here the guidelines here. This is the risk about everybody, it should be less than 70. If there is a SCVD, those who are the high risk, it may be 50, 40. So if you want to remember one figure, I would say bachpan ho ya 55, LDL ho 55 se kam. SCVD is number 1 killer, lipid is risk number 1. Apart from the lipid, we need to lifestyle modification to control the diabetes, hypertension, obesity, smoking, tobacco chewing, stress, and 6 hours sleep is must. LDL targets, as I said, depending on the ASCVD, it may be 70, 55, 50, 30. But one figure you remember, who do not have ASCVD 70, those who have ASCVD 55, if recurrent event or multiple, like diabetes, simple, diabetes with the 20-year duration, diabetes with the target organ damage, diabetes with the multiple risk factor, more aggressive you have to be. LDL target is 30, what we said, 17, 55. This more important thing in Indian guidelines is non-LDL, because we have triglyceride more as compared to the Western world. If we add 30 in LDL target, it becomes non-HDL target. If LDL target is 70, for non-ACVD, for primary prevention, LDL target becomes 70 plus 30, so it keep it less than 100. While for non-HDL target, if it is 55, keep it less than 85. We are moving from LDL to non-HDL because all non-HDL carries ApoB, and the coming, I think in the next couple of days, we will stop talking about the LDL and non-HDL. We will talk about the ApoB. Pregnancy, you have to are very careful. I said most important in adherence. Thank you very much. Still 15 seconds less, Dr. Gajanan. So 5 minutes for discussions. 2020 में बोलते हैं ना, दो बाल रहने से पहले जीत गए. All is clear or everything is totally clean? Yeah.
And what as we can start study the preventive measure, and what is the complication of long time taking the statins, fibromyalgia, body pain, what is to be done for that?
See, technically, if there is some problem with the statin, you have to stop it, wait for 2 days, 2 weeks, and then restart with another statin. Even if it occurs with the same statin, then we call it a statin-induced intolerance. I will just keep it here with the statin slide. You can see here, in the screen you can see very well. Yeah, here you can see here. This is the statistics. So start with the statin. If it is a ASCVD, start with the high dose statin. High dose statin is 40 milligram or 80 milligram atorvastatin or 20 or 40 milligram rosuvastatin, whatever you prefer. But in the ASCVD nowadays with the ACS coming, we start with the ezetimibe. Some doctors start statin low dose plus ezetimibe and bempedoic acid to take care of this statin, and after 3 months they decide. So there are strategies which is beyond the science, like some people give the injection PCSK9 inhibitor for initial 3 months because it start immediately, it brings down the LDL. But that is not the scientific way. Scientific way, I already said, aggressive is better. So you start statin and ask patient to take regularly and make sure that at least 50% reduction is there. It will ensure that you prescribing medicine does not reduces the LDL. Taking medicine reduces the LDL. So whether he is or she is taking or not. So if 50% reduction is there, it ensures that he or she is taking medicine and it is effective. If it cannot be reduced after 4 to 6 weeks, then add another medicine, add third medicine, then maybe injection. 5 medicines we have discussed.
How long we can take PSK9 with a SGLT2? How long, and what is the
See, trials has been done up to 3 years, data is there. But now there are more and more time goes, there will be more data is there. So up till 3 years, that is a safe. It 50 to 60% reduction of the LDL and with the event reduction also. So with the more time, the graph separates. So they say that it should be continued, maybe more, but data we have up to the 3 years. Because any guideline, so if you say somebody should say 15-year data, it is very expensive. Yeah.
Thank you.
Okay. Okay. Thank you very much. You can message me or you can discuss with Dr. Ratna Parke. Yeah, thank you.
Thank you, Dr. Anil Sharma, for such an informative lecture. And for the felicitation of Dr. Anil Sharma, may I request AMA President Dr. Ashok Singh, MCVP President Dr. Shashank Shah, Trustee of Guru Kripa Heart Foundation and Charitable Trust Dr. Ram Chavan, Trustee of Guru Kripa Heart Foundation Dr. Smruti Ma'am, Chairman of Guru Kripa Heart Foundation and Charitable Trust Dr. GP Ratnaparki sir. Please give a big round of applause. Moria. Jai. Thank you, everyone. Doctors, with your heart so pure, you offer hope, you find the cure. Your dedication, day and night, guides us towards the light so bright. For every tear you wipe away, for every word of hope you say, we celebrate you on this day for making pain and fear decay. We move towards our second speaker today, Dr. Darshan Jhala. Dr. Darshan Jhala is MD DM Cardiology. Dr. Darshan Jhala is a senior interventional cardiologist with more than 25 years experience in the field of cardiology. Dr. Darshan has undergone training in the USA for electrophysiology. Dr. Darshan has been a principal investigator for RELY, Trial for Diabetogram Area of Interest, Cardio-electrophysiology, electrocardiography and angioplasty. Sir has done more than 71,000 cases. Dr. Darshan Jhala is associated with hospitals like Leelavati and Nanavati Hospital. Today's topic, management of hypertension, where we stand in 2024. Please welcome on dais Dr. Darshan Jhala.
Good morning. Thank you for the introduction. And I thank Dr. Ratna Parki for giving me this opportunity. Normally, when we talk of such things, generally we find people talking about guidelines. I don't like to talk about guidelines because it's one of the most boring ways of presenting any data. You just keep talking about numbers and but fortunately, the ESC released hypertension guidelines, but this time they released in a very good way. So this time, apart from numbers, they have actually given very good practical suggestions. And this time really the guidelines have made things simple. Normally you find that they introduce some extra numbers, they introduce some extra terminologies and create whole lot of confusion there. Fortunately, the ESC guidelines, which just got published last month, have made things simple, which is really very good thing on that part. So what is the new thing that has happened in this? So I will be comparing the older guidelines with the newer ones. So the older guidelines had said that BP should be classified. They started off with classifying BP so that it helps us in risk stratifying a patient and starting the treatment. So they said optimal, normal, high normal, and then 3 grades of hypertension. So this practically was not possible. We read it multiple times, but we could never understand it. This time the whole thing has been made very simple. So it's non-elevated BP, elevated BP and hypertension. That's it. So when you are non-elevated BP, you don't need treatment. Elevated BP is those people who don't fall in the classic BP numbers, 140, 90. But recent studies have shown that these are the people who are also at a high risk of developing future cardiovascular events. So instead of labeling them as hypertensives, we have labeled them as elevated BP. The connotation is the same. They are given a little more leeway, try lifestyle measures for 3 months. If they don't respond, go ahead and start pharmacotherapy. Things have become very, very clear. The first update in this ESC is the title. They have changed from arterial hypertension to elevated blood pressure and hypertension. So one more new term has been introduced, but it has simplified the things. So elevated BP is a BP, office BP defined as 120, 139 or diastolic BP up to 89. So these are below the standard cutoffs of 140/90. But they are the people who still require treatment. So these numbers are used to label those people who do not meet the traditional thresholds. So why 120/90 has been selected because if you recall about 5 years ago, a trial called sprint trial came, which said you should lower BP below 120. 119 was the target. But we found a lot of problems with this. First of all, the sprint trial was taking BP in an isolated room with no physical contact with any attendant, darkened room, no sound, patient to be waiting there inside for 5 to 10 minutes and then an automated. Such things cannot be done in our day-to-day practice. So what they realized is that the BP target set by sprint 119 was actually equivalent to a BP target of 120 to 129 in the office. So in practical circumstances, 120 to 129 equivalents to a isolated BP measurement of 119. So take this as a practical number and use it for treating patients. Of course, one of the important things that the guideline this time mentioned is that the patient should tolerate this. It's not like you have to do it. So the tolerance of the patient, they took patient feedback, and in these guidelines they have incorporated patient feedback in deciding the numbers. Second thing that they have decided very good is, we used to say that in the initial stage there was a two-step approach. So first you target it down to a certain number, and then if that patient is tolerating it, come down. Now that emphasis has changed. What they are saying is, we are not opting in to a lower level, we are opting out to a higher level. So target everybody to a lower level. If they don't tolerate, then let them go to a higher level. So the emphasis has changed from two-step approach to a single-step approach, where you bring them down to 120 and below 90, and if they don't tolerate, then let them go up a little bit. So instead of opting in, we are now telling them to opt out of to a little higher level. So this is a total change in thinking. That means we are now concentrating on lower levels of blood pressure, provided they are tolerating it. So for those with elevated BP, that means those who are not actually hypertensives, you allow 3 months of standard therapy, standard non-pharmacologic interventions, and then let them, but then after 3 months get into pharmacologic intervention. So the emphasis is that don't wait too long to start drugs. Okay. So, in cases where on treatment systolic BP is at or below target, but diastolic BP, now this time they have addressed the diastolic BP. So far they were all ignoring diastolic BP. So what do you do? So if your systolic BP is at target, but your diastolic BP is above 90, go ahead and intensify the treatment. Bring down the diastolic below 90, again provided the patient tolerates the treatment. So because now they have realized that the cutoff value of 90 for diastole is the one that is to be used for reducing CVD risk. So this time diastolic BP has been separately addressed. So the message goes out, opt into lower levels, opt out if you are not tolerating it, target diastolic BP to below 90 even if your systolic BP is at target. So specific drugs have been mentioned, that amongst all BP lowering drugs, ACE, ARBs, dihydropyridine C3Bs like nifedipine, thiazides and chlorthalidone are the drugs to be preferred. This is actually same as the previous guideline. So they have actually accepted the previous guidelines, and if the blood pressure is not lower by the 3-drug combination, and if spironolactone is not effective, then you may add a beta blocker or you may add a centrally lowering drug like moxonidine or clonidine or an or a alpha blocker. So these three drugs are relegated to the third line treatment, but they have specified these drugs. So now you don't have to, you have guideline backing of how to go ahead and use the drugs. Amongst older patients who are not frail, there is no separate BP target. Below 85 years, if your person is not frail, then the target is same as a young person. Very clear message that you don't have to de-escalate the treatment for elderly people, provided they are not underweight or they are not frail. And the treatment should of course be well tolerated for them. Another thing that they have introduced is that whatever new therapy that you are introducing for future, drugs, interventions like renal denervation are not to be only targeting blood pressure, but they have to be targeting cardiovascular risk as a whole. So the entire emphasis from blood pressure lowering to cardiovascular risk lowering has been emphasized. So any procedure or drug which will be introduced in future will be not only targeted to lower blood pressure, but also to lower the CVD risk. And this is like the diabetic guidelines, where it is mandatory that the anti-diabetic drugs have to bring down the blood sugar and improve the CV outcomes. So this is another major shift, that they are now shifting from blood pressure numbers to CVD risk reduction numbers. How do you measure blood pressure? Well, it's the standard that you have to use a non-oscillometric blood pressure which are calibrated. But the important thing is that for atrial fibrillation, the standard oscillometric methods have not been validated. So unfortunately, people with atrial fibrillation will still need to undergo manual blood pressure measurements. Unfortunately, we don't have now mercury available, but you'll have to use the aneroid blood pressure. So there is a specific recommendation that you should not be using the standard Oberon type of machines for people with atrial fibrillation. You must have had this very commonly. People have atrial fibrillation, they come back with various numbers, and when you actually measure it, they are different. So this is a very clear indication which they have given that it should not be used. These instruments should not be used in atrial fibrillation. Orthostatic hypotension has been emphasized and defined as to what that is in these guidelines. Less than 20 millimeter, more than 20 millimeter systolic drop or more than 10 millimeter diastolic BP drop is diagnosed as orthostatic hypotension, and they recommend that during the first interview with the patient, all 4 limb blood pressure should be taken, and you should check for orthostatic hypotension in every single patient that you are starting off as a first consultation. So this has been emphasized now. Yeah. So for deciding treatment about elevated blood pressure or how aggressively to treat, what they are saying is that use the CVD scoring system instead of blood pressure numbers. So they are talking about a score called the score 2, but this is not applicable to us because the score 2 algorithm does not take into Asian and Indian population. So there is a scoring system called JBS 3, the Joint British Society 3 recommendation. If you look into the internet, you will get the calculator of JBS 3. JBS 3 will give you, by feeding in numbers of blood pressure, age, other things like arthritis, family history, and HDL and total cholesterol and the blood pressure, it will give you a 10-year risk. So any 10-year CVD risk of more than 20% is high risk. Less than 10% is low risk. Somewhere in between is the moderate risk. So for deciding in a young patient, for example, you want to know he is in the elevated BP range. You are not very happy to start medications. should I start? Do the JBS score. If you find his JBS score is moderate or high, don't wait. Age is not a contraindication. A young person also needs to be protected. And that is why I use these CVD scoring systems to assist you in deciding about treatment of a blood pressure patient. So the emphasis is now changing from number of blood pressure to the risk factor management. And blood pressure has to be taken as a part of risk factor management, and that is why they are now shifting this, and this has come in the guidelines. So you have to use scoring systems to decide about how early to start treatment in a given patient. Certain specific sets like pregnancy complications, etc., have now been defined as high risk. So if you have had a pregnancy related hypertension may have become normal subsequently, but they are to be considered as high risk individuals, and they should be monitored frequently, and if they develop any other risk factors, they should be treated as elevated BP and the treatment should be started. Ethnicity has been defined again. The darker races are more prone to hypertension, and that is why more aggressive treatment is required. If you have a difficulty, so for example your blood pressures are borderline and you don't have any other traditional risk factors, and you still would need like to do a risk stratification, go ahead and do a coronary calcium scoring, or looking for plaques in the carotid by ultrasound. If you find this, treat them as high risk and start treatment. So these are again guidelines. So this is a very strong recommendation that these things have to be done. They say opportunistic screening of blood pressure should be done every 3 years for adults less than 40 and every year for more than 40 every year. So this is another recommendation which we have to keep in mind. Adherence of the drugs should ideally be checked by looking at the drug levels in the urine. I don't think this is very practical. If CKD is diagnosed, you do more frequent blood pressure monitoring. And coronary artery calcium scoring also is, if it is high, they should be taken as high risk individuals. Another important thing which I do routinely for every single patient that I see first time, especially if they are lower, means if they are below 40 or if they are above 60. Screening for primary hyperaldosteronism, it's very easy. There are 2 tests only required. The renin, the plasma renin activity or plasma renin level, which is easily done by all the good laboratories. At rest, let the patient rest for 10 minutes, collect the sample. And plasma aldosterone concentration. Then you take the ratio of that. So the PAC to PRA, aldosterone to renin, if that ratio is more than 20, then it is suggestive of primary hyperaldosteronism. It is not uncommon. 1 in 10 patients of those particular age group will have this, and though the treatment really works is ARBs and spironolactone, but still some of them may not respond, and these are the people who need to be evaluated for adenomas. This is not uncommon, and I do this routinely for every single patient that I see for the first time. They have recommended increasing potassium intake in people who do not have CKD and substituting sodium salts with potassium added salts for preventing blood pressure. And blood pressure treatment, lowering treatment should be continued lifelong, even beyond the age of 85 years if it is tolerated. Again, a very clear statement. There is no hanky-panky about it. Old people do not have normally tolerated high blood pressures. They have to be treated and continue treating them. Another thing that has come here is that there used to be something called chronobiology. Means there was a lot of talk about when to give the drugs. whether to give it at night or whether to give it in the morning, or whether you should do an ABPM and then decide the time of blood. Nothing like that. They have made it clear. Whatever time is convenient to the patient, let him take that medication so long as he takes it at the same time. So another good practical suggestion. I am surprised that these kind of small suggestions they have made from European society. Secondary hypertension has to be evaluated, especially below the age of 40, except that there is a young obese patient. Those people have to be screened for OSA, obstructive sleep apnea, because that's one of the commonest causes of hypertension in the young, obesity. These people need not be evaluated for steroid related problems, but they should be evaluated for OSA. And this is another strong recommendation coming from there. Pregnancy, they have of course said that ABPM and home blood pressure monitoring should be encouraged to diagnose pregnancy related hypertension. For elderly people, of course, you have to estimate frailty. If they are not frail, treat them as young people. If they are frail, then you have to target at a higher blood pressure level of about 140/90. Orthostatic hypotension they have defined, and they have said that you should start when they have supine hypertension and standing hypotension. Try to use non-pharmacologic measures, or if you have to use pharmacologic measures, use short-acting drugs which act only during the sleeping hours. Strong recommendation for using SGLT2 inhibitors in CKDs where the eGFR is more than 20. Here, of course, this is applicable to empagliflozin. Dapagliflozin is only up to GFR of 30. But if your GFR is above 20, then there is a recommendation to use SGLT2 inhibitors because of their modest BP lowering effects. So this is another very, very strong indication for a single class of drugs, which the guideline has mentioned. Renal angioplasty was relegated to the background because of a trial called Coral trial. This time they have given good recommendations. They have said that it is a procedure which should not be jumped. But in specific subjects like recurrent heart failure, unstable angina, sudden onset flash, pulmonary edema, or resistant hypertension, or those with a unilaterally small kidney, these are the people, if they have a renal artery stenosis, it should be treated with angioplasty. Because of the Coral trial, the angioplasty, renal angioplasty got a bad name. And those who were practicing it were considered to be doing something unethical. That's not true. This time they have realized, and this is exactly what we used to do, that these are the people who should be selected for angioplasty and they will benefit. Those who have CKD, ACE and ARBs should be used. The moment you have CKD and you start ACE ARB, your nephrologist likely to stop this. Do not do this. Actually, they are beneficial only if the creatinine starts rising beyond 25%, or if you get severe hyperkalemia. These are the only reasons not to give them. Otherwise, they are highly beneficial and they should be continued if they are tolerated. Another guideline directed recommendation. Renal denervation, another procedure which was given a bad name, has this time, the previous guidelines junked it. This time they have said that renal denervation now has sufficient data to use it for those people who are resistant to 3 or 4 drugs and who are not responding to standard treatment. There is another thing which has come which says that those with increased CVD risk, even if they are not on 3 drugs and their blood pressure is difficult to control, you can consider renal denervation. In fact, renal denervation even works for heart failure because eventually it denervates the sympathetic system. It's like using beta blockers. Also works for atrial fibrillation. So probably is a procedure which will gain more and more popularity as time passes. Heart failure, of course, we all know that they have to be treated with most of the heart failure drugs are also antihypertensive drugs. So they have been given just the standard mentions here. In cerebrovascular accidents, there have been some differences that when you have acute hemorrhagic stroke, you have to bring down the blood pressure in the first hour only by 70, regardless of what the blood pressure is, and then over the period of 6 hours, slowly bring it down to a target level. And in ischemic stroke, keeping the blood pressure target is the same as any other patient. They used to say you should keep the blood pressure higher, but now the guideline says that no, the ischemic strokes, non-hemorrhagic strokes are to be managed like standard hypertensive patients. So in summary, the most important point is that the target systolic BP for adults receiving BP medications should be 120 to 129. A new category of elevated blood pressure has been introduced because these are the people who are prone to get CV events. The guideline focuses on true risk reduction related to the cardiovascular system and not just to blood pressure lowering. Out of office blood pressure measurements are recommended. Lifetime interventions are recommended for 3 months only. After that, pharmacologic treatment is probably necessary. And a risk-based approach to hypertension treatment is recommended. Self-measurement of BP is encouraged except unless you have atrial fibrillation. And another thing that they have emphasized is that you have to see that the drugs are taken properly and the guidelines are implemented, then only the guidelines will work. Thank you very much.
Hello.
Questions can be taken later on as we are running short of time and so many lectures. So please cooperate. Thank you, Dr. Darshan Jhala, for such a wonderful lecture. And for felicitation of Dr. Darshan Jhala.
Yeah, short and sweet.
I welcome on stage AMA President Dr. Ashok Singh, MCVP President Dr. Shashank Shah sir, Dr. Ram Chavan sir, Dr. Smruti ma'am, and Dr. Ratna Parki sir.
Thank you.
Please give a big round of applause.
Sir.
Informative lectures and good knowledge.
Ganpati Bappa.
Moria.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you once again.
Thank you.
Dil tham ke baithiye dosto. We are having a first bumper draw of CardioCon, which is worth rupees 8,900.
By the auspicious hands of Dr.
By the auspicious hands of Dr. Darshan Jhala.
एक ही ना?
Everybody is anxious and eager.
T.R. Shah. And those who are in hall, they will get only.
Dr. T.K. Shah.
Only present in the hall will get it.
Mobile number is 9324 311 040.
ठीक है ना, पहले दे दो, आने बैठो, आओ जल्दी आओ,
थोड़ा जल्दी आइए सर।
लेट होगा तो चला जाएगा वो। यूरो किसको थायराइड देना पड़ेगा, एल्ट्रोजिन देना पड़ेगा, इतने में से सर का लेक्चर हो गया था।
मैं उनका नाम लिख लेता हूँ और ये कर देता हूँ।
सर हाथ लगा चला।
जरूर।
Congratulations.
इधर देखो।
The bumper draw, today's first bumper draw of CardioCon.
हाँ,
सर सामने
आया।
सर का चेहरा दिख रहा था ना।
दिख गया।
Dr. Darshan Jhala, please. As it is said, उम्र थका नहीं सकती, ठोकरें गिरा नहीं सकती। उम्र थका नहीं सकती, ठोकरें गिरा नहीं सकती। अगर जिद है तो जीतने की, जनाब हार भी हरा नहीं सकती। We move forward to our today's third lecture by Dr. Vivek Mehan. Dr. Vivek Mehan is MD Internal Medicine and MD Cardiology. Dr. Vivek Mehan is a renowned cardiologist who has an experience of more than 30 years. He has received Young Investigator Award of USA in 1994, an Outstanding Young Indian Award in 1996. Sir specializes in cases like coronary angioplasty and peripheral angiography. At present, he is a member of editorial board of Catheterization and Cardiovascular Interventions and Journal of Association of Physicians of India. Sir is associated with hospitals like Lilavati, BSES, Criticare and Nanavati. Today's topic is understanding sudden cardiac death in young population. Sir, please welcome on the stage Dr. Vivek Mehan. I would request everyone to please keep yourselves on mute.
So I hope I'm live. Audible? Okay. So the story started as follows. Ratnaparki called me up one day and said, boss, I go to the gym every morning. You see now Ratnaparki has lost weight. Where is he? He's become a fit young man. So I go to the gym and now more and more people are saying that my gym partner died, my swimming partner died, I go for Zumba classes, somebody died. And there's been a lot of news in the newspapers about young people dying. So I said, yes, even I find the same. And people are asking me that, is it because of COVID? Because those of us who are in the interventional field saw that during COVID, there was something which went on, especially in the first phase of COVID and maybe the second one also, where people were dying. And we saw thrombosis taking place. We saw myocarditis, changes in the hemorhythmic propensity. People blamed COVID, people blamed the vaccine, and all of us who go for a walk or a swim or Zumba classes or walk on the beach or the gym do get these patients all the time. But since there's no evidence correlating directly COVID, he said, no, change the topic and talk about sudden cardiac death in the young. No, I am a plumber. He tells me to talk on an electric topic. So I'm not an electrician. But you know what Ratnaparki is like, na? He says, मैंने एक बार बोल दिया तो मैं खुद का भी नहीं सुनता. So I said, give me some angioplasty topic. He said, no, you have to talk on this. I love Ratnaparki. He's a good friend of mine. I can't say no to him. So I took the help of a young friend of mine, happens to be Jhala's son. Is he here? He's not here. So this guy is an electrophysiologist, and he gave me slides like this, 300 slides for some presentation he had done in some international conference, talking about the Purkinje fibers, talking about the electrophysiological mechanisms, talking about slow channels, fast channels, sodium, calcium, potassium channels, and then further 300 slides on the fragmented QRS. Ratnaparki said, if you talk like this, everybody will sleep and they won't get up till after the inauguration is over. And I've called many VIPs for the inauguration. I need the audience awake. So don't put them to sleep. So I said, okay, let me talk about an electronic topic, electrical topic like a plumber. Let's make it easy. Split it down to the basics. And the basics are as follows. All of us have faced this question when you go to the gym or for a walk. Doc, my friend died suddenly in the gym. What should I do? You see these headlines, young actor died, young cricketer died. What should I do? Everybody's scared. So I'm going to try and take you through the basic principle as to what is it. So to know a basic idea of what is going on, and then to be able to answer this question to whoever asked you that. So these are the two things that we are going to talk about in this talk, not going into what Malav has bombarded me with 300, because that's even too much for most non-electrophysiological DM cardiologists. So at this stage, I want to take a pause and ask you, who will say this? Somebody died, don't bother, you don't investigate yourself. Which of our audience members will tell a person in your gym, you've been working in a gym, your gym partner who's been working with you for the last 2-3 years comes and says, my friend died, what investigation should I do? Will anybody say, don't investigate? No, na? Now let me change the question. I will say, don't investigate. So who agrees now with me to say that my gym partner who's been exercising with me for 5 years comes and asks me, when I will tell him don't investigate, now please tell me how many of you will agree with me? I see a few hands. So at least that's the way to start off with. So we all think, oh my God, we need to investigate. So let's understand what is sudden cardiac death. So obviously it's sudden, but I'll give you the definition as it comes word by word, line by line, so you understand what you're dealing with. So it has to be unexpected and natural. So if somebody is shot, he's not sudden cardiac death. It's natural death due to a cardiac disease. So if he dies of a ruptured brain aneurysm, it's not sudden cardiac death. It's sudden death, but not cardiac death. In which there's an abrupt loss of consciousness, which occurs within a short time from the onset of symptoms. So within 1 hour is what is traditionally described. So somebody has symptoms and dies within 1 hour is categorized as sudden cardiac death. And further, that is a person who doesn't have any prior condition which would appear to be imminently fatal. So if somebody is bleeding or has cancer and has an imminent condition by which he's likely to die and he dies after 1 hour, it doesn't categorize. So we are restricting ourselves in today's discussion to a person who has a sudden cardiac death as we defined, and that also in a young person. So it has to be natural, it has to be rapid and unexpected. That is the definition of the person who we are talking about today. A few more words, a few more terminologies that we should understand. First is sudden cardiac death, which we already described. Then you have cardiac arrest. A cardiac arrest means the heart rhythm stops. Okay, now these are fine definitions but worth understanding. And you have a cardiovascular collapse where the heart stops pumping. So they obviously come along with sudden cardiac death, but you can have cardiac arrest without sudden cardiac death, you can have cardiovascular collapse without sudden cardiac death. And you know what the SIDS is, sudden infant death syndrome? If that happens suddenly in a person who is older than 1 year, SIDS is less than 1 year, this adult is called the arrhythmic death syndrome. So these are a few definitions just worth knowing, nothing to be done about it. Now you will be surprised that 10 to 15% of all deaths which occur in the world are sudden. 75% of all natural sudden deaths, so of all people who die suddenly, have a cardiac cause. It's about 1 in a lakh in childhood or young adulthood, and a little bit more in the older age groups. I'm trying to keep Ratna Parki has threatened me about the time. Now, unfortunately, it's a major cause of death in the young and middle-aged people after recreational sports, which is why we are talking about it today. There's also this interesting thing which is called the 50% rule. That 50% of all cardiovascular deaths are sudden. 50% of all sudden cardiac deaths are unexpected first expression of a cardiac disorder. So 50% of those who have unexplained cardiac disorder will present with sudden cardiac death. And of course it leads to a 50% loss of life. So it's just one of those things which they use. Now when you consider a person who suffered from a sudden cardiac death, there are 4 events which occur. One is the prodrome. Now the prodrome is what happens earlier. So let's talk about somebody who's been going to the gym and has died. A young man. So few days to weeks before that, he might complain of weakness. He might complain of breathlessness. Those are the prodromes. So he may have some non-specific symptoms which were missed because they were thought of it might be related to illness or weakness. Then comes the onset of the terminal event, where he feels some chest pain, breathless, giddy. He may be just feeling giddy. And by definition, within 1 hour, this leads to a loss of effective circulation and consciousness. So this portion constitutes the sudden cardiac death. Now, at the end of this 1 hour, the person may be resuscitated or may be non-resuscitated. And then it leads on to biological death, which can happen after minutes to hours to weeks. So that's the final aspect of this is how the chronology of sudden cardiac death works. And this is where you need to work on. Now this is a slide which all of us must see and understand to be able to answer that friend of yours who's been exercising next to you, who asks you, what should I do? So when you consider sudden cardiac death, the overall incidence in adult population is 1 in 1 lakh. So of a lakh of people, 1 person will have a sudden cardiac death. But since the population of India is 1.4 crores, of the world is 8 billion, 1.4 billion and 8 billion, the total number of people who will die suddenly with a normal heart is large. So if 10 people die suddenly, 8 of them will have no idea that they had a cardiac disease. And that is what creates panic. As the cardiac risk factors increase, the incidence of sudden cardiac death rises, the percentage of people, but the absolute number falls. Because there are not too many people in this world who have cardiac arrest in the past or who've had myocardial infarction with poor LV. So the bulk of the people who die, the bulk of the headlines which are seen, nobody says somebody who's had an angioplasty and bypass in the past and was in the hospital 15 days and died suddenly. It doesn't cause panic. Because people think, okay, he had a heart disease, he had to die. But those numbers are small, absolutely. What creates panic and excitement in the audience is the man who was okay, he used to come to the gym, he died suddenly. He was normal, he had no symptoms. How did he die? But the large number of these is a small proportion of the entire population. This is something we have to remember. We should divide these, and we are dealing with the left side of the figure where we are talking about the young adults. Now in these people, the marker is a little dubious. Maybe your battery is dying out. So in these people, understand, you have another marker? Pointer. So in these people, understand that coronary artery disease is 10% or less. Remember this. Mainly, it is either structurally abnormal heart, like hypertrophic cardiomyopathy or left ventricular hypertension, or aortic stenosis or things like that, or a structurally normal heart with things like Brugada syndrome, arrhythmogenic right ventricular dysplasia, etc. It is in the older population where coronary artery disease contributes for a large number of people. But we are talking today about the young person with sudden cardiac death, where you are unlikely, by definition, to find coronary artery disease. There's a problem with this, it doesn't advance the slides also. So I need a new marker, a pointer, and if somebody can advance the slide. The battery is gone. Next slide, any udhar se kar do. So you do it here. Okay. Another pointer, if you don't mind. Pointer milega ek? Okay. सो पॉइंट ये नहीं चल रहा ना, आपका बैटरी मर गया है। मैंने किया। दूसरा पॉइंटर ला दूँ ना यार, सादा वाला लेज़र वाला नहीं है, कोई बात नहीं, दे डोंट सीम टू हैव इट, डजंट मैटर, क्योंकि इसमें एडवांसमेंट का भी नहीं हो रहा है। इसका चार्ज होता है कि क्या है कि बैटरी है। वापस ट्राई कर लेते हैं आप कहते हो तो। सो अगेन इन द यंगर एज ग्रुप वी आर टॉकिंग अबाउट पीपल हु हैव नॉन ischemic causes of death. As the age grows, the ischemic incidents take over. Of course, you have the standard risk factors for sudden cardiac death, which apply for any sort of cardiovascular disease: smoking, alcohol, stress, lack of exercise. But in the younger, you have to think about genetics, hereditary, that's in the other people, sudden cardiac death, structural heart diseases, and other diseases which are like hypertension and diabetes. So, common presentation is somebody in the gym dies. ये भी चलेगा, दोनों छोड़ दो। कौन सा वाला? Green button, ये वाला। So the somebody in the gym dies. Now this is the what is called is the exercise paradox. What is the exercise paradox? The exercise paradox is that exercise is protective and also the cause of seeing such patients. So regular exercise is good for cardiovascular health. It is also good to prevent sudden cardiac death. But exercise is the biggest trigger for sudden cardiac death in almost 15% of patients. Paradox. Secondly, in the first half an hour of vigorous exercise is when you find the man starts running on a treadmill, the man starts swimming, the man starts rising, climbing a mountain. But at the same time, the paradox continues by the people who have been doing regular high intensity exercise have less overall incidence of sudden cardiac death. The problem with us and with our friends are that most people are weekend warriors. They want to enjoy, they don't do anything during the week. They party, and on Saturday, Sunday, they suddenly wake up and said, oh, now I have to do my exercise. So then they come for that HIT, the high intensity training, that they'll call a trainer who will make them run unnecessary amounts of things. So weekend warriors is the problem. So in athletes, as I said, the incidence is 1 in lakh. Coronary artery disease is uncommon in young people. I showed you that slide earlier on. The most common causes of sudden cardiac death in the young people who die as an athlete or non-athletic, casual exerciser, are the things which you see over here, which are either, as I said, structurally normal or structurally abnormal heart. But sudden cardiac death is often the first representation. Somebody with hypertrophic cardiomyopathy, they don't know, he's playing football, suddenly dies. And you say, young footballer found dead. But that's the first presentation. And that is where we are now discussing as to what is to be done. There's also this thing called commotio cordis, which happens in contact sports, where because of trauma to the heart, there's either myocardial rupture or arrhythmias which take place. But that's a different subgroup altogether. For understanding sudden cardiac death, remember the 3 aspects which are to be included. One is the substrate, something which modifies the substrate, and a trigger which sets off the sudden cardiac death. So the substrate are the conditions which we mentioned earlier, like hypertrophic cardiomyopathy, myocarditis, long QT syndrome, arrhythmogenic right ventricular dysplasia, WPW syndrome, congenital coronary abnormalities, Brugada syndrome, other patients because of heart diseases. That's the substrate. The person has that and is unaware of it most times. Something alters the substrate. What is this something which alters the substrate? That could be simple thing like ischemia, because of excessive exercise, so there's a mismatch between demand and supply. And as bad as ischemia is reperfusion, because all this causes the changes in those ion fluxes. The first slide that we were thinking of showing you, the slow channel, fast channel, sodium, potassium channels, all these change once the reperfusion takes place. And that causes the substrate for an arrhythmia. Drugs, alcohol, let's not forget alcohol. They party on Saturday night, and they want to make up for the rest of the week on Saturday and Sunday. Then acidosis, hypotension, and lastly exercise, which causes an alteration of the supply demand. And what sets off this is either a VPC or an APC or just short runs of atrial fibrillation or flutter. Of all people who present with sudden cardiac death, 80% will have a tachyarrhythmia and 20 will have a bradyarrhythmia. Most of the ones that you will see have ventricular fibrillation. If you see them early enough, it starts off in some people with ventricular tachycardia. And these, if the earlier you see ventricular tachycardia, which goes into ventricular fibrillation. And if ventricular fibrillation carries on for a long enough time, then you get bradycardias, cardiac arrest, electromechanical dissociation. How does the time before you pick up translate into patient survival? So if you pick up the patient in the first 2 minutes, you're often going to see ventricular tachycardia or ventricular fibrillation. And with intervention, you're likely to get back the return of spontaneous circulation in almost 80 to 90% of patients. And of them, 50% will survive. So 2 to 4 minutes, you have high survival rates. As you go beyond a certain time, 7 to 10 minutes, fibrillation degenerates into asystole or bradyarrhythmias. And then these survival rates fall. And if it takes you roughly half an hour or so, survival rates, discharge from hospitals are abscessively low. Which is why it's important to work quick. Which is why you have the EADs and at all the railway stations and the airports. Which is why the CPR is so important. If you notice or witness a cardiac arrest, quick actions will save lives. End of story. So, we are nearing, so I'm going to just go over these symptoms quickly because Ratnaparki has threatened me with dire consequences for going on for longer, and there are certain questions I want to ask you. Now you say carry on. First you scared me. So the worst thing that you need to happen is if a person has had a sudden cardiac death in the past, but then that person who's already had a sudden cardiac death in the past will not be working in the gym next to you and asking you, what should I do? Because he is going to be already seen by one of us. And we would have acted upon him. But this guy is at extremely high risk. He's a 50% risk. Or a family history of sudden cardiac death. So if your next door gym partner tells you, boss, my friend died, what should I do? Ask him. You were okay? No, you never had that? No? No. Anybody in your family has died suddenly? No. Once he answers these two questions in no, then he goes into a different risk class. Then, of course, you have, as I mentioned, the coronary artery disease, heart failure, HCM, Brugada, mitral valve prolapse syndrome, etc., etc. So, first degree relative of a sudden cardiac death has a 2 times risk of a cardiac arrest. Again, I want to reiterate the same thing which I showed you earlier, that the risk is such that the number of patients is largest with those who have no risk factors. And the number is smallest with those who have higher risk factors. So a risky patient who has an EF of 20% is never going to be working in the gym. He might be walking at the beach with you. But this is the sort of people who's likely to ask you. And these are the people at risk. So if you take the entire population, most of sudden cardiac deaths is coronary artery disease. But only 20% of survivors of out of hospital will have evidence of a new MI. So when you do an ECG, supposing somebody reaches the hospital after sudden cardiac death, you do an ECG. The ECG will show minor changes. You won't see an MI. Your cardiac enzymes will be elevated. And why is that? Because most of these people who have during an exercise is because of supply and demand mismatch. Or even if there's an occlusion, that may not cause a sudden cardiac death. The reperfusion, which happens because of spontaneous reperfusion, causes electrolyte shifts. And the diagram we showed you in the beginning, which causes a sudden cardiac death. So it's been a moment of occlusion, alteration in dynamics, in the electron fluxes, reperfusion. So the artery is open. You hardly get any changes in the ECG. But that shows us that this, for a person like this, the first thing we must do is a coronary angiogram once he reaches the hospital. Of course, people who have higher episodes of ventricular tachycardia, or who have heart failure, or who have hypertrophic cardiomyopathy, have a higher risk. And certain people, if you have a person who has hypertrophic cardiomyopathy, of course, it will be seen mostly by people like us, because you will immediately refer the patient to a cardiologist. There are certain risk factors which are high risk factors, in contrast to others which are low risk factors for getting sudden cardiac death. The Brugada syndrome is again because of electrical instability of the right ventricle. Mitral valve prolapse in some people with certain risk factors will have a higher incidence. Yeah, so 25 minutes. Ratnaparki, I have 23 minutes. Do I have some more time? Okay. Long QT syndromes. The investigations that we do for patients like this are the standard. We don't need to go into each of them. I'm not even going to enumerate them. But finally, what we do is late potentials, QT dispersals, T-wave alternans, electrophysiological studies, which is where Malav Jhala comes into the question. The therapy. The therapy, again, I'm going to run through these because I have some questions to ask you in future. Is the general medications for the cardiac status. Beta blockers have a great role. So do the AICDs, the implantable cardioverter defibrillators, which senses. AICD is like a pacemaker which senses arrhythmias which take place and then decides, it's an intelligent device, it decides whether to overdrive and suppress that arrhythmia or to give a small shock or a large shock. And this is life-saving, which has been shown in trial after trial that if you have conventional therapy versus an ICD therapy, they're life-saving. So the AICDs for anybody who had something like this is essential. I won't go into the details of therapies for each of them, just understand that AICDs will save life and beta blockers are probably the important baseline of medical therapy. I can't emphasize on the importance of bystander CPR and the AEDs, the external defibrillation devices, because every minute that you save or you waste will increase the risk by 10%. So if you are running around not knowing what to do, 10 minutes is going to probably make a difference between life and death. So now we come back to the question that I was asking you. So your friend who's been exercising with you for many years asks you as in the gym, Doc, my friend died suddenly. What should I do? And that's where now you are supposed to be the clairvoyant mystic and tell him what to do. Suddenly he asks you, Doc, what should I do? And you're supposed to look at him and say, do this. So I'm asking you, we need your participation. CT angio. The problem is if somebody has a sudden cardiac death, everybody is scared. Half the people who ask me say, Doc, I got a CT angio done. It's normal. Am I safe? So somebody who, and people like Roshan Shetty have popularized the CT angio so much. Is he here? Roshan? No, he's not here. So they popularize that everybody feels that CT angio is the answer. My CT angio is normal, my final test is okay, and it's done. So I ask you, is the CT angio for a young person who has no symptoms before this, is it a good test or a bad test? So who says you will do a CT angio first? Calcium scoring. So the point is nobody says we should do CT angio first, which means the question I asked you in the beginning is justified. That because the coronary artery disease as a cause for sudden cardiac death in young athletes is 10%. And somebody who's been exercising regularly with you for days, years, is unlikely to have coronary artery disease. You would have got some symptoms by now, generally. ECG. What about an ECG? How many of us, show me hands, na, come on, I can't be all asleep. Yeah, so some people will do an ECG first. So somebody who, your neighbor, your 25-year-old boy whose friend has died, asks you, we will do an ECG for everybody. Change, please. Change. Okay, yeah, sorry. Ratna, I'm 27 minutes. Huh? I have a timer, huh, so. Next, aste. Okay, 2D echo and stress test. How many would do 2D echo? How many would do stress tests? So you remember, we're doing it for the 1.4 billion people. Huh? So people, everybody, you're doing this for everybody. Screening. My young friend died suddenly. Your next door neighbor on the treadmill is asking you, my friend died suddenly while he was in the gym. What should I do? Who will do nothing? Nobody. The whole talk is waste. The answer to who will do nothing has been driven into our minds. This ad came in today's paper. खुद को टेस्ट करते रहो. Everybody is promoting. Do your tests. If your tests are normal, you're normal. The purpose is that even the ESC and the AACC criteria for young athletes just talk about physical examination and discussion. I'm talking about testing. You're right, ma'am. Perfect. इनको भी prize देने का है रत्ना. So the question is, which investigation will you do first? And the point is, most people come to me on the in the gym and say, I've done a CT angio, I'm okay, I have nothing to risk. Of course you have no risk. You had no risk earlier on also. Now you have no risk because there's nothing wrong. So when I say you will do nothing, I don't mean that you will do nothing about family history asking them, if you come to me, have a physical examination. Let's talk about your diet. What is your stress factors? Do you smoke? Cut down on smoking. Do you take alcohol? Stop your alcohol. Whatever you exercise, boss, don't suddenly come on a weekend and ask your trainer to train you. That is what you should do more than investigate. The purpose of the entire talk is that yes, ECG, echo, etc. is a good thing. But if you start doing that for the entire population, even the European and the American guidelines for young athletes do not talk about doing it for everybody. If you suspect it in some patient has some symptoms, has a family history, has something, then you by all means go and do it. But the only problem is everybody likes to investigate. Can you go to the earlier slide, please? Everybody likes to investigate. खुद को test करते रहो. Patient is happy. Companies are happy. And you are also happy. Test कर दो, बात खत्म. If you listen to my advice, then you are in trouble. So don't listen to my advice. You will give the patient good advice and patient will think something else. Thank you.
Hello. Thank you, Dr. Vivek Mehan, for such an impressive lecture and creating awareness on the sudden death. For the felicitation of Sir, please may I call upon Dr. Ratnaparki Sir, Dr. Ram Sir, Dr. Smruti Ma'am, Dr. Ashok Singh and Dr. Shashank Sir. Shawl by AMA President, Dr. Ashok Singh. Bouquet by Dr. Smruti Ma'am. Silver lamp by Dr. Ram Chauhan. Ganpati Bappa idol by Dr. Ratnaparki Sir. Ganpati Bappa. And a memento by Dr. Ratnaparki Sir and Dr. Smruti Ma'am. We have a bumper draw. दिल थाम के रखिए दोस्तों.
$149. Kiran Danait. Danait. है?
Okay.
आवाज नहीं आया, लोगों को लगा अच्छा है, नेक्स्ट करने मिलेंगे ना.
Give him a big round of applause. The bumper draw is worth rupees 8,400. Thank you, sir. In moments of distress and fear, it's your calm voice we long to hear. Your knowledge and gentle care are the answers to our prayer. We move forward to our fourth lecture of CardioCon today by Dr. Anand Rao. Dr. Anand Rao is a coronary and structural interventionist. Sir is a specialist in coronary and calcium management, pioneer in transradial interventions. Currently serving as Honorary General Secretary of CSI Mumbai. Dr. Anand Rao proctors in intravascular imaging and complex interventions, DNB cardiology, and teacher in Holy Family Hospital. Today's topic, coronary angioplasty in calcified vessels, various options. Please welcome on dais Dr. Anand Rao, our fourth speaker of CardioCon.
Thank you, madam. Good morning, everybody. I would like to compliment Dr. Ratnaparki and Dr. Anil Kumar and the team of CardioCon for organizing this meet and inviting me over here. Sorry. First of all, wishing everybody a happy World Heart Day, and the theme of World Heart Day this year is Use Heart for Action. So I think wishing you all a very, very healthy heart. So my job is to talk about calcium management. I'll make it as simple as possible because this is a topic which is a very purely cardiology topic, but I'll try and make it simple. So every time Dr. Mehan's lecture, somebody said calcium score. Yes, I think, yeah. So I think a CT angio is one thing where calcium score is very, very important. And as you all know, more than 300, 400 calcium score in CT angio puts you at that risk of having a block. And most of the time the interventional, most of the time the radiologists refuse to do an CT angio. They'll tell you to go for the regular angio. Now, if you look at the treatment of calcified lesion, why calcium occurs? Many of the patients come and ask, I'm taking shell cal for so many years, is it because of that? No. Calcium is something which nobody knows the cause. Like somebody gets premature balding, somebody gets a premature cataract. Calcium is something which is you don't know what is the cause. We have seen calcification in 25, 30-year-old people. And we have not seen calcium in an 85-year-old gentleman. So we never know why this calcium occurs. But calcium, as an interventional cardiologist, poses me a lot of challenges because I have to choose my tools. I have to choose my tools properly. So what are the risk factors for calcium? So this is one: aging, diabetes, renal disease, hypertension and smoking. This may not be there. We have seen calcium even without these risk factors. So calcium is just there, and well, as I told you, it poses us a lot of issues with us. So when you do an intravascular imaging, angiography is two-dimensional. When you do a coronary angiography, it is two-dimensional. We are seeing the vessel like this. We don't see the vessel like this. So we need to do intravascular imaging, and that's been a mainstay for all my patients. A lot of my practice involves intravascular imaging. Almost 25 to 30% of my practice is based on imaging. Why you do imaging is because of this. You see the impact of calcium over here. It poses me because it does not allow the stent to expand. It does not allow for my stent to go inside. It increases complication, it increases procedural time. So I have to understand this before going inside. Why calcium is very important? Because if you look at all these things, death, cardiac death, MI, and major adverse cardiac events, red is severe calcium, gray is less calcium. If you have severe calcium, your overall adverse events becomes more. So person who is having less calcium, person who is having more calcium, he is got more liable for high risk and further events. So this is again, how do you see calcium on angiography? First of all, when we screen a patient, we see the track of the artery. That's called a Stram track. So if you see that, then my mind starts working, I should use something else for this patient, cutting balloon, rotablators and all those things. So these are various grades of calcification, how I can see it. It makes an impact for the treatment. Imaging, what I said as OCT. This is optical coherence tomography, which earlier was used by ophthalmologists. Now it has come to the cardiology domain, which you see inside the artery. And once you see inside the artery, you will understand the morphology of calcium, you will understand the depth of calcium, you will understand how much quadrant of calcium it involves. 1 quadrant, 2 quadrant, 3 quadrants, arc of calcium and the length of calcium. So all these things will make a very big impact. Now when you do imaging, you can detect almost 75% of calcium. When you do an angio, you will not know much, because angio is 2-dimensional and this is 3-dimensional. You will understand the type of calcium, whether it's a deep, superficial or nodular, and you can do a calcium scoring also, which is also this thing. So I'll show you some images, so it becomes very interesting for you to see. These are our images. See, this is what you have read in physiology. This is the artery, how you see. This is the intravascular imaging, which is called as OCT. This is intima, media, adventitia. If you remember your physiology days, this is the vessel, this is the catheter, this is the wire. This small arc is wire. Now if you look at this is called as eccentric calcium. In the both, and this is called a concentric calcium. See, the calcium is all over the place. So for this, I have to use a different device. For this, I have to use a different device. So deep calcium, it goes in adventitia. It is not in intima, it is not in media, it is in adventitia. That's called as deep calcium. Superficial calcium, it's very superficial. See this, it's very, very superficial. It's close to the intima, it's closing, it's very close to the lumen. So it's called as superficial calcium. So here I have to use rotablators or orbital atherectomy and so on and so forth. Then there are nodules, calcific nodules, nodular calcium and calcified nodules. These are also very important. If you can see, this is a protruding calcium. This is protruding into the lumen. It's protruding into the lumen. If I don't shave this off, how will my balloon and stent go inside? So this is important to understand why imaging is so important. It's nodule. See this, it's almost obstructing the lumen. So if I take a rotablator, I shave off this nodule, then I'll be able to deliver my balloon, stents and whatever. Sometimes these nodules can be calcified. Look at this high degree shadow here. These nodules can be calcified. So these are calcified nodules, much more complex than the regular calcium. It's not going at this. How do I go further? This is not working. Can somebody run the sites, please? Okay. This is a calcium scoring, which will not go in detail of this. And so there are two types of imaging. One is OCT, another one is intravascular imaging, which you can see here. You can see the superficial calcium, deep, those bright shadows, what you're seeing is all calcified calcium over there in the arteries. So then there's thin calcium, there is thick calcium. You can understand this. Top panel is OCT, the down panel is intravascular ultrasound, and this is the angiography, what you see. On the angiography, you don't see anything, but you do imaging, you see this and you classify this, and based on that, you go on for the treatment. So there is a scoring system, which I don't want to get into details, more for cardiology lecture. Yes, angiography, calcium present, then you do IVUS, intravascular imaging. If it's more than 270 degree, you do the scoring. Once you do the scoring, then you use either rotablator, laser or atherectomy. I'll show you some images and some cartoons. It will be easy to understand. You might have heard a lot of people talking about rotational atherectomy. The left side you see this rotational atherectomy, it's a 1.25 to 2.5 burr. This has got a diamond crust on top. This diamond crust rotates and goes inside at 150,000 or 200,000 revolutions per minute. It goes inside and then shaves off all the calcium. Rotational atherectomy needs a specialist. Not everybody can do it. In Bombay, a lot of people do it in Bombay, but I've been a pioneer for doing all these things, and I go to central India and a lot of other states to teach rotablator. Almost on average 70 rotablators I do every year. And this is a very, very 30-year-old technology, but it still holds good. Second, in the central panel, you see laser, which I don't have an experience. I have one experience of one case, doing one case. Orbital is a new kid on the block, which has come 1 month back. We had a pleasure of doing 2 cases. I did one case yesterday, left vein orbital, and day before yesterday we did another case. So I have experience of 2 cases, rotablator, of course, for many years. Then there are many other devices, like high pressure balloon, Scoreflex, cutting balloon. I'll show you some images so you'll see how it goes. Now this is how a scoring balloon goes. If you see, the scoring balloon has got wires on top of it. So when it dilates, the wires sort of cut the calcium and makes the pathway more easily for them to go inside. And on the right panel, if you see, this is a cutting balloon. It has got blades. The balloon has got blades inside. If you see the balloon, the blade come out and cut the calcium. See, it has made 3 dents over there. It cuts the calcium. So this is called as cutting balloon, which is one of the best innovations ever made. You see the blades over there. There are 3 or 4 blades, and it cuts the calcium. And then, so once you cut the calcium, you see the fractures in the calcium. You do imaging. You see those fractures. One at 2 o'clock, one at 6 o'clock, and one at 10 o'clock. You see those fractures of the calcium. Then you know that you're done enough for this thing. Now rotational atherectomy, as you see, this is a diamond tip burr which keeps on rotating at 180,000 revolutions per minute. And if I can run you, this is the angiography which I did, and that's how the burr looks. And this is a cartoon image. See the burr which is drilling the calcium. It doesn't go inside, and you have to keep on doing this. And once you know that it gives away, then you know that you are adequately debugged the calcium. So this is what I was telling, orbital atherectomy. We have experience of 2 cases. It was launched only a few months back, maybe a month back. This is an extremely important tool which is very friendly. What it does is, it has got a burr in the center. It whips the artery like this. It cuts the calcium, and it is very, very safe. And of course, all these things are expensive, but it's very, 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 you see how it cuts, it shaves off all the calcium, it whips through, and then it cuts the calcium, and then you have a situation where the stents and everything goes. So this also needs a bit of training and a bit of experience, which we are gaining. I think over the next couple of months, we'll do more cases, then we can talk about it. So this is how it looks when you do the imaging, how the rotablator has cracked those calcium, and then you will be able to pass your subsequent this thing. Now the other device, which is again, it's called as intravascular lithotripsy. So this balloon has got emitters. It's got emitters, 1, 2, 3 and 4 emitters are there. This emits sonic waves, and it cuts the calcium. It's an expensive device. But if you keep this and it cuts the calcium, and then remove the balloon, and then you can put your stents and all those things. This is called as intravascular lithotripsy, which is available. I have experience of more than 50 cases of intravascular lithotripsy. So this is how the fracture is produced. The calcium is broken. Now laser, this is a very expensive device which is available in 3 hospitals in Mumbai, and the laser, it's the same thing. It goes inside and it gives pulses, the sonic waves, and then it creates cavitation. It breaks the molecular bond, and then it dissolves the calcium. So this is how one of the case which we did, and that's a laser which is going on inside. You keep on flushing the saline, and the laser cuts through the calcium, and then it debulks the calcium. So some of the cases I want to show, I'll end up my lecture by showing some cases. This is, as you can see on the left panel, central RCA, severely calcified. If you look at it, the wires are not going. Then finally, we put a microcatheter, is not growing, and then, as you can see, we pass a rotablator, and here is the rotablator which is drilling the calcium inside, and then once that is done, then we use a balloon, NC balloon, and then we use a cutting balloon. These are cutting balloon, how it looks, and then you see the final result on the right side panel, which is very, very acceptable. These are very complex lesions, and then stenting of the distal, mid, 3 stents we put, and we came out with an excellent result. So this is another patient, 65-year-old male, hypertensive, non-diabetic, increasing angina earlier, rest angina in last few days. EF is normal, renal function is normal. So if you look at it, this is a left main, the LAD on top is severely calcified, and we need to do something, because you can see the calcium without even imaging. On top of the artery, you can see those gray shadow, that is all calcium over there. So we did imaging, and this is how the artery looks. It's circumferential calcium, it's arc of calcium over there, and eccentric calcium is also present, and then there is nodular calcium also which is present. So we take the IVL balloon, this is intravascular lithotripsy, this ablates the calcium, we use that, it's got 120 pulses, so we use 40, wherever the calcium is there, the whole area we use the pulse, and then once we do that, we do the imaging, we see the vessel size, how it looks, and then we put a stent from left main to LAD. If you look at it, it's a beautiful result, the stent is very well expanded, and that's how the image, final imaging looks. So this is another case which we did an orbital atherectomy yesterday itself, yesterday I think so. Yeah, so this is done at Leelavati Hospital. This patient had undergone a stenting by me in the right coronary artery, if you can see the stent. So he has come, anomalous, he has come with a left main stenosis. If you see near the catheter, there's a left main osteostenosis, there's a middle LAD stenosis. So we thought we'll use an orbital atherectomy for this patient. And if you can see, the burr is going down and it whips the artery and clears the calcium. It goes all the way. It's a fantastic device and very, very user friendly. What I found out about this device is it actually expands the lumen so well, and then it makes easy for the balloons to go in and then pre-dilate and then put a long stent, and your job is done. So it saves a lot of time, and this is how the artery looks, very beautiful and well expanded stent. So ladies and gentlemen, my take-home message will be calcified lesions need a critical analysis before proceeding for further steps. I'm not trying to boast, I have learned the hard way, but if somebody cannot handle these cases, please call the experts to do this. Calcified lesions need a lot of hardware to debug. The knowledge and expertise is paramount importance, because you have to understand these come with some complications, and you should know how to handle these complications. Intravascular imaging is extremely helpful to understand the magnitude of calcium and subsequently to use an appropriate tool. So imaging and calcium goes together. Further on, one must be able to handle the complication arising like perforations, stuck burr, stent dislodgement, etc., etc. So not even just doing these cases, I had complications of everything. I had perforations, I had a burr which got stuck in the artery which is not coming out. I had stent dislodgement, stent flew away, it went in the iliac arteries. So sometimes the stent doesn't go, and if you're trying to pull the stent back, the stent dislodges from the balloon and it goes somewhere in the body, and prey does not go in the brain. So this is very, very important, and these cases should be handled very well. I always like to quote what Dr. Matthew has taught me is, if you want to avoid complications, please do not do complex interventions. Simple as that. So that's what Dr. Matthew has taught us, and if you want to play with fire, you should be ready to play with fire. I thank you everyone for a patient hearing.
Thank you, Dr. Anand Rao, for such a wonderful lecture.
Short.
Felicitation of Sir.
Sit.
Shawl by AMA President, Dr. Ashok Singh. We have bouquet
Thank you.
by MCVP President, Dr. Shashank Shah.
Thank you.
Silver lamp by Dr. Ram Chavan.
Wow, this is beautiful.
Ganpati idol by Dr. Ratnaparki sir. And memento by Dr. Ratnaparki sir to Dr. Anand Rao. Thank you, sir. Thank you so much.
Thank you. Thank you. I'll give this mic.
Hi. Again, now it's time of inauguration. And as usual, we have some celebrity. Okay? And please welcome the celebrity. Please do not leave the hall now. Okay? It is a grand function now for another 45 minutes. Dr. Smita Patil.
Shake.
Welcome on our chief guest, Arun Govil ji.
अजर बिहारी राम सिया राम सिया राम जय जय
To see you all in a large number on a rainy Sunday. And it's my honor to conduct the inauguration ceremony of most prestigious academic program of the year, the CardioCon. It's our 7th year, and I'm thankful to Dr. G.P. Ratnaparki for giving me this golden opportunity. I request our chief guest, Mr. Arun Govil ji, the veteran actor and MP, to come up on stage. Please give him a large round of applause.
मंगल भवन अमंगल हारी प्रभु बिहारी
Physician par excellence, Head of Department Medicine, PCMC, PGI, YCM, Pimpri, Pune. Mr. Dilip Jadhav. Now I request AMA President Ashok Singh, MCVP President Dr. Shashank Sir, MCVP Secretary Dr. Rajesh Tiwari, MCVP Treasurer Dr. Sharad Dadit Sir, AMA Treasurer Dr. Seema Tiwari, Guru Krupa Trustee Smruti Ma'am, and Chairman Guru Krupa Dr. Ratna Parkhi Sir to be on stage. Myself, Secretary AMA is already on the stage. And Trustee Guru Krupa and Managing Trustee of AMA, Dr. Ram Chavan, please come up on stage. Dr. Rajesh Ghatkar, Dr. Pranjal Ratnaparkhi, Dr. Rahul Ratnaparkhi, Dr. Anil Kumar, Dr. Tejaswini, Dr. Sanjay Ratnaparkhi. I request you all to be on stage, please. It's time for Deep Prajwalan. I request all dignitaries to gather around for Deep Prajwalan, and I request Dr. Deepali Kate for come up for Ganesh Vandana. Deepali.
Thank you, Dr. Smita. May I request all of you to please stand up for Ganesh Vandana. स्वस्ति श्री गणनायको गजमुखो मोरेश्वर सिद्धिदहं बलास्तु विनायक स्तवतमहे चिंतामणि स्थेवरे लीलाद्रौ गिरिजात्मज सुवरदु विघ्नेश्वरश्चोसरे ग्रामीराञ्जन संस्थितो गणपति कुर्यात् सदा मङ्गलम् मङ्गलम्. Thank you. Please take your seats.
It's time for Deep Prajwalan.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
थैंक यू एवरीवन। आज के हमारे चीफ गेस्ट हैं द फेमस एक्टर एंड एमपी अरुण गोविल जी। ये दास्तां है एक ऐसे अभिनेता की जिनको देखकर श्रद्धा का भाव मन में प्रकट हो जाता है। आज भी जब इनकी तस्वीर देखो तो मन भक्ति भाव से प्रेरित हो जाता है। यह है भगवान श्री राम, एक्टर अरुण गोविल जी। अरुण जी का जन्म हुआ 12 जनवरी 1958 में मेरठ में। पिता चंद्र प्रकाश और माता शारदा देवी के घर में ये बेटा मेरठ में ही साइंस ग्रेजुएट हुआ। और ये मुंबई आ गए एक्चुअली भाई के बिजनेस में हेल्प करने, परंतु कॉलेज दिनों में इन्होंने बहुत सारा थिएटर किया था तो इनका मन एक्टिंग में ही था। 1977 में राजर्षि फिल्म्स के पहली सिनेमा से इन्होंने डेब्यू किया, जिसके बाद 48 फिल्में की, हिंदी, गुजराती, उड़िया, तेलुगु, भोजपुरी, परंतु पूरे भारत देश में वो जाने जाते हैं सिर्फ प्रभु राम जी के रूप में। रामानंद सागर जी ने जब रामायण सीरियल के ऑडिशन के बाद इनको लक्ष्मण या भरत का रोल ऑफर किया था, तब अरुण जी को इतना विश्वास था कि उन्होंने रामानंद सागर जी से बोला कि मैं किरदार निभाऊंगा तो सिर्फ श्री राम का। और वो विश्वास कितना सार था वो आज हम देख रहे हैं। रामायण जैसे ही 1985 में विक्रम वेताल सीरियल का राजा विक्रम का रोल भी बहुत फेमस हुआ। अरुण जी ने अनेक माइथोलॉजिकल सीरियल्स की। इंडस्ट्री में बहुत कलाकार आते हैं, बहुत सारे रोल्स निभाते हैं और गुमनामी के अंधेरे में खो जाते हैं, परंतु ये ऐसे कलाकार हैं जो एक ही रोल से पूरे भारतवर्ष में नहीं पूरे विश्व में अजरामर हो गए। इनकी मधुर वाणी और श्री राम जी का स्माइल आज तक कोई भुला नहीं पाया। आप आंखें बंद कीजिए और मन में श्री राम बोलिए, देखो किसका चेहरा सामने आता है। 1987 में जब रामायण प्रसारित होता था, लोग घरों में टीवी की पूजा करते थे। सभी धर्म के लोग ये सीरियल बड़े भक्तिभाव से देखा करते थे। रास्ते सुनसान हो जाते थे, मानो कर्फ्यू लग गया हो। दुकानों में ग्राहक तक नहीं होते थे और पुलिस ये बताती है कि वो 1 घंटा क्राइम रेट 0 हो जाता था। आज तक की हाई टीआरपी वाली सबसे लोकप्रिय सीरियल है रामायण। और इतना ही नहीं, जब लॉकडाउन में यह सीरियल पुनः प्रसारित हुई तो फिर से टीआरपी के सब रिकॉर्ड्स टूट गए। एक बार जब अरुण जी परिवार समेत मॉरिशस घूमने गए थे, तब मॉरिशस के कड़क ट्रैफिक रूल्स टूट गए। रोड पे ट्रैफिक जाम हुआ और लोग गाड़ियों से उतरे सिर्फ इन्हें साष्टांग दंडवत करने। यह है प्रभु राम की महिमा और जनता का इनके प्रति प्यार। आज हम धन्य हो गए कि साक्षात श्री राम हमारे साथ है। तालियों के साथ स्वागत करते हैं प्रभु राम का, अर्थात अरुण गोविल जी का, आज के हमारे चीफ गेस्ट, एक्टर एंड एमपी। आई रिक्वेस्ट डॉक्टर जीपी रत्नपारखी सर, स्मृति मैम, एमए प्रेसिडेंट, एमसीवीपी प्रेसिडेंट एंड राम to felicitate Arun ji.
मेरे प्रभु श्री राम का लाल निशान
फेलिसिटेशन तो हो गया है, बट एक इम्पोर्टेंट गिफ्ट देना बाकी है, और वो है श्री राम जी को श्री राम। राम के हाथों श्री राम जी को राम सप्रेम भेंट दिया जाएगा। Today we with us another physician par excellence, Dr. Praveen Soni sir, a professor and HOD Department of Medicine, PGI, PGMC, YCM Hospital, Pimpri, Pune. Sir is born on 12 July 1969 and he did his MBBS and MD from Government Medical College, Aurangabad. Kekuchi lymphadenitis, rare case of acute hypersensitivity, analysis of acetic fluid are some of his research papers published in international journals. He is MUSH approved PG teacher. Also elected as BOS member of MUHS. He is elected as General Secretary of Physician Association Aurangabad, Joint Secretary of Indian Medical Association Aurangabad, and elected as Joint Secretary of MAPICON Conference 2016 at Aurangabad. We are grateful to Dr. Praveen Soni sir for giving us his valuable time. Please welcome Dr. Praveen Soni, our guest of honor, a physician par excellence. I request GPR sir, Smruti ma'am, Ashok Singh, Dr. Shashank sir and Dr. Ram Chavan to felicitate sir.
जय जय श्री राम बोलेगा।
आता आपल्या अकॅडमिक पर्सनॅलिटीसाठी रिक्वेस्ट करते GPR सरांना, प्रवीण सोनी सरांना धन्वंतरी मूर्ती प्रेझेंट करावी.
फिजिशियन क्या जो रहता है ना धन्वंतरी, वो देने वाले हैं.
आज आपल्या बरोबर आहेत नाट्य निर्माते श्री दिलीप जाधव. गेली 45 वर्ष मराठी चित्रपट आणि नाट्यसृष्टीमध्ये भरघोस यश देणारं व्यक्तिमत्व. दिलीप दादा मूळचे बँकर, युनियन बँकेमध्ये काम करत असताना नाटक वेळ काही त्यांना गप्प बसू देईना आणि मग त्यांनी नाट्यनिर्मिती क्षेत्रात स्वतःला झोकून दिलं. अष्टविनायक नाट्यनिर्मिती संस्थेच्या माध्यमातून जाऊबाई जोरात, गंगूबाई मॅट्रिक, वाडा चिरेबंदी, मर्डरवाले कुलकर्णी, हॅमलेट, व्हॅक्यूम क्लीनर, नांदी अशा अनेक अजरामर कलाकृतींची निर्मिती केली. निशाणी डावा अंगठा आणि ही पोरगी कोणाची अशा मराठी सिनेमांची देखील निर्मिती केली. आर्टिफिशियल इंटेलिजन्सच्या माध्यमातून रंगभूमीच्या इतिहासात पहिल्यांदाच प्रदर्शित झालेले आजीबाई जोरात हे नाटक महाराष्ट्रात अक्षरशः धुमाकूळ घालत आहे. स्मार्टफोनपासून आईवडिलांना परावृत्त करणे आणि मुलांना भाषेचा आणि वाचनाचा लळा लावणे अशा महत्त्वाच्या मुद्द्यावर हे नाटक पालकांना विचार करायला प्रवृत्त करते. बिग बजेट नाटकांची निर्मिती करत सदैव ग्लॅमर इंडस्ट्रीमध्ये यशाच्या शिखरावर असून देखील विनम्र राहणं हे त्यांचं वैशिष्ट्य. गेली 45 वर्ष त्यांनी केलेल्या कलेच्या विश्वातल्या योगदानास आमचा मानाचा मुजरा. स्वागत करूया श्री दिलीप जाधव यांचे. मी रिक्वेस्ट करते डॉक्टर जी.पी. रत्नपारखी सर, स्मृती मॅम, डॉक्टर अशोक सिंग, डॉक्टर शशांक सर आणि डॉक्टर राम चव्हाण यांना श्री दिलीप जाधव यांचा सत्कार करावा. प्रभू श्री राम झाले, धन्वंतरी झाले. आता नाट्य सृष्टीतील time to felicitate some of the dignitaries. I request Arun Govilji to do the honor. Please welcome with Dr. Sonia and Shri Dilip Jadhav ji, Shri Vijay Chavan, Divisional Superintendent, Charity Commissioner, Amravati. Please welcome Charity Commissioner, Divisional Superintendent, Amravati.
Chillin' with me, feeling like ecstasy.
Dashing and dynamic Deputy Commissioner of Police, Sambhajinagar. Young IPS officer.
Sir, Nandedkar sir is an anti-Scott IPS officer from Sambhajinagar. He is a dashing officer. Now he will become in Mumbai protection.
Padma Shri awardee and Magsaysay awardee Nilima Mishra madam.
Fly with me to another city, chilling with me, feeling like ecstasy.
You might be aware that Magsaysay Award is just like a Nobel Prize of Asia. Okay, she is Padma Shri also and Magsaysay Award. And see this सादगी है ना, किती साधेपणा बघा. ठीक आहे, तर मॅडम नगरच्या रूरल एरियामध्ये एकदम लो सोशल इकॉनॉमिक जे लोक असतात त्यांच्यासाठी काम करतात आहे. सिन्स लास्ट 20 years. फार मोठी व्यक्तिमत्व आहे. थँक्यू मॅडम.
Another person, Padma Shri, Dr. S.P. Verma, Gandhi Global Family President, Jammu Kashmir. Dr. Sandeep Rathod, Executive Officer, Shri Siddhivinayak Mandir, Prabhadevi, Mumbai. Sir is from medical fraternity, but now he is on the panel of Siddhivinayak Mandir, and he is handling everything very minutely and helping all doctors getting darshan of Siddhivinayak Mandir. हल्ली प्रत्येक मंदिरामध्ये एक शासकीय अधिकारी असतो, आता आपल्याला माहित झाला आहे. सर इज अ शासकीय अधिकारी इन सिद्धिविनायक मंदिर प्रभादेवी. डॉक्टर श्री देवेंद्र शेरेकर, फाउंडर चेअरमन, नॅशनल काउन्सिल ऑफ इन्स्पिरेशन अँड डेव्हलपमेंट, NCID. शेरेकर सरांची आपली पूर्वी ओळख झालेली आहे डॉक्टर्स डे कॉन्फरन्स दिवशी. डॉक्टर अजय महाजन, HOD कार्डियोलॉजी डिपार्टमेंट, KEM हॉस्पिटल, मुंबई. डॉक्टर प्रताप नाथानी, HOD कार्डियोलॉजी डिपार्टमेंट, LTMC सायन हॉस्पिटल, मुंबई. डॉक्टर सुयोग दोशी, फिजिशियन अँड डायबिटोलॉजिस्ट. डॉक्टर सुभाष पवार, फिजिशियन अँड डायबिटोलॉजिस्ट. डॉक्टर राहुल जैसवानी, सर्जन, सांताक्रूज मेडिकल असोसिएशन, प्रेसिडेंट, सांताक्रूज मेडिकल असोसिएशन. Dr. Rajiv Kovil, diabetologist. The famous name in Mumbai, a physician par excellence. Sir, please. All my patients are coming to you. Dr. Anand Pednekar, Director Jagannath Gangaram Pednekar Jewelers, a PhD in Gemology and Study of Diamond. Dr. Rajesh Povle, Deputy Editor, Samna Newspaper. Dr. Dheeraj Kumar Khodke, President, MAMPA. Dr. Akhlaq Ahmad Usmani, Secretary, MAMPA. Please be seated. Thank you so much. Dr. Akhlaq Ahmad Usmani. Sir. आज आपल्या बरोबर आहे डॉक्टर विकास वाडावकर, चांद्रसेनीय कायस्थ प्रभू समाजातील निष्ठावंत कार्यकर्ते आणि समाजसेवक. यांनी वैद्यकीय शिबिरातर्फे जनतेसाठी केलेले कार्य कौतुकास्पद आहे. 1994 पासून त्यांनी वेगवेगळी 75 मोफत वैद्यकीय शिबिरे घेतली आहेत. आज सरांनी लिहिलेल्या कृतार्थ या पुस्तकाचे प्रकाशन अरुण गोविलजींनी करावे अशी मी विनंती करते. डॉक्टर विकास वाडावकर, यानंतर लकी ड्रॉ आहे. प्लीज बी सीटेड. बंपर लकी ड्रॉ. GPR सरांच्या कामाची नोंद घेऊन भारत सरकारच्या पोस्टल स्टॅम्पचं सेकंड एडिशन सरांच्या फोटो सहित झालेलं आहे. त्या सेकंड एडिशनचं पब्लिकेशन अरुण गोविलजींनी करावी अशी मी विनंती करते. भारतीय पोस्ट सरांच्या फोटोसहित स्टॅम्प पब्लिश झाला आहे. Please give him a big round of applause everyone. GPR सरांचा ऑनर हा आपला सर्वांचा ऑनर आहे. लास्ट Since 10 years, Literate India, Strong India, under this mission, Guru Krupa have adopted more than 10 schools in tribal area where students are provided all necessary things for education and helping for betterment of their life. After a decade, now Mission Fit India, defeat diabetes and hypertension. Diabetes and hypertension हटाओ, भारत और भारतीय नागरिक बचाओ. ये मिशन स्टार्ट होने जा रहा है वेयर गुरु कृपा विल स्कैन मोर देन 1500 पुअर पेशेंट्स इन अ ईयर एवरी सैटरडे. I request GPR sir to elaborate something about this mission.
So dear friends, you are aware that with your blessings, our Guru Kripa Heart Foundations finished almost 11 years. And last 10 years, you might have seen all the photos. You have seen that we are giving books, notebooks, guides, sleepers, daftars, all these things, and sanitary napkin to the female patients, female students also. We have adopted more than 2,000 students per year. So, under the mission of, कुछ missions के साथ काम करेंगे ना, under the mission of literate India and strong India. These all poor people, poor students are from Talasari, from Murbad, from Jawar. Okay, Ashram Shala, it is called Ashram Shala, where these people are really poor. Their parents cannot afford, so they just dump the student there. Such 2,000 students we are adopted them and giving whatever they required. Last year, 1200 बच्चों को हमने blanket और सतरंजी दिए because they were just sitting on the ground only. So 10 years after that, and we are going to continue that with your blessings. So after completion of 10 years of that mission, ये student का इसलिए क्या कि my parents were teachers. तो उस वजह से स्कूल और बच्चों का मेरा करने की इच्छा हुआ. पर भी ये डॉक्टर हार्ट के लिए अपन क्या कर रहे हैं डॉक्टर के ना. तो from today onwards, today is a World Heart Day. We are inaugurating Mission Fit India because you are aware that India is the capital of diabetes. India is the capital of hypertension, and because of that, India is the capital of ischemic heart disease. Because people don't screen themselves. उनको सब समझता है जब डायबिटीज हुआ है, कब कॉम्प्लिकेशन होता है तब समझता है. बीपी है, मेरे को बीपी नहीं था. ओके, जब फीवर के लिए जाते हैं डॉक्टर के पास, हाँ मेरे को बीपी नहीं है वगैरह बोलने के बाद भी, so they don't screen, they don't accept also. So screening is a simple way to prevent the heart disease. And we are a poor country, so we cannot afford complications. So from today onwards, we are going to do Mission Fit India and defeat diabetes, hypertension. Management of diabetes and hypertension is not very great. There are 4 or 5 medicines, ज़्यादा कुछ नहीं है. But detection, early prevention is very important. So every Saturday in my clinic there will be 30 patients free of cost. We will be doing HbA1c, ECG, consultation, BP, whatever screening is required, free of cost of 30 patients. With this rate, साल में 1,500, ज़्यादा ना, 1,500 लोगों को भी स्क्रीन कर सकते हैं हम. नंबर बढ़ सकता है क्योंकि वी हैव लिमिटेशंस. साल में 1,500 से 2,000 लोगों को कितना होता है, कैलकुलेशन करो, 30 इंटू 1 बराबर है ना, 1,500 से 2,000 साल में हम स्क्रीन करेंगे. और वी कैन प्रिवेंट सम कॉम्प्लिकेशन, वी कैन प्रिवेंट सम हार्ट डिसीज ऑल्सो. सो दिस इज मिशन फिट इंडिया. वी हैव लिमिटेशन. देखो बॉस, मैंने बहुत कुछ ग्रेट नहीं कर रहा हूँ मैं कि उनको फ्री एंजियोग्राफी, फ्री एंजियोप्लास्टी नहीं कर रहा हूँ. बट स्क्रीनिंग, प्रॉपर एडवाइस, प्रॉपर डाइट, प्रॉपर योगा, ये हम उनको दे सकते हैं. सो दिस फिट इंडिया मिशन अँड डिफीट डायबिटीज अँड हायपरटेन्शन, किंवा मराठीत म्हणतात ना, मराठीत काय, डायबिटीज हायपरटेन्शन हटाव, भारत आणि भारतीय बचाव, असं मिशन आपण सुरू करतो आजपासून. आणि त्याचं इनॉग्रेशन बाय रिमोट आपले चीफ गेस्ट श्री रामजी तोंडात येतं, अरुण गोविलजी.
अरुण गोविलजी.
सर प्लीज. Wow. So you can send your patient on Saturday. Number will be there, free of cost, no problem. Okay. So this is a फूल ना फुलाची पाकळी म्हणून आपण काही समाजासाठी करतोय. Thank you very much.
Now it's time to celebrate World Heart Day by cake cutting. I request Arun ji, GPR sir, Praveen Soni sir, and Dilip Jadhav ji to join for cake cutting and celebration of World Heart Day. बलून्स आप लोगों के हाथ में जो बलून्स है वो ऊपर उड़ाने हैं, रखने नहीं है अपने गोद में।
लाहौर दा शरारत बरेली आना रोज रोज नी कर ले तू कॉलेजों ने बहुतियां क्लोज नी कर ले तू
I request everyone to be please seated. I request Dr. Praveen Soni sir to say a few words.
Namaskar. Good morning. Respected dignitaries on the dais and off the dais. On the occasion of World Heart Day, we gathered here for CardioCon 2024 conference, a state level conference. I welcome you all in this conference. Imagine a drum, steady, rhythmic, tirelessly beating day and night. Now imagine that drum is within each of us, a powerful instrument that fuels our lives, the human heart. Today on the World Heart Day, we gather to celebrate this remarkable organ, not just as a symbol of love, but as the engine of life itself. Let's take a moment to appreciate the heartbeat that keeps us alive, explore how we can protect and nurture it for a healthier future. On the behalf of my postgraduate institute, Pune, I would like to take a moment to express my deepest gratitude to the Guru Kripa Foundation. The mission just now, sir told, Dr. Ratnaparki sir, Smriti ma'am, and their teammate. They are really this Guru Kripa Foundation whose unwavering the dedication and service to the heart health have touched the lives of countless individuals. Though their compassionate care and commitment to the cardiology, and they have not only treated but also saved the lives of lakhs of heart patients, and they are helping in not only in rural areas, tribal areas, and making the patients free and all. Their work stands as a beacon of hope for those in need, and their contribution to the field of cardiovascular health are truly invaluable. Thank you, Guru Kripa Foundation, for your tireless efforts and for making a profound difference in the lives of so many. Thank you so much.
Thank you, sir. Now I request Chief Guest, Mr. Arun Govilji, to say a few words. We are waiting eagerly for you, sir.
जय श्री राम। यहाँ मंच पर आसीन मेरे सभी आदरणीय देवियों सज्जनों, आप सबको मेरा नमस्कार, मेरा प्रणाम, मेरा नमन। आज वर्ल्ड हार्ट डे है। दिल का मामला है, कोई दिल लगी नहीं। बहुत सारे लोग कहते हैं कि मैं दिल से नहीं दिमाग से काम लेता हूं, ऐसा कहते हैं वो। पर दिमाग से काम लेना भी दिल का ही फैसला होता है। तो हम दिल से बच नहीं सकते। हर बात में, हर कंडीशन में, हर परिस्थिति में हमारा दिल काम करता है और कभी कभी काम करते करते थक जाता है बेचारा। इसीलिए कहते हैं कि दिल की बीमारी सबसे ज्यादा होती है। अब आप इतना काम किसी मशीन से करवाएंगे तो क्या होगा फाइनली? दिल के फैसले हमारे जीवन में हमें कभी कभी बहुत सुख भी देते हैं और कभी कभी उल्टे फैसले भी हो जाते हैं दिल को लेकर। लेकिन फिर भी ये बात सही है कि दिल के बगैर जिंदगी फिजिकली तो छोड़ दीजिए, इमोशनली भी संभव नहीं है। इट्स नॉट पॉसिबल टू लिव विदाउट योर हार्ट वर्किंग। तो आप सबको इस दिल के लिए बहुत बहुत शुभकामनाएं। आप इसी तरह दिल से काम लेते रहें, इसी तरह से आपका दिल आपको नसीहतें देता रहे अच्छी। मैंने भी डॉक्टर रत्ना पारखी से पूछा कि मुझे आज क्या बोलना चाहिए यहां। अब डॉक्टरों से जो मेरा ताल्लुक है वो केवल एक मरीज का है या मेरे कुछ मित्र हैं। पर एक बात मैं आपसे यहां जरूर कहना चाहूंगा आज। ये बात मैं इस बार जो विंटर सेशन होगा पार्लियामेंट का, I have decided to raise an issue on that. It's the relationship between doctors and the patients. ये कभी कभी बहुत दुख देती है, मुझे दुख देती है कभी कभी। मुझे पर्सनली नहीं, वो थॉट। मुझे याद है, एक तो मेरी जो बर्थ डेट थी वो मैम ने थोड़ी मुझे जवान बना दिया है और थोड़ा सा वो बर्थ डेट बताकर। माय बर्थ ईयर इज 1952। आई हैव डन 72। तो वो जो कभी कभी जो हम वाकई सुनते हैं डॉक्टर्स के और पेशेंट्स के, वो कभी कभी बहुत दुख देते हैं और उसमें ये फैसला करना मुश्किल हो जाता है कि गलती कहां से हुई है। बिकॉज हर व्यक्ति का वर्जन, हर पार्टी का वर्जन अलग होता है। तो उसकी डिटेल में न जाते हुए डॉक्टर्स को शुरू से, अब मुझे नहीं पता बहुत ज़्यादा, पर जब हम छोटे होते थे या जब हम जवान हुए, डॉक्टरों को भगवान माना जाता था। एंड एट टाइम्स इट इज प्रूवन स्टिल टिल डेट दैट दे वर्क लाइक गॉड फॉर ए पेशेंट। लेकिन कभी कभी ये जो परिभाषा है इसमें फर्क आ जाता है। मैं सब लोगों से कहता हूं कि जीवन में अगर हम थोड़ा सा संयम बरतें, थोड़ा सा सोच कर चलें, थोड़ा सा पॉजिटिव होकर चलें, सकारात्मक होकर चलें, तो हमारी बहुत सारी समस्याएं अपने आप खत्म हो जाती हैं, कम होती चली जाती हैं। आप आज यहां सब डॉक्टर्स हैं, इसलिए मैं आपसे रिक्वेस्ट कर सकता हूं, दैट्स ऑल। आई मीन वन कैन do nothing more than that. Professional होना बहुत अच्छी बात है, बट एक हद तक। कभी कभी क्या होता है, हम जब बच्चे छोटे होते हैं, बच्चों के बीमार होने का कोई समय नहीं होता। छोटा बच्चा रात को भी उठकर रोने लगता है और आप एक पीडियाट्रिशियन को ढूंढते हैं उस समय, कभी कभी नहीं मिलता। कभी और इमरजेंसी हो जाती है। मैं मानता हूं कि डॉक्टर्स को अपने लिए समय चाहिए, एग्रीड। उनको भी अपनी जिंदगी जीनी है जैसे बाकी सबको जिंदगी जीनी है। उनको अपने परिवार के लिए समय चाहिए, उनको और दूसरे कामों के लिए समय चाहिए। पर कभी कभी जब इमरजेंसीज होती हैं, मेरी आपसे रिक्वेस्ट है, डोंट अवॉइड इट। अगर आपको लगता है कि ये केस जेन्युइन है, वाकई इमरजेंसी है, कोशिश कीजिए कि आप उसको अटेंड कर सकें। बिकॉज जो व्यक्ति आपके पास आया है वो उस समय आपको भगवान मान रहा होता है। बिल्कुल। आज हम मंदिर भी रोजाना नहीं जाते। हम मंदिरों में जाते भी हैं तो रोजाना प्रार्थना नहीं करते, रोजाना नहीं मांगते। हम तब मांगते हैं जब हम परेशानी में होते हैं, और शायद भगवान के पास हम जाते भी तब हैं जब हम परेशान होते हैं। जब सब कुछ अच्छा चल रहा होता तब हमें भगवान याद नहीं आता। इसी तरह जब कोई बीमार होता है, कोई इमरजेंसी होती है फिजिकल, तभी डॉक्टर याद आता है, अदरवाइज डॉक्टर याद नहीं आता। तो ये एक रिक्वेस्ट है आपसे कि अगर कभी जीवन में ऐसा हो कि आपको लगे कि नहीं ये जेन्युइन है, इमरजेंसी है, तो उस समय उसकी अगर आप मदद कर पाएंगे तो उस इंसान की जो दुआएं आपको लगेंगी, और मैं ये मानता हूं कि दुआओं में बहुत दम होता है, बहुत दम होता है। एक अनजान व्यक्ति आपको दुआ देकर चला जाए तो ये समझिए कि आपकी जिंदगी में क्या क्या आपको मिल गया होगा। ये मैं एक संवेदनशील इंसान होने के नाते आपसे कह रहा हूं, इसका कोई और कारण नहीं है। क्योंकि हो सकता है आप में से कुछ लोगों को ये लग रहा हो कि ये एक एक्टर और एक पॉलिटिशियन यहां आकर हमें कुछ सिखाने की कोशिश कर रहा है। ना, मैं नहीं सिखा नहीं रहा हूं किसी को। मैं एक रिक्वेस्ट आपसे कर रहा हूं, एक हम्बल रिक्वेस्ट कर रहा हूं, एक कंपैशन है, ये एक कंपैशनेट रिक्वेस्ट है मेरी, बस, दैट्स ऑल। मुझे याद है सबसे ख़राब सीन वो होता है हॉस्पिटल में, जब ऑपरेशन थिएटर में हमारा अपना कोई चला जाता है, बाहर लाल बत्ती जलती रहती है और हम इंतज़ार करते रहते हैं, और जब डॉक्टर निकल कर आता है तो हम उसकी तरफ ऐसे भागते हैं जैसे उस फीलिंग को बयान नहीं किया जा सकता। और जब डॉक्टर कहता है कि यस एवरीथिंग इज ओके, लिटरली ये फीलिंग होती है उस वक्त। तो आप सोचिए ये जो रिलेशनशिप है ये कितनी ह्यूमन है, कितनी ह्यूमन है, कितनी संवेदनशील रिलेशनशिप है ये। हमें दांत में दर्द होता है, चलो ठीक है, 6 घंटे बाद भी आदमी मिलेगा, अगले दिन भी मिलेगा तो चलेगा, हम एस्प्रिन खा लेंगे या कुछ भी खा लेंगे। मैं उन बीमारियों की बातें नहीं कर रहा था आपसे। तो मैं सिर्फ इतना ही कह रहा था, इसको आप अन्यथा ना लें बिल्कुल भी। मेरे मन में एक बात आई थी आप सबको देखकर, आप सबको मिलकर, जो मैंने आपके सामने रख दी है। अब मैं यहाँ से दूसरी तरफ चलता हूँ। मुझे देखकर आप सब जय श्री राम कहते हैं, उसके लिए मैं अगर आपका शुक्रिया अदा करूं तो वो बहुत छोटी सी बात होगी। वो जो मुझे मिला है, जो आप लोगों ने दिया है, उसको बयान नहीं किया जा सकता, उसको उसकी परिभाषा नहीं दी जा सकती। आज रामायण वॉज रिलीज इन 1987। टिल डेट व्हाट आई बीन गेटिंग, मुझे लगता है शायद वो बिरले लोगों को मिलता होगा जो श्री राम ने मुझे दिया है, लेकिन वो दिया है सब आपके थ्रू दिया है, आपके द्वारा दिया है। मैंने एज शी सेड इट, द एंकर सेड इट, कि मैं रामानंद सागर साहब के साथ काम कर रहा था पहले, रामायण से पहले भी, और उन्होंने मेरा रामायण के लिए ऑडिशन लेकर मुझे आउटराइट रिजेक्ट किया था। मेरे मन में आया था कि मुझे राम का, भगवान श्री राम का चरित्र करना है। हालांकि मेरी फैमिली ने, मेरे फ्रेंड्स ने, सब ने कहा कि नहीं, माइथोलॉजी इज नॉट अ स्टैंडर्ड मटेरियल नाउ। बहुत नीचे के दर्जे की जो फिल्में होती हैं वो माइथोलॉजिकल होती हैं, तुम क्यों अपना करियर खराब कर रहे हो? बट आई डोंट नो व्हाई, मेरे मन में आया था कि मुझे श्री राम का चरित्र करना चाहिए। तो पहले मुझे उन्होंने रिजेक्ट किया, लेकिन उसके बाद दे केम बैक, उन्होंने फिर मुझे बुलाया कि नहीं, वी हैव डिसाइडेड दैट यू विल बी द बेस्ट। ये जो भी कुछ हुआ है ना मेरे जीवन में, ये सारा डेस्टिन्ड है। क्यों उसने किया है मुझे नहीं पता। As far as the politics is concerned, recently I joined. मुझे रामायण के समय से मेरे पास ऑफर्स आते रहे। पहले कांग्रेस से ऑफर आते थे, उस समय कांग्रेस ही कांग्रेस होती थी बस। 2014 से बीजेपी से ऑफर्स आए मेरे पास। I could never think of going to politics at all. I'm too straight of a man. मैं सीधी सीधी बात करता हूँ, सीधे सीधे रास्ते पे चलता हूँ, और पॉलिटिक्स में दिस इज नॉट अ प्लस पॉइंट एट ऑल। पर इस बार अभी जब रामलला की प्राण प्रतिष्ठा हो रही थी जिस दिन, उस दिन वहाँ मंदिर में बैठे बैठे मुझे, मेरे मन में ख्याल आया कि हमने आध्यात्मिक सेवा, मॉरल्स की सेवा तो रामायण के थ्रू काफ़ी हो गई है, लेकिन जन सेवा मैंने कभी की नहीं, 1 to 1 जिसे हम कहते हैं। ये एक थॉट आया और आकर उसी वक्त निकल गया। डिडंट डिस्कस इट विद एनीबॉडी। 2 महीने बाद फिर जब इलेक्शंस की बात शुरू हुई तो मेरा नाम, मुझे somebody told me कि तुम्हारा नाम टेलीविजन में आ रहा है। तो मैंने भी देखा, I didn't bother. Finally one day somebody from the top called up, asked me, and I don't know why I did not take a single second and said yes, I'll do it. I did it. पर मुझे अंदाजा नहीं था कि इतना मुश्किल काम होता है वो। मतलब इलेक्शन में खड़े हो जाना तो ठीक है, उसी इलेक्शन को, और फिर इस बार का इलेक्शन जो हुआ वो, उसमें धीरे धीरे जो सर्कमस्टांसिस थे, जो एयर फ्लो था, वो भी धीरे धीरे चेंज होता चला गया, परिस्थितियां चेंज होती चली गई, एंड इट टर्न आउट टू बी अ टफ फाइट। बट एनीवे, तो मैं राजनीति भी, मैंने भी डॉक्टर रत्न पारखी को मैं बता रहा था कि मैं राजनीति में होकर भी वहां राजनीति नहीं कर रहा हूं, बिल्कुल नहीं कर रहा हूं। मैं सिर्फ वहां हूं समाज कारण के लिए। मैंने लोकल लेवल पे भी सबको, जो हमारे दूसरे विधायक होते हैं या पूर्व सांसद थे, उन सबको मैंने बताया, देखिए मैं यहाँ कोई राजनीति नहीं करूँगा, मुझे राजनीति आती नहीं है। पहली बात तो, जो चीज़ आती नहीं वो मुझे क्यों करनी चाहिए, और मैं कोशिश भी नहीं करूँगा उसको सीखने की। मैं यहाँ सिर्फ समाज कारण के लिए आया हूँ, वो चाहे आपका काम हो, आपका काम हो, आपका काम हो या आपका काम, मुझे कोई फर्क नहीं पड़ता वो किस धर्म का व्यक्ति है, वो किस जाति का व्यक्ति है, वो किस पार्टी का व्यक्ति है, मुझे नहीं फर्क पड़ता उस बात से। कोई भी अपनी समस्या लेकर मेरे पास आएगा, I'll try my level best to sort it out. और यही मैंने सेंटर में भी जब हमारे बड़े नेताओं से बात हुई तो मैंने उन्हें कहा कि ये मेरा काम है नहीं, मैं आ गया हूँ यहाँ पर, बट मैं जो कुछ कर सकता हूँ, एंड सिंस दे आस्क्ड मी टू contest the election from Meerut, which is my hometown. I was born and brought up there. I spent almost around 22 years of my life there. I know the place, one of the most criminal places in the country. Temperament भी लोगों का वैसा ही है. Imagine my temperament and वहाँ का temperament. Poles apart. Poles apart. नहीं, मैं उन्हें रावण नहीं कहूँगा. मैम कह रही हैं कि राम और रावण का टेम्परामेंट ऐसे नहीं, कोई भी रावण नहीं होता. हर इंसान में अच्छाई ज़रूर होती है. हमें देखनी होती है सिर्फ. हम चाहें तो इंसान की सारी निगेटिवनेस भी देख सकते हैं और चाहे हम ये भी देख सकते हैं कि इसमें अच्छाई क्या है. तो हम उस इंसान को उस अच्छाई की वजह से क्यों ना जाने, क्यों ना पहचाने. हम ये क्यों कहें कि इंसान खराब है. नहीं, हमें कहते हैं इंसान बहुत अच्छा है, इसमें ये अच्छाई है, और वही उसका परिचय होना चाहिए. मेरे लिए उसका परिचय वही होता है. तो मैं राजनीति में होकर भी राजनीति का व्यक्ति नहीं हूं. समाज कारण है, समाज कल्याण है. जो भी मैं कर सकता हूं वो मैं करता रहूंगा. पहली बार मुझे डॉक्टर्स की कॉन्फ्रेंस में आने का मौका मिला है. डॉक्टर साहब, मैं बहुत दिन से ना एक फिजिशियन की, मुझे अच्छे फिजिशियन की तलाश है. वो मेरी तलाश ख़त्म करा दीजिएगा प्लीज़ आप. नहीं, इसके दो माने नहीं है, सीधी सीधी बात कह रहा हूँ मैं. इसमें कुछ और छुपा हुआ नहीं है. हमारे डॉक्टर साहब, हमारे फिजिशियन डॉक्टर सुभाष पवार, जिनको मैंने भी सम्मानित किया यहाँ, बहुत सालों से हमारे फिजिशियन हैं. पर डॉक्टर साहब ना ज़्यादातर टाइम अपना फार्म पे गुजार देते हैं. जब ज़रूरत होती है तब मिलते नहीं हैं हमें. नहीं, उनको अपनी ज़िंदगी अपने हिसाब से जी रहे हैं सर. वो ही कैन अफोर्ड टू डू दैट, व्हाई नॉट. तो एक अच्छा फिजिशियन मुझे प्लीज़ बताइएगा जो हमारे घर के आसपास हो, छोटे छोटे कामों के लिए. बड़े कामों के लिए नहीं है. बड़े काम तो अभी तक शुरू नहीं हुए, तो छोटे कामों के लिए अगर आप बता दें तो. मुझे ऐसे याद आ गया तो मैंने कहा मैं आपसे रिक्वेस्ट कर लेता हूँ. तो मुझे पहली बार आप सबसे इस तरह से मिलने का मौका मिला. आई एम श्योर मैंने कुछ बातें अपने दिल की आपके सामने रखी हैं. और जहाँ तक समाज कल्याण का प्रश्न है, समाज सेवा का प्रश्न है, मेरे लिए कभी भी कुछ भी हो जो मैं, जिसमें मैं सहायता कर सकता हूँ, जिसमें मैं सहभागी बन सकता हूँ आप सबका, आप लोग प्लीज़ मुझे ज़रूर बताएं. नेवर हेजिटेट. तो चाहे कहीं का भी कोई भी जगह हो, कहीं का भी कोई भी काम हो, प्लीज़ आप मुझे ज़रूर बताइएगा. आई विल बी हैप्पी टू बी अ पार्ट ऑफ इट, टू बी एसोसिएटेड विद गुड कॉजेज़. आपने इतनी देर तक मुझे सुन लिया है, उसके लिए बहुत बहुत धन्यवाद. आप में बहुत पेशेंस है, बहुत पेशेंस है आप में. जी, विंटर सेशन के बारे में आई एम गोइंग टू स्पीक अबाउट पेशेंट and doctor's relationship. Something concrete should be done about it. Lot of incidences are happening every day. Patients का कुछ बिगड़ जाता है तो वो डॉक्टर्स पे इतने नाराज हो जाते हैं कि मत पूछिए आप. मतलब तोड़ फोड़ की नौबत आ जाती है हॉस्पिटल की. Violence against doctors. और पेशेंट ये कहता है कि हमारी तरफ ध्यान नहीं दिया जाता. This is a very peculiar kind of a situation. So something should be done about it. I think this is a high time now. मेरठ में इतने ज़्यादा डॉक्टर्स हैं और इतने ज़्यादा नर्सिंग होम और छोटे छोटे हॉस्पिटल्स हैं, आप सोच भी नहीं सकते. वहाँ तो ये रोज़ाना होता है. एक तो वैसे ही एटीट्यूड लोगों के थोड़े से वो हैं, तो वहाँ ये रोज़ाना होता है. तो मुझे दिमाग में आया था, मैंने इसके लिए काफ़ी डाटाज वगैरह भी कलेक्ट कर लिया है. तो दिस आई एम गोइंग टू टेक अप इन पार्लियामेंट दिस टाइम, कि कुछ तो भी एक कोई इसे हमें कुछ ना कुछ इसके लिए करना चाहिए, कि ताकि दोनों तरफ की बात जो है वो सुनी जा सके और एक अच्छी रिलेशनशिप डॉक्टर्स में और पेशेंट्स में बनी रहे. So that's what I was talking about. Thank you very much. Good day to you. और एक बार फिर दिल को संभाल कर रखिएगा, बहुत जल्दी इधर उधर भटकता है. Thank you.
I request everyone to give standing ovation for Prabhu Shri Ram, Arun Govil ji.
अभी मैम ने रावण की बात की थी ना, मुझे रावण का एक संवाद याद आ गया है, वो मैं आपको सुनाकर जाऊंगा. वो संवाद बताता है कि हमारी जिंदगी क्या है, हमारी जिंदगी कैसी होनी चाहिए, कैसी नहीं होनी चाहिए. जब पहली बार भगवान राम और रावण का युद्ध हुआ था, तो उस दिन भगवान राम ने फाइनली संध्या होते होते रावण का रथ, उसके खड़ग, ध्वजा, पहिया सब कुछ तहस नहस कर दिया था. और तब भगवान राम ने रावण से क्या कहा, देखिए. वाह रावण वाह, भगवान शिव के त्रिशूल की भांति प्रचंड वायुपुत्र हनुमान की मुष्टिका का प्रहार तुमने सह लिया. तुम सचमुच परम शक्तिशाली हो, परंतु कितने दुख की बात है कि तुमने अपनी ये शक्ति अधर्म के कार्यों में लगा दी और इस दुर्दशा को पहुंच गए. रावण, भक्त और ज्ञानी में अंतर होता है. भक्त चाहे मूर्ख हो, परंतु हृदय का सच्चा और मन का सरल होता है. परंतु ज्ञानी तुम जैसा दुष्ट भी हो सकता है, जिसे स्वर्ण लंका के राज सिंहासन पर बैठकर भी जीवन की अपूर्णता का कांटा चुभ रहा है. तुम्हारे जीवन में इस समय अशांति, चिंता और तड़प के अतिरिक्त और कुछ नहीं है. तुम्हारे जैसे हर दुराचारी को एक समय इस बात का आभास हो जाता है कि उसका अंत समय निकट आ गया है, और तब वो एक घायल सांप की भांति अपनी सुरक्षा के बिल ढूंढता फिरता है, लेकिन उसे कहीं सुरक्षा नहीं मिलती. वही अवस्था इस समय तुम्हारी है. तुम्हारे पाप कर्मों के विष के प्रभाव ने तुम्हारे मन की शांति को जला दिया है, और तुम उस पाप के विषैले कांटे की चुभन को छुपाने के लिए ऊंची ऊंची आवाज में बड़ी बड़ी डींगे मार रहे हो, जिन्हें तुम्हारा अपना मन भी सच नहीं मानता. रावण, इसी का नाम है दुर्दशा. युद्ध जीतने के लिए अस्त्र शस्त्रों की गिनती और पार्श्विक बल की आवश्यकता नहीं होती. युद्ध जीतने के लिए आवश्यकता होती है धर्म और आध्यात्मिक शक्ति की. तुमने एक बार लक्ष्मण से कहा था कि तुम्हारे यहां कोई नीति, कोई धर्म नहीं होता. हमारे यहां युद्ध का भी एक धर्म होता है. हम निहत्थे शस्त्रहीन शत्रु पर कभी वार नहीं करते. यह है रघुवंशियों की वीरता. अब जाओ, कल फिर शस्त्र लेकर आना. रावण अगले दिन फिर शस्त्र लेकर आए, और जो हुआ वो हम सब जानते हैं. अनीति पर नीति की विजय हुई, अन्याय पर न्याय की विजय हुई, असत्य पर सत्य की विजय हुई, और अधर्म पर धर्म की विजय हुई. जय जय श्री राम.
सर ने बताई हुई, श्री राम ने बताई हुई एक बात मन में रखकर ही इस कार्डियोकॉन से हम घर जाएंगे. कोई भी व्यक्ति बुरा नहीं होता, उसके पॉजिटिव पॉइंट्स हमें देखने चाहिए. नाउ आई रिक्वेस्ट अरुण जी टू फेलिसिटेट आवर सम मोर डिग्नेटरीज who are very important for us.
हेलो. या सर, आपने बहुत अच्छी बात की. पहली बात मैं बताना चाहता हूँ, आपने कि रात को 3 बजे आके भी आप जो मरीज है उसको देखना चाहिए. ये सब लोग उनमें से है कि रात को 2 बजे 3 बजे भी जाके पेशेंट को देखते हैं, इंक्लूडिंग माई सेल्फ. कुछ भी हार्ट अटैक किसी को आया तो मैं जाके 2 बजे एंजियोप्लास्टी करके आता हूँ. तो आपने जो बताया तो वो हम लोग है, ये सब लोग हैं हमारे दोस्त. दूसरा आपको बोल रहा हूँ कि काफी लोगों ने मुझे बोला, अरे हार्ट का कॉन्फ्रेंस है, दिल का कॉन्फ्रेंस है, फिर अरुण गोविल जी साहब को क्यों? दूसरे क्यों सेलिब्रिटी को बुला रहे हैं? अपने सब के दिल में क्या है? राम है। और राम कौन है? अरुण जी है। शाश्वत राम।
शाश्वत।
और उनके तरफ देख के लगता है कि यही राम है। उनको देख के कोई फाइटिंग करने वाला हीरो या कोई अलग हीरो लगता नहीं। उनको देखने पहले आंख में आता है राम आता है। इसलिए आपको सर हमने बुलाया। आप हमारे दिल में हो। हमारा पूरा बचपना आपको देखते देखते बड़े हुए। हमारे गांव में एक दो ही टीवी रहता था। हम थोड़ा सा छोटे रूरल एरिया में थे। एक ही टीवी रहता था। तब हमारे पापा एजुकेशन ऑफिसर थे, उनके घर में टीवी था। गांव में फिर सब लोग आते थे और कुछ लोग वो टीवी को माला चढ़ाते थे। ठीक है, ये आपके उस वक्त भी हुआ होगा। पूरा गांव, स्मिता ने बोला कि कर्फ्यू लगता था, सच में कर्फ्यू लगता था। कुछ लोग वो हार भी लगाते थे टीवी को। तो ये इनकी लोकप्रियता है। अभी भी पूरे टीवी इतिहास में सबसे बढ़िया सीरीज और सबसे ज्यादा चलने वाली सीरीज, ज्यादा वॉच सीरियल इज रामायण ओनली।
हाईएस्ट टीआरपी।
ओके। और तीसरा लास्ट, मैं बड़ा स्वार्थी आदमी हूँ। सर ने बोला कि स्वार्थ नहीं रखना चाहिए। सर ने लास्ट सेंटेंस बोला, अगर आपके लिए कुछ भी मैं हेल्प कर सकता हूँ तो आई विल बी हैप्पी। तो मैं आपको थोड़ा सा और तकलीफ देने वाला चाहता हूँ। ये लोगों ने, स्मिता हो गया, अशोक हो गया, ये लोगों ने ये कॉन्फ्रेंस के लिए बहुत मेहनत की सर। तो इनके पीठ पे एक छोटा सा शाबाशी का हाथ रखोगे ना तो विल बी हाईली मोबिलाइज। तो इनको दोनों का कुछ सत्कार कर लीजिए। एक मिनट, फेलिसिटेशन प्रॉपर करेंगे सर, स्टेप बाय स्टेप।
स्टेप बाय स्टेप।
तो जस्ट नाउ यू टेक ओवर। थैंक यू।
फर्स्ट डॉक्टर अशोक सिंह।
मैं इसलिए ये वातावरण निर्मित इसलिए किया क्योंकि सर को जाना था। सर को रुकाना है तो मुझे सब करना पड़ा।
डॉक्टर अशोक सिंह, प्रेसिडेंट AMA एंड फर्स्ट लेडी CA अनीता सिंह। Dr. Shashank Shah, President MCVP, and Mrs. Sandhya Shah. Dr. Rajesh Ghatkar and Dr. Smita Ghatkar. डायरेक्टर क्रिटिकेअर हॉस्पिटल चाकण पुणे. ट्रस्टी गुरु कृपा डॉक्टर राम चौहान, मैनेजिंग ट्रस्टी AMA डॉक्टर राम चौहान एंड डॉक्टर अश्विनी चौहान, इलेक्ट प्रेसिडेंट AMA. अरुण गोविल जी, श्री राम हमें आज मिलने आए और ये राम चौहान रोज हमारे साथ रहता है. डॉक्टर अनिल कुमार उलागड़ी, आले सर आले. The silent man whose work speaks. Dr. Tejaswini Pandare and Mr. Sagar Pandare. Pandre. Dr. Sanjay Ratnaparkhi and Mrs. Sadhna Ratnaparkhi. Dr. Sanjay Ratnaparkhi sir and Sadhna ma'am. Dr. Rahul Ratnaparkhi and Dr. Pranjal Ratnaparkhi. आणि करता धरता ऑफ द कार्डियोकॉन डॉक्टर GP Ratnaparkhi sir and Dr. Smruti Ratnaparkhi ma'am. Standing ovation for both of them.
जिन्होंने भगवान राम के लिए, भगवान राम मतलब अपने लिए अरुण गोविल सर के लिए इतने अच्छे शब्द यूज किए हैं, इतना स्टडी करके आए, ऐसे स्मिता मैम को भी अरुण सर फेलिसिटेशन दे. एक बुके द्या. स्मिता मैडम, जय महाराष्ट्र, जय श्री राम.
Now it's time for a bumper lucky draw. Please be seated, everyone. I request Dr. Sanjay Ratnaparki sir to take a bumper lucky draw. Those who will be in the hall will get the prize. निकाला काढा 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 तुम्ही जरा बोला.
Hello, hello. 094, Dr. Habibur Rahman.
डॉक्टर हबीबुर रहमान
नहीं है?
नहीं है.
चलो नेक्स्ट. हाय थांबा थांबा, हात दाखवतोय वरती. हाय आगे आओ. डॉक्टर हबीबुर रहमान. मुसलमान. डॉक्टर हबीबुर रहमान मुसलमिन. यार आपको वहां पे नाम घ्यायला सांगा ना, मोठा वाला. थांबा सर, रुको सर, रुको सर. तुमच्या हाताने
अरे Now I request our second MOC, Dr. Poonam Solanki, to come up on stage and handle next session of speakers and lectures. She is a perfect example of beauty with brains, a renowned gynecologist and obstetrician, practicing since 15 years in Andheri. Please welcome Dr. Poonam Solanki.
Very good afternoon to all my dear friends and senior colleagues. Today, on the occasion of CardioCon, I am honored to welcome our next speaker, Dr. Nitin Patankar sir, to speak on a global health crisis, obesity, comprehensive review of obesity. Dr. Nitin Patankar sir did his MBBS MD in 1988 from University of Mumbai, fellowship in Johns Hopkins University, Baltimore, USA, and Duke University. He is a certified bariatric physician and president of International Metabolic Physician Association. He is a director of Wisdom Clinic and consultant at Jupiter Hospital, Thane and Mulund. Sir is a consultant metabolic physician at LH Hiranandani Hospital, Powai. Sir has conducted more than 500 training programs and diabetes. Sir has written a textbook of endocrinology for the medical students, written a chapter in RSSDI textbook of diabetes on obesity and nutrition. Sir is a writer of a chapter on nutrition in API textbook of medicine in 2021. Sir is a writer of a popular Marathi book on obesity called Kata Rute Jayanna. Sir is doing research on yoga, yoga chakra and music. Please welcome sir on stage.
Thank you so much.
ओके. सो गुड आफ्टरनून एव्हरीवन. आणि एवढा आपण म्हणतो की हृदय समारंभ झाला आत्ता, त्याच्यानंतर बऱ्याच लोकांचं हृदय भरून आल्यामुळे बहुतेक बाहेर गेलेले आहेत लोक. सो पहिल्यांदाच मला सांगायला पाहिजे की आय रिअली थँक डॉक्टर रत्नपारखी because to invite me to this conference. And nowadays whenever I attend conferences, I have seen that there are more number of people on stage rather than in auditorium. So here it is a reverse scenario is seen, and when I came at 10 o'clock in the morning, the auditorium was full. So I really had heard of Dr. Ratnaparkhi but never had met him. And my good friend Dr. Vinay Parvatkar, who told me that Dr. Ratnaparkhi will call me and call me for a lecture on obesity. So I inquired with some people that who is Dr. Ratnaparkhi, what he does. And 2-3 people told me, "Arey baap aadmi hai ekdam." And when Dr. Ratnaparkhi called me, he said that your topic is baap of all diseases. So I was wondering, ye kya connection hai? So he had given me this topic, obesity, father, that is baap of many diseases, a comprehensive review on obesity. So keeping in mind that you all must be hungry, so I will try to finish it as quickly as possible. So when I got this lecture topic, somebody sent me on Facebook this picture. So this is a person named Umair in Saudi Arabia, and this has come in Pakistan Times. So he has adopted a school in Saudi Arabia, and immediately he married to a student, teacher, supervisor and principal of the same school. So their names are also Meher, Munira, Maisoon and Mahzibin. And when he was interviewed, he said that we want to have a lot of children. So I thought that this is the best picture for depicting obesity. So you can just extrapolate those words. The Omer can be called as obesity, and the 4 wives the Omer has married to, they can be like 4 M's again, like the M, the letter with which the all names were starting. So with obesity we can have metabolic problems, mechanical problems, mental problems, mutagenic problems, and 5th M maybe till date that Omer must have married another 5th M also. So that is like monetary problems. So we have all these problems can come up out of obesity. And when I was thinking about this lecture, that what obesity does, and I was told that there will be a validatory function later, but there will be a lot of dignitaries will be coming on stage, and so you may have to crunch the lecture, crunch the time. So I was thinking what I can do so that if I get only one slide to present, what I will present to. So in Hindu culture there are a lot of old texts are described in 4-liners. Like Gita Sar, jo ho raha hai acha ho raha hai, jo hua tha acha hua tha. The 3 sentences, Gita Sar is over. Similarly, and I didn't know Mr. Arun Govil, who portrayed Ram, was coming here, but I got a 4-liner from Ramayana, which describes the whole Ramayana in one shloka. That is called as a Ekashloki Ramayana. So what it says like, Adau Rama Tapovanaadi Gamanam Hatva Mrugam Kanchanam Vaidehi Haranam Jatayu Maranam Sugriva Sambhashanam Bali Nirdalanam Samudra Taranam Lankapuri Dahanam Paschad Ravana Kumbhakaran Hananam Etadvi Ramayanam. Means रामायण का पूरा सार इसमें आ गया, राम की कथा इसमें आ गई है. एक बार राम वनवास में गए, उन्होंने स्वर्णमुख का पीछा किया और उसका वध किया. उसी दौरान रावण ने उसकी पत्नी वैदेही यानी सीता का हरण किया. उनकी रक्षा करते हुए जटायु से झगड़ा हुआ, मारामारी हुई. फिर जटायु से संभाषण हुआ राम का. श्री राम की मित्रता सुग्रीव से हुई, बाली का वध किया. फिर समुद्र पर पुल बनाकर लंका में गए, लंका का दहन हुआ और रावण कुंभकर्ण का वध करके वो वापस अयोध्या चले आए, इसमें पूरा रामायण आ जाता है. So it is called as a Ekashloki Ramayana, and I didn't know that the whole atmosphere will be so much filled with Prabhu Ram, but this was a, I think, coincidence. But I thought that if I want to present in the same way, only 4 lines about obesity, if I get only 1 slide to present, then what I can say about obesity is, it is the excess fat and not weight, which is a genetically based chronic disease. It leads to most of the modern day diseases, as we have talked about. Medical bariatric surgery in today's world is the gold standard of treatment, because medical treatments are judged against all the new drugs which are coming, are judged against bariatric surgery, and the claims by all the companies and the trials are they are catching up with bariatric surgery, and permanent changes in social environment, psychology, diet and activity is required to retain the benefits of any treatment, whether it is surgical or medical treatment. So ये 4 में obesity का पूरा हो जाता है. Luckily I am getting some more time, so I will continue with the lecture. So today the obesity is not called as obesity per se, but because there are so many realms of obesity are there, it is now renamed as ABCD. So in a position statement, the American Clinical Endocrinologist and American College of Endocrinology, this is the term they introduced, that is adiposity based chronic disease. Adiposity based chronic disease, ABCD. So like alcoholic, non-alcoholic liver disease is now called as a MASLD. So many renames are being there because we want to incorporate all the things that are included. Similarly, obesity is now called as ABCD. The adiposity based component of ABCD points to abnormalities in the fat mass, which was like previously judged by BMI, but distribution of fat is also now a critical factor, whether fat is subcutaneous, whether fat is visceral, or whether fat is ectopic, that is inside the organs, and the disturbed function of fat, because there are so many times people have got something called as a healthy fat. So they don't meddle with metabolism, they don't meddle with so many things, so they get only mechanical problems but may not get metabolic problems. So it is function, distribution and mass, that's why that adiposity based component, and the chronic disease is a term added to that to underscore the associated complications such as hypertension, diabetes, sleep apnea, which produce morbidity and mortality. So we no more call this as obesity, it is called as a ABCD. So the motto of the treatment is lose fat, not weight. How to find out the quantum of fat in the body? The easiest way, this is by Oxford University, and there are many other scientists who have found out this, that instead of going for DEXA machines, instead of going for all those bioimpedance machine, this is a simple formula they have derived, that for men 64 minus 20 into height upon waist circumference, and for females 76 minus 20 into height upon waist circumference. This value of fat percent matches almost 99% to DEXA scan related values. So it is the most accurate measure of finding out how much is the body fat. So the approach towards the obesity management should be based on not on only weight loss or fat loss, but preventing complications or co-managing the complications with adiposity based disease. Secondly, with emphasis on chronicity, that it cannot be cured, and thirdly, with strong statistical evidence presented by various trials. In the past, like I was talking with Dr. Raman, that obesity was considered not even as a risk factor. So obesity was considered as a God-given gift. People were supposed to be wealthy when they are having paunch. So on those days when people started treating obesity, there are, like in Marathi it's called as haushe, gaushe, naushe. So everybody joined the bandwagon to treat obesity. So the gym people, the dietitian, the exercise trainers, the doctors, everybody joined in. But unfortunately what happened, that whenever the obesity was presented in medical conferences, the medical part was taking a back seat. And it turned out that people were showing only celebrity faces, only before and after photographs. So it's almost becomes an advertisement for the presenter, that you come to me, and everybody's visual impact is so much. So to get away from that kind of a scenarios where you are before after photographs are shown, we don't show such photographs when somebody's gout is corrected, somebody's diabetes is corrected. We don't show that person with HbA1c 9.5 and now. We talk of a group of population where the drug have resulted into such and such results. So that's why the Edmonton obesity scoring system, which was developed in Canada by Dr. Arya Sharma, what they were saying that goal should be preventing the complications, that should be the goal. But the funny part is, and in Dr. D. Nornish's book he has mentioned, that everything that can be prevented cannot be counted. That is the worst part of it. Because that's why it can be only statistically proven. So in medical conferences, we need to present statistics or the techniques rather than all those fanfare. अरे पुढे नाही. So let us look at this trial, because many people will say I lose weight so many times. Bernard Shaw had given that famous statement that it's easy to quit smoking, I have tried it I have done it many times. Similarly, there are so many people who will say that I have lost weight many times, but they have regained weight. So don't worry if your patient comes to you and says that I am trying to lose weight but I don't lose weight. This is a very good trial that it says that overweight diabetic adults, basically it was conducted in diabetic people, overweight diabetic adults trying to lose weight, understand this word, trying to lose weight, which have reduced risk of all-cause mortality and morbidity, independent whether they have really lost weight. So just trying to lose weight, doing something to lose weight gives, and the numbers which are present are around 24% reduction in mortality and morbidity even if you don't lose weight. But people who don't try to lose weight, they keep on, they say, Bhagwan ki dein hai, main aisa hi rahunga, aisa hi karunga. They have got 34% increased mortality and morbidity when they maintain obesity, and intentional weight loss with maintaining muscle mass and lean tissue mass, there is always around 30% reduction in mortality and morbidity. But I like this trial very much because this motivates people to do something to keep on losing weight and don't get disheartened if you don't lose weight. So this is our Edmonton obesity scoring system, and why this was developed? Because it should be comorbidities condition. BMI just gives you the mass, and there is a next slide which shows why BMI is insufficient, but this EOSS has been proved to be very useful. So there are stages and not class of obesity, stage 1, stage 2, stage 3 and stage 4, depending on what kind of a comorbidities, how many comorbidities are present and what level of comorbidities you are into. So this scoring system says that even if your BMI may be 27, but if you have got major comorbidities, the first line of treatment can be bariatric surgery. Or it can be BMI, somebody is 45 BMI, but there are no comorbidities at all, then you can still try for lifestyle modification or pharmacotherapy. So that has changed the perspective of looking at obesity management. And this is the graph I was trying to show. So this is the EOSS scoring system. So at initial stage, at 0 month, if you label the patient depending on the comorbidities, at the end of 200 months, you will find the graph separate so much that somebody who was labeled as stage 3 can have much higher mortality or morbidity, but BMI doesn't show any difference. BMI, the graphs don't separate over the period of 200 months. So EOSS has been very useful in finding out whose treatment should be intense and what should be done. So this is again a very simple Australian system which shows that you find out what is the BMI level, what is the comorbidity levels, and what you can do with it. So this is I just will jump to skipping diet, exercise, everything, but because that you must have heard so many times, and if I get a chance I can give that into question answer sessions. But these are the drugs that I was talking about, and in 2026 or 27 we will get so many drugs to manage obesity, and we will have to really choose. Like today we have to choose between antihypertensive medicines or anti-diabetic medicines. We will get a lot of choices. So what are these drugs? So basically they are injectable and oral, and if you look at this retatrutide, which is supposed to, we will get it in around 26 end, which can give around 25% weight loss. 25% weight loss, which is nearer to surgery. Surgery can give 30% or more, but this is matching it. So now you will think that what happens if I stop the drugs? So that will be my main discussion, and I will stop there. So these are all newer anti-obesity drugs. There are various mechanisms, but I want to focus on one thing, that is the retatrutide I talked about. I think that is So this drug I want to focus on. This is a monoclonal antibody. It's a biologic drug. And why I want to focus on this, all other drugs which are basically related to GLP-1, GIP, glucagon, amylin, all those basically neurotransmitter receptors. This drug basically works on activin receptors in stomach, activin receptors in brain, and this is the only drug, phase 3 trials, they have found out that it can cause around 24%, 20% fat loss, at the same time 3 to 4% muscle gain. So that will be the very attractive drug in future. So as I said, surgery is the first option, but when surgery is not option, so not indicated by class or stage, there are contraindications which I will talk about. Then there are financial constraints or patients pure unacceptance that I don't want to undergo surgery. Then somebody has to take care of that patient. So what are the contraindications for bariatric surgery? So the risk for bariatric surgery, surgical risk, those are different things, but basically if there is a severe cardiopulmonary disease or coagulopathies, in which condition it will be very difficult or risky to operate. So in these conditions, luckily the even newer drugs, that is GLP-1 receptor analogs or GIP-1 receptor analogs are useful in these conditions. It doesn't cause any like CVOT risk. So it has been proved that GLP-1 receptor analogs can be little superior to other drugs to treat in presence of cardiopulmonary diseases. Then the mental health factors are the biggest concerns, because if the patient has, say, alcoholism, patient has got psychiatric disorders, patient has got severe anxiety and depression, or patient has got no support system, because obesity treatment requires a lot of support system, then lifelong nutritional changes, lifelong activity and lifelong stress management cannot be possible, and this can be a contraindication for any form of a medical therapy or surgical therapy. So I will read out some medical conditions which you all must be facing, and we unfortunately as physicians have to tackle these people with obesity, because surgeons will usually won't touch these. So what are they? So eating disorders. So what are physical symptoms, and look at these. Your obese patients, whether they have this, they need a psychiatrist, but it's like a belling a cat. Who will say that patient who has come for weight management or diabetes management with obesity management that you go to a psychiatrist? So frequent fluctuations in weight, stomach cramps and bloating. Bloating is a main feature of eating disorder. Then dehydration and electrolyte imbalance, sore throat, repeated attacks of sore throat, and we feel it is viral infection. It is, but because of the GERD, they can get these. Then acid reflux and gastrointestinal symptoms, and overeating despite of becoming full. If you get these patients, don't treat. First send to a psychiatrist or call a counselor on board, because that is what is required. Then eating disorders, behavioral symptoms, binge eating followed by purging, That is very rare in our cases, but secrecy around eating. Then extreme concern with body weight. They will, wherever they go, they will start talking about their body weight and shape. Then evidence of binge eating, excessive exercise to use self-medication. Then eating large amounts of food in short amount of time, eating in secret and feeling a lot of guilt after eating, lack of control over eating, eating when not hungry to cope with stress, and repeated attempt to diet without success. So if the patient tells you that I've tried many times, gained weight, first thing on board should be a psychologist. But we as daredevil physicians, we try to part counsel them, part to try and give medicines, but nothing will work for them unless the psychological problems are tackled. So I will talk about, I got 2 minutes, neuroplasticity, the neurochemical changes in hypothalamus and hippocampus. So basically quantifying the exact percentage of neurochemical changes in hypothalamus and hippocampus attributable specifically to surgical procedures and to medical procedures also versus weight loss is complex, but surgical or medical treatments can give rise to 30 to 50% changes in brain and periphery, while 50 to 70% changes are attributable to pure weight loss. So this is a combination. So neuroplasticity, the research suggests that bariatric surgery can promote neuroplastic changes in the brain regions involving appetite and reward system, potentially leading to long-term effects on eating behaviors. Now I will skip the slides. So what are the brain changes? There is a lot of things that have been described about hippocampus and hypothalamus, but brain changes, even after stopping the medicines, newer medicines, even after 2 years, the changes can be remaining permanent if lifestyle modification, diet and exercise is actively followed and you are constantly into a help of a psychologist. So then these also can be a permanent thing, but similar to bariatric surgery, the GLP-1 RAs and GIP RAs can lead to behavioral changes such as reduced cravings and improved satiety signaling, which may persist even after stopping the medication. So I will give you a last hint that there are something like a reflex relaxation of stomach after eating. So after bariatric surgery, that is gone. Similarly, after the GLP and GIP-1 receptor analogs, when they are used, the reflexive dilatation of the stomach is prevented and the elasticity of the stomach goes down. So it takes around 1 year to 2 years of treatment with medications where these changes can be found. So anybody who desires to treat obesity medically, when there are surgical options are not available, they have to wait till 2026, where there are multiple kinds of drugs will be available. But till today, we have got starting from orlistat to GLP-1 receptor analogs, and maybe receptor analogs like tirzepatide will be available in India. So back to basics. Again, as I said, excess fat, not weight, is a genetic based condition. It leads to most of modern day diseases. Bariatric surgery is still the gold standard of the treatment. Medical treatments are judged against and is catching up with surgical treatments. But whether you treat medically or surgically, permanent changes in social, psychological, dietary and activity based changes is required to retain the benefits of treatment. To sum up, permanent changes in lifestyle is required to retain benefits of any form of a ABCD treatment. Thank you. Thank you.
interesting, sir.
Thank you. Thank you.
Favorite topic.
आणि ही इज परफेक्ट मॅन टू स्पीक स्वतः ओबेस नसल्यामुळे.
My sincere thanks to Dr. Nitin Patankar sir for sharing his knowledge on obesity
Yeah, thank you so much.
and making our event successful.
Yeah.
Now I would like to call upon stage AMA Secretary
एक आवाज आहे गणपती बाप्पा मोरया कर.
Ganpati Bappa.
Moria.
भूक लागली वाटते सर्वांना.
हो.
मी म्हणतो आमच्या सौ या.
Yeah, thank you. Yeah. Thank you. Thank you so much. Yeah.
पॅक करून द्या सर्वांना.
हे
ये पैक करके दे
Yeah.
सर वो दे दिया. सर शॉल दे दिया.
I know you all are hungry. Yes or no? And I also know that is a hunger of knowledge. Yes, because nobody is going outside. And even if you go outside, nothing is there. But for you, there are 2 or 3 instructions. One, in the morning, hotel people complained, lots of wastage was there. Enough food is there, enough time is there. We kept breakfast up to 11 o'clock. So no need to take, I'm sorry to say all these things, but what happened, I'm telling you, I'm feeling bad. So don't waste any food, one thing. Secondly, after this lecture of Raman sir, we will be breaking for lunch. Normally, I speak and then only lunch, okay? This time I'm a little bit liberal, okay? Ki wali tumchi, chala. I will send you for lunch. During lunch, we are going to do 2 things. We are going to felicitate all the pharma company because of those we could do such a grand event. One thing. Secondly, you people are all genuine people, very pure soul. So I request you, before their felicitation, just half of you go for lunch. Those who are young, can sustain, we'll have quiz. You know that this pattern every day, we will have quiz, we will have prizes. So 50% will stay here. Those who are diabetic, age, or some compulsions, health compulsion, please go for lunch, no problem. Remaining young people, or even at the age of 70, if you are feeling young, be here. It will be, see, lunch to milne wala hai. Quiz के जो बख्शिश है प्राइज वो उनको नहीं मिलने वाला है. ठीक है? सो दे आर पेइंग अ कॉस्ट ऑफ दैट. सो आपको लंच भी मिलेगा, प्राइज भी मिलेगा, नॉलेज भी मिलेगा, प्लस एंटरटेनमेंट तो है आप मेरे तरफ से आपको फ्री. ओके. सेकंड, और आपके क्विज के बाद फिर मैं फार्मा को सबको बुला के उनका फेलिसिटेशन करूंगा. एंड देन विथ फार्मा पीपल एंड विथ माय एंटायर टीम विल हैव लंच. दिस इज व्हाट द pattern है. So please cooperate. Okay, any suggestion? Any problem? बराबर है ना? Okay, so those who are young, be here. Those who are having some health problem or not young at heart also, na, can have. So because what happened, although there are 4 counters, no problem. Accommodation of 800, 900 people is difficult. You have to wait with the plate. Wait with the plate. अरे कविता होगी तो है ना? You have to wait with the plate. Unnecessarily there. So आराम से उनका होने दो. फिर अपन जाएंगे. Last में we will go. So we'll divide into 3 batches. Agreed? Thank you, sir.
Now I would like to call upon Dais Dr. Raman Goel sir to present role of bariatric surgery in the management of cardiometabolic diseases. Dr. Raman Goel sir is a pioneer of laparoscopic surgery in India. Dr. Goel was instrumental in training surgeons in laparoscopy across the India. He was associated with Grand Medical College, Mumbai as honorary professor of surgery from 1994 to 2010, performing advanced laparoscopy surgery on thousands of patients. He is the first bariatric surgeon in Mumbai and a second in India as started bariatric surgery in 2001. Sir is a senior bariatric and metabolic surgeon at Wokard Hinduja Khar and Zen Hospital. Editor of International Peer-Reviewed Journal of Bariatric Surgery, has recently started doing surgery for diabetes even on in non-obese person. Past president of Obesity and Surgical Association.
Yeah, thank you. Okay. Good afternoon. Thank you. So now that everybody is waiting for lunch, but I am not going to leave you. Because this topic, when it was given to me, I was wondering why a bariatric surgeon has been asked to come to a cardiology meeting. And after preparing this, I realized the old saying that the way to a man's heart is through the stomach. And we are stomach surgeons. And this is what is an eye-opener even for me. Thanks to Dr. Ratnaparki for inviting me for this talk. Yeah. Because I found so much evidence, and as Dr. Patankar was saying, we should present the evidence. So I'm going to talk about how bariatric surgery can prevent heart disease and how bariatric surgery can treat heart disease. It will not be out of place that after this presentation, you will realize that this is the most effective therapy for heart disease, next to PTCA and CABG. So just hold your hunger for some more time. I know all of you are young, as Dr. Parki said. I do only bariatric surgeries, and we do about 250 bariatric surgeries a year, and I do mostly gastric bypasses. So what are the issues? One is, does it give enough weight loss? Is weight maintained? How the surgery works? How it works for diabetes? I'm sure some of you have seen one of my videos which got viral about doing treatment for diabetes in non-obese patients through surgery. How does it protect heart? And how does it compare to the newer drugs? Everybody is talking about the newer drugs, but what is the comparison between the two? And why physicians are still not accepting bariatric surgery? So just one picture, no videos. Bariatric surgery, as all of you know, is very, I just need to know which one. Yeah. These are the three common procedures. There is nothing great about it. In all the procedures, we reduce the size of the stomach, and that leads to less eating and also leads to hormonal changes. Now, the hormonal changes are the same on which these drugs are based, and I'll be talking to you about them. And these are the recommendations in heart patients. Even if your BMI is more than 25 or just 26, you should lose weight, and especially if the waist circumference is more or if there is at least 2 heart risk factors. But does lifestyle changes really work? There is enough published data that they can lose weight meaningfully in immediate period, but they find it extremely difficult to sustain it for more than 1 year with diet and exercise. And thus this advice of making lifestyle changes is really a controversial advice, because lifestyle changes are required for better health, but for weight loss, lifestyle changes have limited role. What about these lifestyle changes on heart diseases? So this is a meta-analysis, 54 randomized control trial. These are not just the cohort study of 30,000 patients who are put on diet for weight loss. They found that they indeed lost weight, they had less deaths, but there was no effect on cardiovascular mortality, or it had a preventive role in developing new cardiovascular events. So weight loss is important, but weight loss has very limited role in long-term cardiovascular disease, and that is what with diet. Now what happens when we do achieve weight loss with bariatric surgery? Again, this is a meta-analysis of 11 randomized control trials, and they found that with bypass they have lost about 67% excess weight, with sleeve they have lost about 71% excess weight. But what happens in long term? Again, this is from studies that with sleeve patients lost about 37% weight, but even after 15 years, 31.5% weight loss is still maintained. I know so many of you come and say that patients regain weight. I have seen 2 patients who had bariatric surgery, both of them regain weight. These are anecdotal. It's possible that you have not seen the other 8 patients who did not regain weight. But this is long-term published study with bypass. Patients have lost 45 kgs in 2 years, and even after 12 years, they have maintained 35 kg weight loss. So please accept that ultimately science is statistics, and this is what is most important. These are long-term published data. Moving on quickly from weight loss to diabetes. What happens when we do these same surgeries for patients who have diabetes? They need not be morbidly obese, they are just overweight people. Now this is a long-term follow-up study. 90% follow-up at 12 years, patients who had surgery and those who were suitable for surgery but they didn't undergo surgery. They found that in surgery group, remission was seen in 75% patients at 2 years. Remission means they are completely off medicines and HbA1c is below 6.5. This remission is maintained in 51% patients at 12 years. So if I do this surgery for diabetes alone, not for weight loss, 51% patients are still maintaining HbA1c below 6.5 even after 12 years. And this is a strong statement because all of you treat diabetes daily, but do not think that this is a competition between surgeon and physician. It's a competition between better care for your patients or better care for your family members, maybe your father or your mother or your brother who has diabetes and is not well controlled. And then what happens about those patients who are going to develop diabetes, who don't have diabetes today? If you do a surgery, only 3% of them will develop diabetes in future compared to the control group where 26% patients will develop diabetes in future. So it has a preventive role in developing diabetes in these patients even after 12 years. Based on this, American Diabetes Association, which is a diabetologist body, came out with these guidelines in 2021 saying that we can offer this surgery at 27.5 BMI for Asians like us whose sugars are not well controlled. This is standard of care. All the physicians, endocrinologists follow this. Please look up and question the person who is not agreeing to this because this is a published guideline. Based on this, surgeons changed their guidelines in December 22. And this is where they said that for Asians, the threshold is less and it's 27.5. After that, we started operating patients at 28 BMI, 29 BMI with uncontrolled diabetes, and I'll show you their results a little later. We also changed the Indian guidelines, which says that at 27.5 BMI for uncontrolled diabetes, we can do these surgeries. How does this surgery work as far as diabetes is concerned? Now, we all know that GLP-1 is secreted from terminal ileum. So, in gastric bypass or a sleeve gastrectomy, food goes there faster. So, this is gastric bypass. So, now I have brought the terminal ileum closer to the stomach. So, the food reaches here and the GLP-1 is secreted, which reduces insulin resistance, which increases insulin secretion from pancreas. Now, this has never been achieved, that you can increase insulin secretion from pancreas, or except metformin, there is no other drug which reduces insulin resistance. Now, this is direct effect on this, and it is believed that it also increases the number of beta cells in pancreas, but very difficult to establish because who does pancreatic biopsy just for the sake of it? So, how does it work for diabetes? There are multiple mechanisms. Definitely the person is eating less, but there is also the hormonal changes, the GLP-1, PYY, the amylin, and all these leads to multiple differences at the brain level, which Dr. Nitin Patankar just explained very well, and this leads to improved glycemia in these patients. We have also published data repeatedly, and this shows that at 3 years after bariatric surgery, 80 to 91% patients are maintaining HbA1c below 6.5, and even after 7 years, 68% of them are maintaining HbA1c below 6.5. All of you treat diabetes daily. You know how difficult it is to achieve this kind of HbA1c control without hypoglycemic episodes when you're treating with medicine. Now, they are extremely rare as far as surgery is concerned. These are our early results. As I said, we started operating in December, 16 December, we did first low BMI patients. We operated about 43 patients in first 1 year. Look at this. At 3 months after surgery, all of them have achieved HbA1c below 7 and they are maintaining even after 1 year. So the glycemic control happens even before weight loss happens. And that's why this surgery is now more indicated for diabetes than for weight loss. And this is an important thing. But this is not my slide is not working. Slide is not working. Okay. This is not a new concept. Can you move it, please? Yeah. In 1955, a surgeon published this data saying that he did a subtotal gastrectomy for a peptic ulcer and diabetes got treated. At that time, there was no other medicine except insulin for diabetes. I wish surgeons had taken this forward. We would have an excellent control of diabetes in years. This is not about diabetes control, it also reduces the complications. There are enough published data to show that macrovascular complication reduced by 78% and microvascular complications reduced by 90%. We are operating more number of doctors and medical representatives nowadays than the lay people, because these are the people who hear our lectures and they come for surgery with us. And this leads to increase in lifespan by almost 9 years. So diabetic patients who undergo bariatric surgery, their lifespan is likely to increase by about 9 years. Moving from diabetes quickly towards metabolic syndrome and then cardiac diseases, the blood pressure goes, this is our own data, which shows that the 55% patients after sleeve are off all medicines at 3 years. 80% of gastric bypass patients are off all medicines for blood pressure, and there are few who are with reduced medicines. Now, this is about the primary prevention. When we operate on these patients, 50% of them will not develop blood pressure in future when we operate on patients without blood pressure. 50% in future at 5 years. Secondary prevention, those who already have blood pressure, 84% patients after surgery will have improvement compared to 13% patients. And 51% patients are in remission, that they don't need medication. This is international published data. Moving to the next phase of metabolic syndrome, dyslipidemia correction. This is again a long-term follow-up studies which says that 76% patients will achieve total cholesterol of less than 200 milligram. HDL increases. This is the only way HDL increases besides exercising. With bariatric surgery, the normal levels of HDL is achieved in 58% patients. You know the most common dyslipidemia in India is low HDL. So with this surgery, the HDL can go up, and there is 75% lowering of triglycerides after bariatric surgery. So when you see all this, you realize all the components of metabolic syndrome, whether it's waist circumference, triglycerides, HDL, blood pressure, or diabetes, the bariatric surgery is impacting each of them, and that is why we are not talking of improvement in 3 out of 5, we are talking of 5 out of 5 factors which improve, and that's how the cardiac factors improve. And now I'm going to talk to you about the improvement in cardiovascular disease. Let's start with angina. Patients who have surgery for weight loss or diabetes are likely to have angina in only 0.4% patients in future, compared to 1.8% who are in the control group, that means who did not have surgery, compared group. Secondary prevention, those who already had angina and who are persons with obesity, there is a two-thirds reduction in hospitalization in these patients. What about coronary artery disease? So many of you treat coronary artery disease every day. This is a meta-analysis of 6 studies. About 17,000 patients who had bariatric surgery compared to 43,000 patients in control group. And they found significant 32% risk reduction of coronary artery disease in the surgery group. Look at this. All the studies are on the left side. That means there is a hazard is so much reduced in these patients in coronary artery disease. And how does it work? Because it reduces inflammation it reduces adhesiveness, and if you want to measure it objectively, it has been seen that the carotid intimal thickness is reduced with weight loss. And this not only has an impact on coronary artery disease, it also reduces myocardial infarction and cerebrovascular accidents. So let's look at myocardial infarction. Again, a large study, 16 studies, meta-analysis, more than 2 lakh patients who had bariatric surgery versus about 5 lakh patients who are in control group, and they have established 47% risk reduction of myocardial infarction. Which other drug can promise this kind of change? I'm not saying every patient should have a surgery, but the patients who are at high risk of developing myocardial infarction or the family history is there and are suitable for surgery can be offered. The same thing applies on heart failure. Again the large study meta-analysis, because these are very large group, and they have found 55% risk reduction of heart failure. We are getting now patients referred by cardiologists with 20% ejection fraction for bariatric surgery, because young people who are 40, 45-year-old, and they say this is the only way we can ensure that this person lasts for next 20, 30 years. And how does it work? So it's not about, one thing is that 40% of them are obese. The primary prevention, obese patients who undergo this surgery for bariatric, the risk of heart failure reduces by 5 times in post-bariatric patients compared to the control group. And secondary prevention, those who already have heart failure, 40% reduction for heart failure episodes. So extremely strong statements from publications, and I am glad Dr. Ratnapar invited me today, because I could read this data myself and I can share it with you. There are multifactorial mechanisms. There is reduced risk factors, we have just discussed that, improved left ventricular systolic dysfunctions, and 43% reduction in left ventricular mass, and that leads to the reduction in the ventricular wall diameter. What about atrial fibrillation? We know obesity is associated with higher risk of atrial fibrillation. Now again, look at the large group, bariatric group versus control group. They found that 19% risk reduction of atrial fibrillation. It is statistically not significant, but there is a 19% risk reduction of atrial fibrillation. And then what about primary and secondary prevention? So if I operate on an obese patient, then there is a 21% less risk of first-time episodes in bariatric surgery over 20 years compared to the control group. But this benefit is more to young people and those with higher diastolic pressure. So if you have a young patient who is obese and has a higher diastolic pressure, this benefit can go to him. But what about secondary prevention? They say there is no significant reduction in atrial fibrillation episodes, but 50% reduction is in related mortality. So it benefits every aspect of cardiac disease, and that is what is required. When it benefits cardiac disease, it also benefits the cerebrovascular accidents. Look at this meta-analysis of more than 2 lakh patients who had bariatric surgery, same study, and they found significant 32% risk reduction of cerebrovascular accident. These are such common problems happening in our society, and you are managing them every day. Because of this, the cardiovascular mortality reduces by 52%, and this is probably the key of the thing, that these patients can live longer. I am aware newer drugs are coming, and newer drugs are coming in multiple combinations, because when semaglutide is introduced, it's a GLP-1RA, just one hormone. But when we operate, we are changing multiple hormones, not only, and that's why the pharma industry is trying to catch up with that. But now we have a 7-year follow-up study of surgery versus GLP-1RA. And this study got published, if you can see the last line, September 2024, this month. And this is the most recent study, because so they have followed these patients, the surgery versus the multiple GLP-1RAs for 7 years, and they have come out with this data. 5-year follow-up of surgery versus GLP-1 RA group in terms of weight loss. This is the surgery group, this is the GLP-1 RA. Yes, they work very well, but not at par with surgery. 5 years outcome of HbA1c reduction. This is the surgery group, this is the GLP-1 RA group. So, this is in terms of the weight loss and diabetes control. But what about the MACE reduction? The surgery group in first, surgery and the drug group in first 4 years remain the same. And then the surgery group has definite benefit compared to the drug group. These are the projected difference because this is a 7-year follow-up study, they have projected it. Nephropathy, surgery has definite benefit on the drugs. The mortality, not much difference. And the retinopathy also there is significant improvement. So there is a reason why the MACE is better after surgery. Because the MACE reduction is not only about weight loss. If you lose weight, 10% weight with the diet, you can definitely have a benefit. But to have a significant benefit, you need to lose 20% weight. But with surgery, even if you lose 10% weight, because of hormonal changes, the benefit is substantial. But somehow what we are finding is that the referral for surgery in these patients is not happening. Either it's because of knowledge gap, which I don't believe, at least in Mumbai, hesitancy and concerns of post-operative care and safety. All right. Let me tell you, as far as surgical risk is concerned, the perioperative mortality in laparoscopic cholecystectomy is 0.7%, while in a bariatric is 0.13%. I agree there is a higher risk of anemia, bone diseases and GI adverse event in surgery, but the risk of death from any cause is much less for patients who have had a surgery versus who did not have a surgery if they were indicated. There are awareness barriers. Studies have been done which have shown that if the physicians are understanding this thing, the referrals improve and post-operative care improves because ultimately most of the patients are managed by you. As far as bariatric surgery is concerned, let me assure you, we are now doing 20,000 surgeries a year in this country. It's not a small number. There are comprehensive program, there are Center of Excellence program, there are 30 publications coming from India. We publish this international journal from India, and we have FNB, FMBS and MUHS fellowships in this. So this is an accepted specialty. As far as bariatric surgery is concerned, last slide, this is happening for last 70 years. There has been intense media scrutiny and academic scrutiny. It is the most effective weight loss, diabetes and metabolic syndrome intervention, one-time intervention, and it can improve quality of life and save lives of your patient. Thank you so much.
Thank you very much, Dr. Goel, sir, for your valuable information and knowledge about the role of bariatric surgery in the management of cardiometabolic diseases. Now, I would like to call Dr. G.P. Ratnapaki, sir, Smita madam, and Ram, sir, to felicitate, sir. Okay, sir. Dr. Rajesh Tiwari, sir, Smita madam, and Dr. G.P. Ratnapaki, sir.
I'm here, I'm listening to you.
Yes. Moria. Sir, bumper.
Okay, dear friends, ते बॅग बी गिफ्ट आणा, दाखवा काहीतरी, बिचारे उपाशी तापाशी बसले आहेत. सो डिअर फ्रेंड, यू आर ऑल लेसर यंग लोग, ओके, आपसे थोड़े बुजुर्ग लोग खाना खाने गए, आणि वी आर हैप्पी दैट 75% people are here. I am really happy. Okay. This is all hunger of knowledge, hunger of quiz. Bas, baki rukta nahi. Hunger of prize also. Okay, you are telling that. So these are the quiz. The rules, regulation, you are aware that you have to just raise a hand and say yes. Huh? Because visually we cannot see you, but sound are either say I like that. Okay, fine. बॅगा बिगा आणा, दाखवा काय गिफ्ट देतोय आपण. दिनेश, बॅगा दे मोठ्या मोठ्या. These are the good bags, not the same what you are going to get at the end. Okay, वो नहीं, उसके साथ ये अलग है. So आज आप चाहे 2, 4, 5 बैग लेके जा सकते हो. Okay, these are the laptops bags. I am repeating, these are not the delegate gifts. They are different one. Okay, you are going to get delegate bags plus something worth of 2,000 rupees. I'm not telling because you should return. I know everybody will be there till evening because you are hunger of knowledge, absolutely. Huh? Huh? हाँ, और एक आदमी को अगर दो बार 3 बार भी जीतेगा तो एक ही बैग मिलेगा, क्योंकि इतने नॉलेजेबल लोग नहीं चाहिए अपने को, थोड़ा सा चाहिए. ओके, एक क्विज करेंगे. ऑल pharma company people should come inside. They can also take part. So one question, one pharma felicitation. Okay, we'll start simple, huh? To test your patience. What was the name of Hema Malini in Sholay? So this is what we don't want. Say yes. Okay. So this was trial. Don't open your mobiles. Pharma company also you can sit, no problem. आज अपने पास एक्टर आए है ना, एक्टर आए थे. तो ऐसे एक क्रिकेटर ने एक्टिंग किया था, संदीप पाटिल. उस पिक्चर का 2 क्वेश्चन है. उस पिक्चर का नाम क्या है? यस कौन बोला है? ओके, मैंने बोला है आंसर मत दो, सिर्फ यस बोलो. डोंट डिस्क्वालीफाई द क्वेश्चन. ओके, अगर ऐसा किया तो आपसे 100 रुपये लिया जाएगा और वो इनको बांटा जाएगा. वसूल एजेंट. ओके सर, क्या बोलो? परफेक्ट. ये क्वेश्चन नहीं था. उसमें क्वेश्चन इज नाउ यू आर गिवन चांस टू आंसर दैट. उसमें हीरोइन कौन थी? फर्स्ट चांस उसका है. नहीं, रॉन्ग. 100 रुपीज. हाँ, 100 रुपीज. यस. कौन? दीपा पाटिल. ये स्मिता पाटिल. अपने पास 2 ही पाटिल है, वृंदा पाटिल और स्मिता पाटिल. उसमें से ले लो. नहीं. ओके,
सब हीरोइंस के नाम धीरे धीरे ले लेंगे लोग.
क्लोज्ड. इट इज अ देवश्री रॉय. 3 चांस बहुत हो गए ना. ओके, नाउ सीरियस. ओके, पहला हो साइड रूम में फोटो में थी वो कोरस में गा रही थी वो. Who has given, seriously, who has given the motto of Jai Jawan, Jai Kisan, Jai Vidyan? सीरियसली पैसा ले, 100 रुपए ले उनसे. हाँ, अटल बिहारी वाजपेयी. परफेक्ट. चलो. हाँ, और सर दिखाओ लैपटॉप बैग. ये Okay, now little complicated questions. It has 4 components. Bag एक ही मिलेंगी. Which is the country who has 3 capital cities? बोल मत ना यार. हाँ सर. ऑस्ट्रेलिया नहीं, 100 रुपए लो सर. Yes. Who? 100 रुपए ले ले, बाकी आंसर नहीं है. हाँ. Perfect. South Africa is right answer. Now tell me names of all these three capitals. हाँ sir. हाँ? नहीं. हाँ. नाही. एकच बरोबर आहे त्याचं आणि बाकी दोन्ही चुकले. जोनबस नहीं है सर, सबको ना बोला मैंने. हाँ. यस. केप टाउन ओके. हाँ. ओके. परफेक्ट. व्हाट्सएप पे देखा आपने, मोबाइल देखा, बाजू वालों को मिल सकता अगर मोबाइल देखा उसने. आपके हंसी से झुटाई दिखाई रही रे. एनीवे somebody told 3 है, उसको एक दे दो बेटा. ब्लैक शर्ट को ब्राउन बैग दे दो. Okay, tell me 2 movies who won maximum Oscar awards. Yes. आवाज बोलो. yes बोलो. black shoot. परफेक्ट. 2 बोला मैंने आपको था, वो बोल रहे हैं. हाँ. परफेक्ट. इनको दे दो. So Titanic, Lords of the Rings and Banner. These are the 3 movies who got maximum Oscar awards. कितने मिले थे? फेंक रहा है तू. हाँ, यहाँ तक ठीक है. हाँ, 26. ओके. ओके. खिलाड़ू है, हाँ खेलने वाले हैं. अच्छा, एक पहला कर लेंगे. हाँ, पहला फैसला कर लेंगे. USV Pharmaceuticals entire team to come up. USV Pharmaceutical entire team to come up. Next question. The height of the net of table tennis. Huh. Perfect. 6 inches. She deserves. There beta. Weight machines banana kai. Okay, entire team is there. Perfectly all right. We'll continue. Meanwhile, somebody to see that it's vacant or not. But we have enough bags, don't worry. परफेक्ट. मॅडमला मिळालं, गिफ्ट मिळालं मॅडम. परफेक्ट. सोपं पाहिजे की डिफिकल्ट पाहिजे? सोपं पाहिजे. व्हॉट इज द कॅपिटल ऑफ कुवैत? बोलना मैंने यार, इतना बोलने के बाद भी बोलते हो तो मैम. ठीक है, डिस्क्वालीफाई क्वेश्चन हुआ. कुवैत itself is a capital of the Kuwait. हाँ प्राइज नहीं, वो सबने आंसर दे दिया। उसने नहीं, उसने कोई दूसरा बोला। हाँ okay, little bit again. Keep your mobile in the pocket. Who was the first batsman to wear the helmet? Yes. 100 रुपए दे। हाँ 100 रुपए दे, तू 200 दे। ओके करो ना, ठीक है ना, पैनिक क्या कर रहा ना, करतो ना, उसे तो ना मला। सर आप 300 रुपए दो, मैंने बोला था सिर्फ यस बोलो, आंसर मत दो। हाँ लास्ट क्वेश्चन। डेनिस ने लेके हेलमेट डाल के बॉलिंग करेगा? मिस वाओ। हाँ ओके नहीं, ओके आंसर इज ग्रैहम एलप फ्रॉम ऑस्ट्रेलिया। बरं ठीक है, somebody was telling गावस्कर, राइट? कौन है गावस्कर? हाँ 2 गावस्कर है अपने पास। गावस्कर हैज ओनली 1 विक्टिम एज ए बॉलर। हु इज दैट बैट्समैन? जहीर इकबाल। ठीक है, जहीर इकबाल गलत है, जहीर अब्बास ठीक है, पर डिस्क्वालीफाई हो गया। इकबाल बोला उसने। वैसे तुमको नहीं मिलेगा। ओके, अपने राम देखा है ना, रामायण देखा है, अभी थोड़ा सा महाभारत देखेंगे। ओके जस्ट कॉन्सेंट्रेट। हु प्रेजेंटेड गांडीवा टू अर्जुन? अर्जुन का जो धनुष बाण था उसको, हाँ परफेक्ट, दे दे उसको, बैग दे देला, फार्मा ना, हाँ बैग दे उसको। एनीवे, वन जस्ट एक्सटेंशन ऑफ क्वेश्चन, इफ यू डोंट आंसर इट विल गो टू अ पब्लिक। कृष्णा का सारथी का नाम क्या था? कृष्ण कौन सिलाए? मैडम 100 रुपए लो, सच्ची ले, तब तक नहीं सुनेंगे। कृष्णा के सारथी का नाम बताओ। It's just collect 100 रुपए। You have to really। दारू सगा, महाभारत में दारू कहाँ थे? बट यू आर पार्शियल राइट, इट इज दारू का। ओके तो दारू का दे, साहब को दे दो। चलो वेट मशीन दे। हाँ ओके ओके नेक्स्ट। ओके, अ पर्सन फ्रॉम Abbott Vascular, Zoeb Sheikh and team. Next team is Meril Subroto, Meril's Life Sciences. Third is Rakesh Kadam from Generic. Fourth is Manjit Singh, SMT. Zoeb bhai. Okay, next question. Be prepared. मजा आ रहा है? बहुत धन्यवाद। Manjit Aja ऊपर. We are really thankful to all this pharma who have generously donated. Okay. Without asking, they didn't ask a single question. मैंने बोला मेरे को इतना चाहिए. The conference cost is 75 lakhs. Okay. The gifts are worth of delegate gifts and bag worth of 2,000 plus 1,000, 3,000. I'm not praising myself, because at least you say thanks to these people. मैं तो जो गुरु कृपा आज है बिकॉज ऑफ यू, सो आई एम रिटर्निंग टू यू. गुरु कृपा जो आज है, डॉक्टर रत्नर की जो आज है बिकॉज ऑफ यू, सो आई एम रिटर्निंग. बट these are the media, these are the persons who are behind this. Okay, so give a big hand of applause. अच्छा, आपने ज़्यादा बहुत अच्छी ताली बजाई. उसने मुझे बोला नेक्स्ट टाइम आई विल डबल द अमाउंट. राकेश कदम आला का नाही, म्हणजे झाला मेरिलचा सुब्रतो. ओके, इफ्का लॅबोरेटरी कीप द टीम रेडी, अजंता फार्मा कीप द टीम रेडी. मीनवाइल यू बी रेडी. किधर गया? ओके, you know the great people ना, इतिहास सबने पढ़ा है. I will ask a simple question. Who was the guru? गुरु कृपा है ना. Who was the guru of महात्मा गांधी जी? इधर का पहला आया. हाँ, आप बताओ. Yeah, we should. What do you think? आंसर गलत हुआ तो 100 रुपए लेना है. हाँ, आंसर गलत हुआ 100 रुपए लेना है कि नहीं लेना है? लेना है. पहला कलेक्शन ले. विनोबा भावे बाद आफ्टर गांधी ना. विनोबा अभी दे. हाँ, मैं जिसको बोलो उसका. हाँ सर. हाँ, परफेक्ट. गोपाल कृष्ण गोखले. परफेक्ट. वेट मशीन दे. ओके, अनदर क्वेश्चन, एक्सटेंशन ऑफ दिस. आप ले लो उनको. हु वॉज द गुरु ऑफ गोपाल कृष्ण गोखले? हाँ, बोला. गोपाल कृष्ण गोखले से गुरुजी कौन होते? हाँ सर. सर ये उनके पहले की बात है. हाँ, शाह साहब. जोर से बोलो. रानडे. रानडे. परफेक्ट आंसर. न्यायमूर्ति महादेव गोविंद रानडे. वेट मशीन दो. पहली बार अच्छी बात किया कुछ मेरे साथ. राम राम, जय श्री राम. चलो. ओके, एनीवे, सुभाष चंद्र बोस के गुरुजी का नाम क्या था? हाँ, बोला. सुभाष चंद्र बोसच्या गुरुजींचं नाव काय होतं? गुरुचं नाव काय होतं? हाँ, परफेक्ट. CR दास. परफेक्ट. वेट मशीन देना. ओके, इप्का टू कम अप. अजंता फार्मा, झायडस फार्मा, जस्ट कीप इट अलाइंड. इप्का नाही कोणी? मग तयार राहा म्हटलं. मग असं 3 निघून जायला पण लक्षात ठेव. पैसे घेणार मी, सत्कार पण होणार नाही. नेक्स्ट अजंता फार्मा, नेक्स्ट झायडस. ते पकड. चल ये रे. अजंता फार्मा, Zydus, yes or no? Dr. Reddy's Laboratories, Dr. Reddy's Laboratories, क्या? Ladies, अरे बाबा मेरे को भी भूख लगी, ऐसा नहीं कि तुम ही भूखे हो क्या? हाँ? और मैं सवेरे से काम कर रहा हूँ, सवेरे से आप बैठे हो, थोड़ा गरीब के क्या जान लोगे क्या? हाँ क्या बटा जायडस कौन है? रेडीज आ जाओ, ऊपर आओ ना, अकेला है? हाँ कौन सी कंपनी? रेडीज। नेक्स्ट कौन है? ओके ना, मैनकाइंड फार्मा बी हियर, माइक्रो सिप्ला एंड अल्केम बी प्लीज बी हियर। ओके चलो, रविंद्रनाथ टैगोर के गुरुजी का नाम क्या था? यस, क्या नाम? रामकृष्ण परमहंस? नो नो, रविंद्रनाथ टैगोर के गुरु का नाम क्या था? नहीं, हाँ हाँ, महात्मा गांधी और रविंद्रनाथ टैगोर का ऑलमोस्ट सेम एज है। नहीं, ओके, नो नो, हाँ नहीं, नहीं, ओके, डिस्क्वालीफाई को। दिनेश बोल। उपाध्याय? नहीं, ओके, बंकिम चंद्र चटर्जी। ओके ओके ठीक है। अभी कुछ स्लोगन्स दिए थे कुछ बड़े बड़े लोगों ने, उसके बारे में पूछूंगा मैं। एग्जाम्पल, गरीबी हटाओ बाय इंदिरा गांधी कांग्रेस, राइट, फॉर एग्जाम्पल। अभी थोड़ा डिफिकल्ट वन, वंदे मातरम। हाँ, लाल शर्ट। कौन चिल्लाया यार, प्लीज। डिस्क्वालीफाई होगा, जस्ट से यस, जोर से बोलो यस, मैंने मेरा ध्यान उधर रहेगा। हाँ ओके, बंकिम चंद्र, परफेक्ट, गुड, दे दो। ओके, सारे जहां से अच्छा हिंदुस्तान हमारा। इकबाल, मोहम्मद इकबाल, वेट मशीन दो। हाँ, अपने नेक्स्ट। मैनकाइंड, माइक्रो सिप्ला, प्लीज कीप योरसेल्फ रेडी। We'll just see there what's the situation, okay? नेक्स्ट, नहीं, मैनकाइंड, माइक्रो लैब, सिप्ला, माइक्रो देन सिप्ला, देन एल्केम। बट आई एम स्टिल सरप्राइज, माइक्रो को इतनी टालियां क्यों मिली? हाँ, बिकॉज माइक्रो है इसलिए, माइक्रो नहीं. नेक्स्ट क्या है? सिप्ला. उसके बाद का क्वेश्चन बोल के रखता हूं. अरे अरे मैं ऐसे बोल के रखता हूं, बोल रहा हूं क्या मैं? हाँ? मैं नेक्स्ट क्वेश्चन तैयार रहेगा. अल्केम. देन ओके, वेरी गुड क्वेश्चन. सरफरोशी की तमन्ना आज हमारे दिल में है. हाँ, अरे थामा ना आप. हाँ, बोलना जोरों से. इधर आ. क्या नाम क्या है? भगत सिंह. 100 रुपये ले पटका आए तो सच्ची सच्ची. हाँ मैडम मैडम. हाँ 100 रुपये. मैंने पहली बार 100 रुपये बांटने के लिए इतनी उत्सुकता देखी है. गुड, ऐसा कीप इट अप. नेक्स्ट. हाँ अभी बोलो आप. हाँ दोनों सामने आओ. हाँ सॉरी. हाँ क्या नाम? बिस्मिल्ला अजीबा बादी. ओके कलेक्ट कर. हाँ राम प्रसाद बिस्मिल. परफेक्ट आंसर. परफेक्ट. डर के क्यों भाग रहा क्यों? 100 रुपये नहीं. आंसर अच्छा है, ले ले बेटा. ये ध्यान समर्थन देना. ओके टोरेंट को लास्ट लिखते हैं अपन. मैक्लॉइड्स, ल्यूपिन, सन, एरिस एंड बायर. कौन आ रहा है? मैक्लॉइड्स. यस. मैक्लॉइड्स, ल्यूपिन, सन, एरिस एंड बायर.
Lupin Pharmaceuticals. Sun Pharma. Sun Pharma. हा हो ते येत आहे क्वेश्चन घेत आले ना ते लाल लाल
नेक्स्ट कौन है नेक्स्ट कौन आहे बोल ना सन फार्मा झालं ना एरिस बायर फार्मा वर्क्यू वाला हाँ है ना एरिस उसके पहले एरिस और कोई बाकी है ओके थोडा सोपा हा पण चिल्लाव डोंट आन्सर द क्वेश्चन हा सिर्फ येस बोलो मराठीत आहे मी टरफले उचलणार नाही हा येस ने हा हा बरोबर हा परफेक्ट लोकमान्य टिळक सोपं होतं ओके आता लिटल बिट डिफिकल्ट back there. Okay, now some people has formed some sanstha, है ना, some institution. For example, Acumentis and last Torrent. I am keeping last Torrent because they are the first to help me in a huge way. That's why I am keeping them last. है ना? Okay. Okay. How much is them? So, Glenmark. Acumentis, Glenmark and Torrent. Just keep yourself ready. Okay. सब तैयार रहो. So, for example, Abhinav Bharat Sangatna was formed by Savarkar ji. Example बता रहा हूँ. Now, question is, Muslim League is formed by. ये सच्ची में पैसा लेने वाला भैया 100 रुपए कितना कमाया होता था मेरा अगर पैसे लेता था ना सच्ची ना क्या 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 नहीं आंसर इज नवाब समीउल्लाह खान ठीक है यार कीप रेडी नेक्स्ट क्वेश्चन
ग्लेनमार्क झालं ना. अलेम्बिक फार्मा. जातो तसा तिकडे जा पटकन. राकेश. मिस्टर राकेश कदम, जिनोट्रॉनिक्स. झाले ना सर आता टोरेंट.
And last but not the least, ते मराठी नाटक असतं ना, आणि काशीनाथ घाणेकर, राइट, लाइक दैट. लास्ट बट नॉट द लीस्ट, मेरे अजीज दोस्तों का ग्रुप टोरेंट. कितने मात्रे साहब, जून पिक्चर का स्टूडियो इनके ऊपर ही किया था. आणखी एक राहिला आहे, फार्मा आणखी एक राहिला आहे. अच्छा, खाली हो गया वो. ओके, सो डियर फ्रेंड, थैंक यू वेरी मच. अगर वहाँ खाली है तो क्या खाली हो गया वहाँ? हाँ, तुला भूक लगली? लास्ट क्वेश्चन. ओके, फाइन. फॉरवर्ड ब्लॉक वॉज फॉर्म बाय. हाँ, सुभाष चंद्र बोस. बरोबर है, परफेक्ट. ये दो पहली बार मिल रहा ना. हाँ, सेकंड नहीं मिलने वाला, पर ठीक है, दे दे बेचारे को. तुला काय मिळालं? वेट मशीन मिळालं की बॅग मिळाली? वेट मशीन दे दो उसको. ओके, सिंपल. नेक्स्ट क्वेश्चन. हमाल पंचायत इज फॉर्म बाय. हमाल पंचायत इज फॉर्म बाय बाबा आढव. हरिजन सेवक संघ इज फॉर्म बाय. परफेक्ट. सॉरी. कोणी राहिलं फार्मा प्लीज सांगा. हा, चुकून एक बार चक्कर मार बागे. झालं ना, पण दिलं त्यांचे पण बनवायचे लक्षात. ओके, लिटिल बिट डिफिकल्ट क्वेश्चन. एव्हरीबडी नोज बीजेपी, एव्हरीबडी नोज काँग्रेस. हु वॉज द जनक, म्हणजे भारतीय राष्ट्रीय काँग्रेसचे जनक कोण? हां पहिले हो. हां हां मॅडम परफेक्ट. A.O. Humes परफेक्ट. वेग मध्ये ओके वहाँ का सिचुएशन बता. भारतीय धवल क्रांतीचे जनक कोण? परफेक्ट. डॉक्टर वर्गीस कुरियन. वो ब्लू शर्ट, डार्क ब्लू शर्ट,
डार्क ब्लू शर्ट,
डार्क ब्लू शर्ट,
डार्क ब्लू शर्ट,
डार्क ब्लू शर्ट.
ब्लू शर्ट, डार्क ब्लू शर्ट.
डरा दिया आपने. डरा दिया ना. वो डायलॉग था ना, घुसता ही चला जा रहा है ना. कौन सा पिक्चर? घुसता ही चला जा रहा है. हाँ? कोणाचा? हां नाव ओके. भारतीय चित्रपट सृष्टीजनक आहेत दादासाहेब फाळके. ओके आणि आपल्यासोबत एक मराठी हिरोईन बाकी आहे, त्यांचा आपण सत्कार करूया. आणि आपली दुसरी हिरोईन स्मिता पाटील त्याचं इंट्रोडक्शन देईल प्लीज.
Dipti Ketkar is the most popular Marathi film and TV actress. She has achieved PhD in Bharatnatyam from being a child actress. Marathi actress, she had success graph which has reached stratospheric level. Her films are all hits. Example are Pawan Khind, Sher Shivaji, Sapda. Her popular TV serials are Kamla, Mala Sasu Havi, हम तो तेरे आशिक है, अबोल प्रेमाची अजब कहानी. She received an award for this serial and she's received multiple awards since last 5 years. Please welcome Dipti Ketkar.
गर्दी आहे नाही जाऊ शकतो. एनिवे हु इज अ राईट नाव सुपरस्टार ऑफ मराठी पिक्चर्स? अशोक सराफ. ओके नाही हु नाही गेले ना बिचारे स्वर्गीय दालताकडे. अशोक सराफ राईट. यू वॉन्ट टू मीट हिम टुडे? यू वॉन्ट टू मीट हिम? ठीक है एक करो सब अंदर चाहिए मुझे. No crowd should be outside. If such a big personality comes in the hall, we don't want empty hall. आपकी इच्छा पूरी करता हूं मैं. ठीक है खाना खाओ. You'll get the superstar Marathi picture also. Don't worry. खाना खाओ मस्त पैकी. ज्यादा मत खाओ क्योंकि लेक्चर में सुनोगे सो जाओगे.
हाँ हाँ मेरा लास्ट चलेगा सब लास्ट पब्लिक से एक्सेस सब हाँ हाँ एग्जिट कर देता हूँ यहाँ का ये हाँ जहाँ पे हाँ ठीक है कल तो मैसूर जा रहा हूँ ओके ओके ठीक है मेरा हर हफ्ते चालू रहता है मेरे को कार देना
Hello.
दीपाली कुठे आहे ना? झाल्यावर मग आता काय नाही, दीपाली. तहान भूक हरपावी असं व्यक्तिमत्व आपल्यामध्ये आलेलं आहे. सुपरस्टार अशोक सराफ. मी दीपाली काटेला विनंती करते गणेश वंदना करून त्यांचं स्वागत करावं. दीपाली.
Thank you, Dr. Smita. May I request you all to please stand up for Ganesh Vandana. गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि. धन्यवाद. कृपया स्थानापन्न व्हावे.
थँक्यू दीपाली. दीपालीला ऐकणं नेहमीच आपल्यासाठी आनंददायी अनुभव असतो. आता मी स्टेजवर उपस्थित मान्यवरांना दीप प्रज्वलनासाठी विनंती करते. अशोक सराफ सर, जी पी रत्नपारखी सर, प्रवीण सोनी सर, विशाल कडणे सर, डॉक्टर राम चव्हाण, प्रेसिडेंट MCVP, डॉक्टर शशांक सर, MCVP MA, डॉक्टर अशोक सिंग.
शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदं
धनंजय माने इथेच राहतात का? नाही, ते आपल्या मनात राहतात. बनवा बनवी मधला धनंजय माने, गुपचूप मधला प्रोफेसर धोंड, एक डाव भूताचा मधलं प्रेमळ भूत, रामराम गंगारामचा ममद्या, पांडू हवालदारचा हवालदार आणि धूमधडाका मधला उद्योगपती यदुनाथ जवळकर. हे आणि असे असंख्य रोल्स निभावून आपल्या सर्वांच्या मनावर राज्य करणारा एकच मराठी कलाकार अशोक सराफ. अशोक सराफ म्हणजे मराठी मनावर कोरलेली सोनेरी अक्षरं. निखळ मनोरंजन, सहज अभिनय, परफेक्ट टायमिंग, अप्रतिम बॉडी लँग्वेज, जबरदस्त शब्दफेक असा हा अष्टपैलू सच्चा कलाकार. विनोदी, आनंदी, करुण, खलनायकी, बालिश, बेरक्या, भूमिका कोणतीही असो त्या भूमिकेचं सोनं करण्याचं काम हे सराफ शिताफीनं करतात. आभाळा एवढ्या यशानंतरही कसं नम्र राहावं हेही शिकवून जातात. या जगात, खरोखर या जगात एकही मराठी माणूस नसेल की ज्याने या मामावर प्रेम केलं नाही. कारण प्रत्येकाच्या आयुष्यात प्रेम पेरण्यासाठीच मामा असतो. आणि कॅमेरामननी एका शूटिंगच्या वेळी एका कॅमेरामनच्या मुलीनी यांना मामा म्हणायला सुरुवात केली आणि हे सर्वांचे मामा झाले. 4 जून 1947 साली मुंबईत जन्माला आलेले अशोक सराफ यांना खरं तर घरातून नट बनण्याला विरोध होता. थोडे वर्ष बँकेत नोकरी देखील केली, पण आतला कलाकार काही गप्प बसू देईना आणि त्यांनी शेवटी निश्चय केला की मी जे काही करेन ते अभिनय क्षेत्रातच करेन. वयाच्या 18व्या वर्षी ययाती आणि देवयानी या नाटकात सर्वप्रथम विदूषकाची भूमिका साकारली आणि त्यानंतर अनेक संगीत नाटकं केली. 1971 साली दोन्ही घरचा पाहुणा या सिनेमानंतर आजपर्यंत त्यांच्या चित्रपट कारकिर्दीची यशस्वी वाटचाल चालूच आहे. 226 मराठी चित्रपट, कोयला, करण अर्जुन, सिंघम असे अनेक हिंदी चित्रपट, 5 नाटकं, 8 मालिका, त्यातली हम 5 मालिका पाहिलं नाही असं कुणीही नसेल. आज तागायत त्यांना 5 फिल्मफेअर अवॉर्ड्स आणि 10 महाराष्ट्र स्टेट फिल्म्स अवॉर्ड्स मिळालेली आहेत. महाराष्ट्र शासनाकडून दिला जाणारा सर्वात मोठा पुरस्कार म्हणजे महाराष्ट्र भूषण पुरस्कार. आजपर्यंत हा पुरस्कार पु ल देशपांडे, भीमसेन जोशी, बाबासाहेब पुरंदरे, लता दीदी, आशाताई, सचिन तेंडुलकर अशा दिग्गजांना मिळाला आणि 2023 साली तो आपल्या कलेच्या बादशाहला मिळाला म्हणजे अशोक सराफ यांना. 50 वर्ष केलेल्या कलेच्या आणि रसिकांच्या सेवेचं चीज झालं असं सांगतात. एकदा स्मशानभूमीमध्ये मामांच्या फिल्मचं शूटिंग चालू होतं. त्यावेळी आपापल्या आत्तस्वकीयांची कार्य सोडून लोकांनी यांना बघायला गर्दी केली. लोकप्रियतेचं याच्यापेक्षा जास्त मोजमाप काय असू शकतं. दिसताना अत्यंत सिरियस, गंभीर दिसणाऱ्या कलाकारामध्ये रिदम अगदी मुरलेला आहे. आठवा त्यांची गाणी आणि त्यांनी केलेली नृत्य. मग मंगला हो मंगला, अश्विनी येना, हृदयी वसंत फुलताना, अगं नाच 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 रागे अशी कितीतरी गाणी आणि त्याच्यावर नृत्य करणारे अशोक सराफ आपल्या हृदयात घर करून राहतात. 4 पिढ्या एकत्र राहून ज्यांचा सिनेमा निखळपणे पाहू शकतात असा हा कलाकार. आमच्यासाठी तर आमचं बालपण म्हणजे काय तर शनिवारी ब्लॅक अँड व्हाईट TV वर दूरदर्शनवर लागणारा अशोक सराफ यांचा सिनेमा आणि त्यांचे विनोद आठवून हसत हसत घालवलेला रविवार. आनंद आनंद म्हणजे अशोक सराफ यांना पडद्यावर पाहणे. आमचं बालपण, तारुण्य आनंदमयी आणि अविस्मरणीय करणारे अशोक मामा. यांच्या चित्रपटांची नुसती नावं आठवून पहा, चेहऱ्यावर हसू फुलणार याची 100% गॅरंटी. अशोक सराफ हे मराठीतलं 100 नंबरी सोनं. मी तर असं म्हणते, साऊथला रजनीकांत असेल, बॉलिवूडमध्ये अमिताभ असेल, तर आमच्याकडे त्याच्या तोडीस तोड अभिनयाचा बादशाह आहे अशोक सराफ. मी GPR सर, स्मृती मॅडम, अशोक सिंग, शशांक सर आणि राम चव्हाण यांना विनंती करते की अशोक सराफ यांचं फेलिसिटेशन करावं. यांचा सत्कार करणं हा सुद्धा आपल्यासाठी एक मानाचा. गणपती बाप्पा मंगल मूर्ती. I also request GPR sir, Shruti ma'am to felicitate Dr. Praveen Soni sir with Ashok Singh, Dr. Shashank Shah and Dr. Ram Chavan. आज आपल्यामध्ये आहेत डॉक्टर विशाल कडणे सर. 200हून अधिक हॉस्पिटल्सच्या फॉर्म नोंदणी, फायर कॉम्प्लायन्स, फायर NOC यासारख्या महत्त्वाच्या प्रकरणामध्ये मुंबई महानगरपालिका क्षेत्रात प्रत्येक प्रकरण निकाली लावणारं अग्रेसर नाव म्हणजे डॉक्टर विशाल कडणे. सिव्हिल इंजिनियर क्षेत्रात प्रावीण्य मिळवून लायसन्सिंग आर्किटेक्ट, स्ट्रक्चरल ऑडिट, विकासक आणि इमारत बांधकाम व्यवसायात अल्पावधीत मोठे झालेलं नाव म्हणजे डॉक्टर विशाल कडणे. आशिया खंडातील सर्वात श्रीमंत हाऊसिंग फेडरेशनचे तज्ज्ञ व तरुण संचालक म्हणजे डॉक्टर विशाल कडणे आणि लोकमत दी चेंज मेकर 23 या पुरस्काराचे मानकरी डॉक्टर विशाल कडणे. स्वागत करूया डॉक्टर विशाल कडणे यांचे. आणि मी रत्नपारखी सर, मॅडम आणि AMA MCVP प्रेसिडेंट राम चव्हाण या सर्वांना त्यांचं फेलिसिटेशन करायची विनंती करते. पुढच्या कार्डिओकॉन पर्यंत आमदार विशाल कडणे असं बोलावं लागलं तर त्यात नवल नाही. Now I request our chief guest Ashok Saraf sir to felicitate few members, Dr. Rajesh Tiwari and Dr. Seema Tiwari, Secretary MCVP and Treasurer Andheri Medical Association. The hard-working couple of both associations. Dr. Dheeraj Jhumbar sir and Dr. Poonam Solanki.
नाही मी घेतो.
तुमच्या टाळ्या कमी वाटत नाही असं वाटतं का? या सर्व लोकांनी लास्ट 2 महिने राबली बिचारी. कॉफर मार्केट जा, हे कर, इकडे जा, तिकडे जा, तर काही अपेक्षा नाही त्यांच्या, फक्त काही टाळ्या. ठीक आहे.
थँक्यू सर. हो मी हो. थँक्यू. ज्या आपल्या आवडत्या निवेदिका, मला तर वाटतं डॉक्टर चुकून झाल्या, डॉक्टर स्मिता पाटील, त्याने खरोखर दूरदर्शनवर निवेदिका म्हणून व्हायला पाहिजे होतं. अशा आपल्या डॉक्टर स्मिता पाटील आणि समीर पाटील यांचं सत्कार अशोक सराफ सर करतील. अरे टाळ्या वाजवा. डॉक्टर स्मिता पाटील प्रत्येक तासाला त्यांच्या रील्स असतात फेसबुक इंस्टाग्रामवर आणि त्यांना लाखो लाईक्स मिळतात. अशा आपल्या लाडक्या स्मिता पाटील आज आपल्या निवेदिका भेटल्यात, त्याबद्दल मी गुरुकृपा हार्ट फाउंडेशनतर्फे त्यांचं धन्यवाद देतो आणि त्यांना भावी आयुष्यासाठी शुभेच्छा देतो की आपल्यामधून कोणीतरी रील्स बनवणारा डॉक्टर्स आहेत. अशा आमच्या डॉक्टर स्मिता पाटील. AMAच्या ज्ञान कोकिळा डॉक्टर दीपाली काटे आणि डॉक्टर गजानन काटे यांना मी मंचावर बोलवतो. सराफ सराने त्यांचं सत्कार करावं. मी रिक्वेस्ट करतो डॉक्टर सुनील परांजपे सर, जे विलेपार्ले ईस्टमध्ये फेमस सर्जन आणि क्रिटिकेअरमध्ये प्रॅक्टिस करतात, त्यांचं गुरुकृपा हार्ट फाउंडेशनतर्फे ॲज अ गेस्ट ऑफ ऑनर म्हणून आम्ही सत्कार करतो. आणि सत्कार मूर्ती आजचे आमचे आवडते कलाकार, हा माझा बायको फेम अशोक सराफ करतील. आणि एक साडू दुसऱ्या साडूला सत्कार करतायत. मतलब एक साडू लूटा और दूसरा भी साडू लूटा एक ब्रांड से. ऐसे डॉक्टर परांजपे सर आणि अशोक सराफ सर, हाँ हे साडू भाऊ आहेत. कहना ये चाहते हैं कि एक ब्रांड के दो फंसे हुए ग्राहक.
डॉक्टर संजीव पाटिल एंड डॉक्टर वृंदा पाटिल. डॉक्टर पार्थिव संघवी एंड डॉक्टर जागृति संघवी. जेवण जास्त झालंय का झोप आलीये काही कळत नाहीये. डॉक्टर पार्थिव एंड डॉक्टर जागृति संघवी. डॉक्टर सुहास वोरा एंड डॉक्टर प्राची वोरा. डॉक्टर प्राची एंड डॉक्टर सुहास वोरा सर. डॉक्टर प्रियमवदा शर्मा. मोर्या. मंगल मूर्ति. डॉक्टर प्रियमवदा शर्मा. Dr. Sharad Dadich sir. है ना. Dr. Sharad Dadich sir, Treasurer, MCVP. Dr. Sharad Dadich sir. अजून खूप आहे. Dr. Prabodh Mamtora sir and Dr. Neeta Mamtora madam.
हे बोलतील मग सरांचं
काय झालं
हे झाल्यावर इकडे झालं हे येतील
हे पण मीच बोलायचे ना हे मी बोलायचे ना
इथपर्यंत तुम्ही बोलायचं
हां हां मग
ह्यांना द्यायचं थांबा
Mamtora sir बोले ना नीता मैम एंड डॉक्टर प्रबोध मामतोरा सर नहीं आए वो मैं क्या करेगी डॉक्टर मोना एंड डॉक्टर HP गांधी
आम्ही अजून 2 बंपर प्राइज करणार आहोत त्यामुळे जोराने टाळ्या झाल्या पाहिजे
डॉक्टर रुचा रत्न पारखी हम आदि डॉक्टर मोना एंड डॉक्टर HP रुचा नाही ऐका तुम्ही इकडे त्याच्यासाठीच रुचा
नाही होणार तशी
आहे म्हणूनच तर त्या नावमध्ये आलं
मला माहिती आहे की तुम्हाला माहिती आहे
तुम्ही दिलेली लिस्ट प्रमाणे माझं वर खाली झालं ऐका जरा ऐका बघा डॉक्टर रुचा रत्न पारखी हाँ मग मी तेच म्हणते माझ्याकडे बरोबर म्हणून तर मी काल एवढं वो देखो ना मुझे कन्फ्यूज कैसा उल्टा नहीं नहीं डॉक्टर राजेश एंड डॉक्टर स्मिता घाटकर सांगून ठेवते सर तयार तयार रहा थांबा 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 तयार रहा हां तर लोक तयार राहायला पाहिजेत लोक सर ने नहीं सर ने लिस्ट में किधर भी नाम नहीं बोले हाँ लेकिन हाँ कौन चल रहा है उधर कौन चल रहा है अच्छा ना डॉक्टर राजेश एंड डॉक्टर स्मिता घाटकर मैं है निवेदिका Dr. Sanjay Ratnaparkhi and Mrs. Sadhna Ratnaparkhi. कडणे सरांना बोलवा. कडणे सर. त्यांना काय श्री विजय कडणे. श्रीयुत राजेंद्र थेराडे.
So this is the time now to announce the special award to Dr. G.P. Ratnaparkhi sir. The award is given to the outstanding contribution in the medical field, and the award is presented by the Gandhi Global Family, Jammu and Kashmir. So I would like to call upon the Padma Shri Dr. S.P. Sharma Saab to come on to the stage to present the award to Dr. GPR sir, along with the yes. Yeah. So मैं रिक्वेस्ट करूंगा डॉक्टर एसपी वर्मा साहब को, जो पद्मश्री हैं, जीपीआर रत्नपारखी सर को राष्ट्रीय सेवा पुरस्कार 2024 से सम्मानित करें. With the grace hands of the Marathi actor Ashok Saraf sir. महात्मा गांधी राष्ट्रीय सेवा पुरस्कार 2024, ये अवार्ड फॉरेन एम्बेसी के कई लोगों को दिया जा चुका है, जो आज आपके सम्मुख डॉक्टर जीपीआर सर को ये दिया जा रहा है. सो दिस इज द वेरी ऑनरस अवार्ड टू द आउटस्टैंडिंग कंट्रीब्यूशन इन द मेडिकल फील्ड. And also I would like to give this special gratitude to the Dr. SP वर्मा साहब, जिन्होंने इस साल का बहुत मेहनत के बाद डॉक्टर साहब डॉक्टर जीपीआर सर के लिए पद्मश्री के लिए नॉमिनेट किया है. सो बाय द ग्रेस ऑफ गॉड हम ये आने वाले कुछ दिनों में देखेंगे कि डॉक्टर जीपीआर सर भी पद्मश्री कहलाएंगे.
SP वर्मा साहेबांना पद्मश्री मिळाले आहे, कारण त्यांनी टेररिस्ट हिट एरियामध्ये समाजकार्य केलं आहे. कितीदा तरी गोळ्यांच्या आवाजामध्ये त्यांनी समाजकार्य केलं आहे. गिव्ह अ बिग हँड. आणि ही फ्रॉम गांधी 3दा गोळ्या लागतात मरता मरता वाचले आहे ते 3 टाइम्स, लक्षात ठेवा. तर उगाच पद्मश्री अशी नाही मिळाली आहे ना. ठीक आहे.
स्मरणिकेचे काय नाव?
Dr. Dicosta, President of Cyber Security Corporation.
बोला ना. एक जरी चुकलं तर मग.
I would like to call upon next Dr. Herald Dicosta, the President Cyber Security Corporation Pune, to receive the felicitation with the grace hands of Ashok Sarabji and Dr. GPR sir. Please. Dr. Herald Dicosta sir. I would like to request Dr. GPR sir and Ashok Sarab sir to felicitate Dr. Herald Dicosta. हाँ ठीक है ना. Next, I would like to call upon Dr. Vijay Vadai sir, the Vice Chancellor of Political College of Engineering, Nagpur, and request GPR sir and Ashok Sarab sir to felicitate Dr. Vijay Vadai sir.
श्री विजय कडणे. कुठे आहेत ते? फादर ऑफ डॉक्टर विशाल कडणे सर. श्री विजय कडणे सर. सर राव. चेहरा देखते लोग, ऐसा मत करो, चेहरा सब देखते हैं. अपने तरफ ध्यान रखो. नहीं, उधर से अलग है. लोग देखते हैं ना. आता मी माननीय अशोक सराफ यांना विनंती करते की त्यांनी गुरुकृपा हार्ट फाउंडेशनच्या स्मरणिकेचे प्रकाशन करावे. सोव्हिनियर ऑफ गुरुकृपा हार्ट फाउंडेशन अँड चॅरिटेबल ट्रस्ट.
या सेव्हनमध्ये लास्ट 11 वर्षात जे काही आपण कामं केले आहेत ते सर्व प्रिंट झालेले आहे. धन्यवाद.
मान्यवरांनी प्लीज बसून घ्यावे. आणि ज्या गोष्टीची आपण वाट पाहत आहोत, मी अशोक सराफ सर यांना विनंती करते की त्यांनी 4 शब्द बोलावेत.
नमस्कार. अरे वा, नमस्कार. नमस्कार. बस बस बस. हे 4 शब्द बोलायचे म्हटले की धडकी भरते हो एकदम. निश्चितपणे काय बोलावं तेच कळत नाही. मला वाटतंय तो तोंडातच घालतोय. तुम्हा लोकांना बघितलं ना की मला खरंच घाबरल्यासारखं होतं. कारण हे डॉक्टर्स लोक सगळे म्हणजे थोडं आम्ही दचकूनच असतो. पण आज फार छान सोहळा हा, दिमागदार झाला असं मी म्हणेन. तुम्ही हे जे काय लोकांचं कौतुक करता हे नेहमी त्यांच्याही लक्षात राहील आणि त्यांच्यासाठी फार महत्त्वाचं असतं असं मला वाटतं. मी पण एक तुमच्या कामात थोडीशी मदत केलेली आहे एकदा. म्हणजे मी एक फिल्म केली होती लाईफलाईन, आणि त्या लाईफलाईनमध्ये मी डॉक्टरचा रोल केला होता. वाटत नाही तसं पण केला होता. आणि तो डॉक्टर फार म्हणजे अतिशय म्हणजे एक वेगळंच काही सांगून जातो. आणि हा संदेश लोकांपर्यंत पोचवण्याचं त्याचं काम होतं. आणि हा लोकांपर्यंत पोचला असेल काही असंही मला वाटतं. अवयवदान या सब्जेक्टवर तो पिक्चर होता. आणि त्याचं महत्त्व काय आहे हे तो डॉक्टर सगळ्यांना पटवून सांगतो. मला कुठेतरी बरं वाटलं की शिक्षणात का होईना पण अशा रीतीने तरी डॉक्टरांची बरोबरी साधता आली. आज तुम्ही इथे मला बोलून जो माझा सत्कार केलात, मला एवढा मान दिलात, त्याबद्दल मी कायम ऋणी राहीन तुम्हा लोकांचा. ही खरं म्हणजे न विसरण्यासारखीच गोष्ट आहे माझ्या दृष्टीनं. मला नुसतं निरोप मिळाला की तुमचं हे असं आहे, इकडे तुम्ही हा प्रोग्राम करणार आहात. आत्ता मी लोणावळ्यावरून आलो इथे. आणि थोड्या वेळाने परत लोणावळ्याला जाणार आहे, कारण माझं तिकडे शूटिंग चालू आहे. शूटिंग चालू असताना मध्येच मी हा एक प्रोग्राम उरकून घेतलेला आहे. का? डॉक्टरांसाठी एक अत्यंत जिव्हाळाचा विषय माझ्या दृष्टीने तरी. कारण माझ्या दृष्टीने तरी माझ्या माहितीप्रमाणे जेव्हा जेव्हा मला मदत लागली तेव्हा तेव्हा डॉक्टर माझ्या मदतीला धावून आलेले आहेत. आणि एकतर म्हणजे आमचे साडू साहेब स्वतःच डॉक्टर आहेत. डॉक्टर सुनील परांजपे. त्यामुळे मला घरचाच तो डॉक्टर असल्यामुळे जरा बरं वाटतंय. प्रॉब्लेम येत नाही हो काय. बरंच काही सांगण्यासारखं आहे, पण आता मला काय सांगावं तुम्हाला हे आठवत नाही. आता माझ्याबद्दल मॅडमनी बरंच काही सांगितलं. चांगला दिसतोय त्यांचा अभ्यास एकंदरीत. त्यांनी कुठलं पुस्तक वाचलं होतं आणि काय वाचलं होतं मला माहिती आहे. बहुतेक माझंच पुस्तक वाचलं असेल. अच्छा, म्हणजे त्यांनी पुस्तक नाही वाचलं. पुस्तक वाचलं असं तुम्हाला बरंच काय सापडलं असतं आणखी, पण हरकत नाही. त्यांनी जे सांगितल्यानंतर मला असं कित्येकदा वाटलं की असं वाटलं की मी खरंच त्या म्हणतात त्याप्रमाणे आहे का. कारण ते अमुक आहेत, तमुक आहेत, तमुक आहेत, असं बरंच काय काय सांगितलं. मी म्हणतो एवढं कुठून मी आलो मला काय कळत नाही आहे. पण एकंदर तुम्हा लोकांचं प्रेम आणि जिव्हाळा लक्षात घेतलं की निश्चितच मला वाटतं मी काहीतरी केलं असेल आयुष्यात. त्यामुळे मी काहीतरी मिळवू शकलो आणि त्यामुळे मी तुमच्यासमोर उभा राहू शकलो. नाहीतर खरं म्हणजे मी इथं येण्याची आणि इथं उभं राहण्याची सुतराम शक्यता नव्हती आणि काही कारणही नव्हतं. पण मला आवडतं, मजा वाटते. एका म्हणजे असे सगळे असे मोठ्या आपल्यापेक्षा मोठे असलेले लोक आपल्याला भेटले तर नेहमीच निश्चित मजा वाटते. मलाही आता तो फील येतो आहे की काहीतरी मी केलेलं आहे, ज्या अर्थी हे लोक माझ्याबद्दल एवढं चांगलं बोलतात आणि हे लोक माझ्यासाठी काहीतरी करतात. मला एवढंच म्हणायचं की जास्ती काय म्हणायचं नाही, पण हे कायम ठेवा तुम्ही खरंच माझ्या दृष्टीने, मला माझ्यावर तरी. कारण माझं आणि तुमचं नातं हे असंच अतूट राहिलं पाहिजे असं मला वाटतं. मी जास्ती काही बोलणार नाही, पण एवढंच म्हणेन की तुम्ही जे मला बोलून माझं कौतुक केलं किंवा माझ्याबद्दल 4 शब्द बोललात चांगले, माझा आणखी हुरूप वाढलेला आहे. की आम्हा आर्टिस्ट लोकांचं हे असंच असतं की तुम्ही जेवढं कौतुक कराल तेवढं ते जास्ती त्यांना हुरूप येतो, उत्साह येतो, नवीन काहीतरी करण्याची त्यांच्यात इच्छा तयार होते. आम्हा आपल्या सगळ्यांना एवढ्या लोकांना बघून खरंच माझा उत्साह वाढलेला आहे. कोणत्या शब्दात माझे तुमचे आभार मानू हे मला काही कळत नाही आहे आणि खरं म्हणजे मी आभार मानणारही नाही आहे. कारण शेवटी तुम्ही लोक हे माझेच आहात आणि मी तुमचाच आहे. तुम्ही जो आम्हाला मान दिलात आम्ही कधीही विसरू शकणार नाही, कायम माझ्या लक्षात राहील. धन्यवाद, मनापासून धन्यवाद. निरनिराळ्या विषयात ते डॉक्टर मी ऐकले होते. हा हसवणारा डॉक्टर मी पहिल्यांदाच ऐकतोय. काय हरकत नाही, ती काही डिग्री असेल तर द्या मला, मी लावतो माझ्या नावामागे. मग ती निदान डिग्री बघून तर 4 लोक आणखी बघतील माझ्याकडे. हा डॉक्टर लाफ्टर स्पेशालिस्ट. अरे हो वा. पण ते लाफ्टर स्पेशालिस्टने होत नाही हो, त्यांना वाटतं हा जोकर असेल म्हणून. तसं नाही, ते काहीतरी जशी भारदस्तही पाहिजे त्याला. बरं काय तुम्ही डायलॉग काय असतं माहिती आहे, डायलॉग हे ना आम्ही तेव्हा वाचलेले असतात आणि नंतर आम्ही विसरून जातो. खरं म्हणजे लक्षात ठेवतात ते हे लोक. तर माझ्यापेक्षा तुम्ही ह्यांनाच म्हणायला सांगा, या म्हणतात बघा. कारण माझे असे कितीतरी आहेत डायलॉग, कुठले सांगू आता मी तुम्हाला सांगा. बघा बघा यांनाच सगळं माहिती आहे. आता मी काय सांगू, तुम्ही सगळे एकत्र जमून आपापसाच हे भरवा आणि तुम्ही एकमेकांना हे प्रोग्राम सादर करा, बघ मजा येईल. कारण मला आठवण करून देणार मग मी बोलण्यात यात काय मजा नाही हो, नाही का. बरं काय होतं, दुसरी गोष्ट म्हणजे हे आम्ही जेव्हा डायलॉग बोलतो ना त्यावेळेला आम्हाला पैसे मिळतात हो. माझी गोष्ट सोडून द्या, पण असे बरेच नट आहेत पैशाशिवाय तोंडच उघडत नाहीत. मी तोंड उघडलंय. पण काय आहे आता बघा, आता तुम्ही ते वाक्य उखू उखू म्हणताय. मला वाटतं हे सगळ्यांना बऱ्याच जणांना माहिती आहे, तरी देखील परत परत मला विचारला जातो हा प्रश्न सगळीकडे की ते व्याख्या वेख्यू उखू काय आहे. माहिती आहे ना तुम्हाला? माहीत नाही तरी सांगा. हो. काय झालं, जेव्हा मी पिक्चर करत होतो आम्ही धूमधडाका, आणि धूमधडाका जेव्हा करतो तेव्हा मी त्यातला हिरोचा मित्र असतो, तो बापाचं सोंग घेऊन येतो आणि बापाचा कुशल सगळं वावरतो. तर त्या बापाला त्याला असं हे द्यायली होती, पाईप ओढायला दिला होता. पाईप, आता पाईपमध्ये जो तंबाखू असतो हा सिगरेटच्या तंबाखूसारखा सॉफ्ट नसतो, हार्ड असतो. हार्ड हे मला माहीत नव्हतं. आणि मी असं गाडीतून असं उतरतो आणि समोर बघतो तो त्या हिरोचा बाप उभा असतो, हिरोईनचा बाप, आणि तो झाडाला पाणी घालतो. त्याला वाटतो हा माळी येतो. तो येतो तिकडे हातात पाईप घेऊन म्हणतो, ओ माळी बुवा, हे अमुक मऊ इथेच राहतात का, एवढं वाक्य. तर मी माळी बुवा म्हटल्यावर मला इनेल केला मी चुकून आणि घशात बसले आणि असा खोकला आला एकदम. तर म्हटलं कट 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 परत 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 काय झालं, खोकला आला. तो हार्ड तो तंबाखू एवढा त्रास द्यायला लागला, तर मी शेवटी त्याचाच एक मॅनरिझम बनवला की तो असं बोलताना त्याला प्रत्येक वेळेला बोलताना खोकला येतो. तो हे ओढवताना काय माळू बुवा, धनंजयराव वाकडे इथेच राहतात का, असं तर दमुक अमुक वाकडे असं. आणि शेवटी सगळं अख्खं वाक्याच्या वाक्य मी त्याच्यातून कन्वे करत बसलो की सगळं बरं. मला माहीत नव्हतं एवढं पॉप्युलर होईल म्हणून, पण त्या त्या कॅरेक्टर कुठल्या या नुसती एका मॅनेजरने कुठे गेली असं असतं ते. पण ते काय त्या वेळेचं असतं, हे ते आपण काय ते ठरवून केलेलं नसतं, अचानक सुचेल असंच. झाडू घेऊन बरोबर, झाडू यांना का आठवलं मला कळलेलं नाहीये. तुम्हाला दिला होता? पण आमच्या ह्याच्यामध्ये उलटच झालं होतं. ती झाडू घेऊन माझ्या मागे लागली होती मारायला. वास्तविक ते शस्त्र त्यांचंच असतं उपयोगात आणण्यासाठी, आपण काय बोलू शकत नाही त्याच्यावर. तर आता ह्याच्यापेक्षा मी काही जास्ती सांगणार नाही, कारण तुम्हाला काय असतं, रेफरन्स असेल तर त्याचा बोध होईल, नाही तर काय बोध होणार नाही. ते उगाच सांगण्यात काय अर्थ नाही आहे. पण मी जे काय बोललो आणि मी काय जे सांगितलं हे तुम्ही ऐकून घेतलं, ते माझ्यासाठी फार महत्त्वाचं आहे. धन्यवाद. थँक्यू व्हेरी मच. थँक्यू.
थँक्यू. सगळ्यांची झोप उडाली, सगळे ताजेतवाने झाले आहेत. प्लीज बसून घ्यावे. माणसं जमवणं, माणसं जोडणं आणि अशी जमवलेली जोडलेली माणसं टिकवणं हे काही येऱ्या गबाळ्याचं काम नाही. कारण त्यासाठी लागतो प्रेमळ स्वभाव, मदतशील वृत्ती आणि हृदयात सदैव वाहणारा माणुसकीचा झरा. हे सगळं मी बोलते कारण गेली 7 वर्ष दरवर्षी या कार्डिओकॉनमध्ये 700, 800 आणि आता 1000 डॉक्टर्स एका माणसामुळे एका छताखाली एकत्र येतात. वर्षभर या दिवसाची वाट पाहतात. फक्त अंधेरी पार्लामधून नाही तर मुंबईच्या उपनगरातून आणि कधी मुंबई बाहेरून सुद्धा. आणि ही किमया करणारा किमयागार आहे डॉक्टर गजानन रत्नपारखी, आपले लाडके GPR सर. शिवाजी महाराजांची पुस्तकं वाचताना मी त्यात एक वाक्य वाचलं होतं. महाराज म्हणतात, साम्राज्य छोटं असावं पण ते स्वतःचं असावं, म्हणजे तुमचा आदर वाढतो आणि लोक तुम्हाला आयुष्यभर लक्षात ठेवतात. ते वाक्य सरांनी नक्कीच अभ्यासलं असणार, कारण त्यांनी यवतमाळहून येऊन मुंबईत स्वतःचं दणदणीत साम्राज्य स्थापन केलं. आज गुरुकृपा हार्ट फाउंडेशन आणि चॅरिटेबल ट्रस्ट अनेक अकॅडमिक सोशल ॲक्टिव्हिटीजमध्ये सक्रिय सहभाग घेऊन समाजाचे ऋण फेडत आहे. द वर्ल्ड वेअर पीपल आर बिकमिंग मोर अँड मोर सेल्फ सेंटर्ड, जिपेर सर बिलीव्स इन हेल्पिंग द पुअर अँड नीडी पीपल इन एव्हरी पॉसिबल वे. Sir has adopted 6 night schools, also is running free ambulance service for poor and needy people. 10. मी बघत होते, तुम्ही झोपलायत का जागे आहात? Behind this successful cardiologist who performs highest number of cardiac interventions in the city of Mumbai, there is a soft-hearted poet. He has published his Marathi Kavita Sangraha Dur Ghar Maze. Sir has also published a book, Prevention of Heart Disease, in Marathi, English and Gujarati. He was awarded Best Cardiologist of Mumbai by Devendra Fadnavis ji in 2017. Chief Minister Eknath Shinde Sahib also felicitated him with Abhiman Andhericha Award in 2022. He was awarded as Jogeshwari Bhushan Puraskar by MP Ravindra Vaikar Sahib. I request everyone to give Sir a standing ovation, and our chief guest will felicitate Sir and Smruti Madam. Please everyone, टाळ्यांचा आवाज चालूच राहिला पाहिजे. स्मृती मॅडम सरांच्या मागे खंबीर उभं असणारं व्यक्तिमत्व. मॅडम स्वतः एक गोल्ड मेडलिस्ट आहेत. प्रॅक्टिसेस इन अंधेरी ईस्ट सिन्स 35 years. ट्रस्टी ऑफ गुरुकृपा हार्ट फाउंडेशन अँड चॅरिटेबल ट्रस्ट. अतिशय नम्र, मितभाषी आणि मोठेपणाचा लवलेशही नसणाऱ्या आमच्या सर्वांच्या स्मृती रत्नपारखी. मोरया, मंगल मूर्ती. मी रत्नपारखी सरांना विनंती करते की 2 शब्द मनोगत व्यक्त करा. त्यांना 4, तुम्हाला 2च शब्दांची विनंती आहे. सर 2 मिनिटं बोला. काय
2 शब्द थँक्यू. पण सरांसोबत नाही बद्दल नाही बोललो तर इट विल बी इनजस्टिस. ते बिचारे खूप बिझी होते. 8-15 दिवसापासून ते आउट ऑफ इंडियामधून आले. ते थकलेले. मग लोणावळ्याला शूटिंग होतं, तर आज सकाळी शूटिंग करता 9-9:30 निघाले, आपल्याकडे आले आणि आता पुन्हा लोणावळ्यात जात आहे. अशा माणसाच्या ऋणात आम्ही राहू शकतो. थँक्यू म्हणून तुमचं ऋण आम्ही कमी करत नाही. आम्ही तुमच्या आयुष्यभर ऋणात राहू सर. आणि तुम्ही जे माझ्या या थकलेल्या, कारण थकलेल्या का सकाळी 8 वाजल्यापासून बिचारे ऐकत आहे आमचं. काय लोक काय मध्ये झोपतं पण आहे. पण तुम्हाला पाहून सर्व जागृत झाले, खुश झाले. त्यामुळे तुमचं धन्यवाद. डॉक्टर सोनी सर, हेड ऑफ डिपार्टमेंट अँड डीन आहे आमचे YCM पिंपरीचे, ते सुद्धा बिचारे दिवसभर एवढं डेंग्यू साथ चालू आहे पिंपरीला, तरी पण ते काम सोडून आपल्यासाठी इथे आले. हे सर्व आपले चीफ गेस्ट जे येतात आहे त्यांच्या ऋणात मी राहू इच्छितो. आणि ऑफकोर्स मी तुमच्या ऋणात तर नेहमीच असतो, दरवर्षी असतो. प्रत्येक वेळेस डिबेट हे कर्ज वाढत चाललं आहे. धन्यवाद.
आता आपण पुन्हा आपल्या जगात परत येऊया. अकॅडमिक फीस चालू करूया आणि अशोक सराफ सरांना मानवंदना देऊन प्रोग्राम संपवूया. इनॉग्रेशन सेरेमनी संपवूया. सर तुमचे आम्ही खूप खूप ऋणी आहोत. Our third MOC of the day, Dr. Dipali Kate. AMA Lata Mangeshkar. She is also practicing in Andheri East since more than 20 years. Dr. Dipali.
Good afternoon, everyone. I am Dr. Dipali Kate, your MOC for the final session of the conference. Let me introduce our next speaker, respected Dr. Lancelot Pinto. Dr. Pinto is a consultant respirologist at the PD Hinduja National Hospital and Medical Research Center, Mumbai. His main areas of interests are management of severe COPD, drug-resistant TB, smoking cessation therapy, and management of sleep disorders. Today he will discuss about topic snoring and its cardiovascular disease link. Please welcome Dr. Pinto on stage. Dr. Pinto.
It's the wrong set of slides. ये मेरा नहीं है. I think the earlier one. Yeah, this is fine. Good evening. I'd like to thank Dr. Ratnaparki and the organizing committee for inviting me here today. It's going to be a tough act to follow Mr. Saraf, but I'll try my best to keep everyone entertained. So the topic for this evening is that snoring is not just a habit, it is a disease. And I think we are realizing more and more the relevance of snoring. A lot of us traditionally used to think that a person who snores loudly is enjoying good sleep. बहुत गहरी नींद में सो रहा है वो, it's good, everyone was happy about snoring. But I think there is a growing realization that this is not something that we should take lightly. So over the next half an hour, I will cover what we know about snoring, what we know about sleep apnea. Since this is CardioCon, it's very relevant, the connections of sleep apnea to cardiovascular disease, which are getting more and more appreciated. A brief overview as to how to test for obstructive sleep apnea and a quick overview as to how to treat for sleep apnea. So the first question which anthropologists, which evolutionary biologists have asked is, why do people snore? Like, why has evolution not taken care of snoring? And then there are many different theories. So there's a theory that once upon a time human beings went together as a group, and when they slept at night, if everyone snored, it would keep predators away. It would make people realize that there is a group of individuals here who should not be attacked, and there was an evolution advantage to that. There's also an evolution advantage to deep sleep. If you sleep deeply, you are likely to be more restored in the morning, you're likely to be more energetic, and therefore there was an evolution advantage to having sleep as deep as possible. But unfortunately, with deep sleep came the side effect of relaxation of the pharyngeal muscles, and as a result of which airflow limitation was one of the side effects that we bought. As human beings started using language, their air passages also changed, their upper airways changed, and they became tighter, which increased the probability of snoring and sleep apnea. And of course, these were all physiological advantages when it comes to evolution, but now we are realizing that the obesity epidemic is causing its own bunch of problems. So as you have increasing neck girths, as you have narrow pharynxes, as you have a lot of fat around your neck, the collapsibility of the upper airway is increasing. So is snoring harmful? So we know that about 40% of the population snores, but only about 5 to 10% of the population has sleep apnea. So what about the remaining 30%? Is snoring in itself harmful? So we know that if you snore, you are more likely to develop OSA as you grow older. So it's a prelude condition to OSA. If you have snoring as a young individual, as you grow older, as your muscles get more lax, you're more likely to have sleep apnea as you grow older. It is a predictor for OSA. If somebody snores loudly, they are more likely to have sleep apnea than somebody who's a gentle snorer. It is associated with reduced sleep, and episodes of daytime somnolence, even in the absence of apnea. So even if you do a sleep study, the person doesn't have sleep apnea, a person who snores tends to have a poorer quality of sleep than a person who doesn't snore. And this was an interesting study which found that just habitual snoring versus non-snoring had an increased hazard risk for cardiovascular disease, for coronary heart disease, and for stroke. So even if you don't have sleep apnea, but you snore, you have a slightly increased probability of developing cerebrovascular and cardiovascular disease. So that's as far as snoring goes, right? But what exactly is OSA? What is obstructive sleep apnea? So this is a concept from physics. It's called a Starling resistor. So if you have two solid tubes at either end and you have a collapsible segment in between, whether or not the collapsible segment remains open depends on the box around it, depends on the pressure around it, and depends on the velocity of flow that goes from upstream to downstream. So the human oropharynx at this level is very much like this. There is the skull, which is upstream, which keeps the air passages in place. So when air is going through your nose, there is a skull, there is a scaffolding around it. If you go further downstream, you have cartilage rings of the trachea, which keeps things in place. But you have this segment of the oropharynx out here, the hypopharynx and the oropharynx, which is completely collapsible. So that collapsible segment, the patency of that collapsible segment completely depends on the tissue around it. And that's one of the fundamental principles of sleep apnea. So what causes sleep disordered breathing, or what causes sleep apnea? Anything that causes narrowing. So for example, we know in children, if you have large adenoids and large tonsils, that causes narrowing. In adults, we know if you have a lot of fat at the base of the tongue, you have a big neck girth, you have adipose tissue around the neck, that causes narrowing. Or anything that increases collapsibility. So if the tone of the muscle goes down, which often happens as you grow older, for example, that can cause increased collapsibility. So what are the physiological consequences of sleep apnea? So this is what a sleep study of somebody with sleep apnea looks like. So let's begin with flow, right? Airflow. So normally you would have waxing and waning with every tidal breath, but you see these periods where there's no flow going through, and this is what we describe an apnea. What typically happens is at the start of the apnea, your oxygen levels are normal because you have a functional residual capacity. You have air which is still in your lungs, which is diffusing oxygen in the middle of the apnea. But as you go further towards the end of the apnea, the oxygen levels start dipping. This is where your brain wakes you up subconsciously. You take a deep breath, flow is restored for some time, oxygen levels pick up, and this cycle is repeated over and over again in sleep apnea. What also happens as a result of this is there is increased sympathetic activity. So if you did transesophageal probes and looked at sympathetic activity, there's a significant surge in sympathetic activity. There's an increase in blood pressure during those episodes, and there are huge negative intrathoracic pressure swings. So think about it, if somebody is obstructed air out here, and you're trying to take a deep breath, you're generating negative intrathoracic pressure. That pressure stretches the heart, stretches the ventricles, stretches the pulmonary arteries, and we'll speak about the consequences of that as well. Multiple consequences of having sleep apnea. Metabolic complications. So do remember to ask your patients about nocturia. So frequency of urination at night, of course, could be because of your prostate, but it's a very common symptom in sleep apnea. Why does this happen? Because you have negative intrathoracic pressure, there's a stretch on the ventricles, you release atrial natriuretic peptide, and the diuresis that happens as a consequence of that is a very common symptom of sleep apnea. Weight gain, metabolic syndrome, we know insulin resistance is strongly tied to quality of sleep, and therefore sleep apnea is strongly linked. Sexual dysfunction, which again doesn't get spoken about much, is again a common symptom of sleep apnea. The consequences, the strongest association of sleep apnea with disease is with hypertension, with cardiovascular and cerebrovascular events. And of course, we now know more and more that there are behavioral disturbances. So in children with attention deficit hyperreactivity disorder benefit hugely with improving the sleep quality. In adults, it's associated with depression, it's associated with mood swings. Again, all linked to the fact that your sleep quality tends to be very poor. You can get headaches in the morning, fatigue-related accidents. Sleep apnea is very often the cause of road traffic accidents because the person driving falls asleep at the wheel. So let's talk about OSA and cardiovascular death. Fortunately or unfortunately, this person has done more for the field of sleep apnea than all of us doctors combined. And as a result of it, a lot of people came to us and started speaking about their own symptoms, saying that Bapi Lahiri died of sleep apnea, could I have sleep apnea? Now the question is whether he really died of sleep apnea or not is difficult to prove, because when that episode happened, obviously nobody was monitoring his sleep. But there is a strong association of sudden cardiac death and sleep apnea. So these are huge studies which are done, which have looked at people dying from midnight to 6 a.m., that period of 6 hours where we do know that a lot of cardiovascular events happen. They found that individuals with sleep apnea had a much higher probability of dying within those 6 hours than those who did not have sleep apnea. Again, difficult to prove whether it's actually the sleep apnea killing the person, but there is a strong association between the two. This was another study, huge study, again looked at 10,000 individuals, and they found that those who had a polysomnography, OSA predicted sudden cardiac death. So if you had OSA, your probability of sudden cardiac death was much higher than individuals who did not have OSA. Again, suggesting that it is possible that he passed away because of sleep apnea. It is a known association. So how does OSA exactly affect cardiovascular physiology? Again, this is a great resource if you want to read up. It's Shahrukh Jawahri is one of the world experts in OSA. He's written two articles in JACC, which is a cardiology journal, which covers all the broad effects of sleep apnea very well. And if you look at this, so let's go forward and backward, right? So we know when you have sleep apnea, your oxygen levels decrease at night. Your CO2 goes up gradually. We know that there are micro-arousals. So when your oxygen levels dip, your brain wakes you up subconsciously. That waking up is an arousal. And we spoke about the pleural pressure swings that happen because of the negative intrathoracic pressure generated when you're trying to take a breath against a closed glottis. So the consequences of that, we know when the O2 levels are low, your organ dysfunction is a common side effect. So including the heart, myocardial ischemia is something that can happen. Endothelial dysfunction is associated with hypoxemia. There's an increased right ventricular afterload which happens as a consequence of hypoxic pulmonary vasoconstriction. So saturations go down, pulmonary artery pressure goes up, heart strain on the right ventricle increases. We know that the arousals lead to increased sympathetic activity and therefore lead to increased blood pressure, arrhythmias, increased heart rate. Atrial arrhythmias have also been described. So we know that a lot of people with atrial fibrillation, if you did sleep studies on them, you would get a significant proportion of them having sleep apnea. And the pleural pressures can actually increase the lung water, can increase the pulmonary edema because of interstitial fluid accumulation, and can increase aortic dilatation again as a consequence of the negative intrathoracic pressure. So this is the physiology of how sleep apnea actually affects the heart and the cardiovascular system. If you look at various different studies, again, the citations are right here if you want to click a photograph. If you look at the association, if you look at people with drug-resistant hypertension, 80% of them have sleep apnea. So that's not a small number. So 4 in 5 people who have drug-resistant hypertension have sleep apnea. Half of all people with congestive heart failure, half of all people with atrial fibrillation have sleep apnea. If you look at all people with hypertension, a third of them have sleep apnea. All individuals with coronary artery disease and angina, a third of them have sleep apnea. So again, in the subset of individuals who have significant coronary artery disease, ischemic heart disease, arrhythmias, there is a high prevalence of obstructive sleep apnea. What about the pathophysiology in terms of cardiovascular disease in general? What are the associations that we know about? And this is again an interesting systematic review which looks at the prevalence of sleep disordered breathing in different conditions. So systolic dysfunction, diastolic dysfunction, heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, acute decompensated heart failure, post-acute cardiogenic pulmonary edema. So the blue line, the blue bar is anyone with an AHI of greater than 15, so that's moderate sleep apnea. Red is any sleep apnea at all, and this is CSR or complex sleep apnea or Cheyne-Stokes respiration. And you look at the blue bars, around 60 to 70% of individuals with left ventricular systolic dysfunction, almost 80% of individuals with acute decompensated heart failure, if you did sleep studies on them, will show significant sleep apnea. So we know that there is a link now. We know that there is an association. We know that we should start thinking about the condition. When we see patients come and approach us with any cardiovascular condition in general, how do we go about diagnosing it? So what are the symptoms? So what's interesting is you must remember that people with sleep apnea will never complain about the quality of sleep. It's the spouse or the partner who will complain about what happens at night, the loud sound, the choking, the tossing and turning. It's usually the spouse who will complain about that. The person themselves will complain about what happens during the day. They're excessively sleepy. They don't wake up feeling fresh. They find it very difficult to stay awake in the middle of the day, especially in the afternoon post-lunch. So when you ask symptoms and you tell them we want to do a sleep study, very often they will say, I sleep anywhere. They sleep anywhere because they are so sleepy, because their quality of sleep is so bad, right? So you need to ask them about daytime symptoms more than you ask them about the night symptoms. Sleepiness, whether they have high blood pressure, irritability, fatigue, morning headaches, concentration, memory problems. In children, hyperactivity is very often a sign of poor sleep quality. So paradoxical, right? You would expect them to be sleepy, but instead they end up being hyperactive. The nocturnal symptoms very often come from the partner-witnessed apneas. Don't forget to ask about nocturia is a very common nocturnal symptom. Cardiac arrhythmias are very often a manifestation. In children, night sweats are a common symptom. So in children, if you want to ask the parent, you ask them when the child wakes up, does the bed feel a little damp? Are the sheets thrown away because they are tossing and turning all night? So you may not get the classical adult symptoms of sleep apnea. This is a useful questionnaire in primary practice if you want to keep it in your clinic to just screen for people who may have sleep apnea. It's called the Stop Bang questionnaire. Do you snore loudly? Are you tired or fatigued? Has your partner observed you stop breathing at night? Do you have high blood pressure? So that's the stop part. BMI more than 35, age over 15, neck girth more than 40 centimeters, and a male gender. If you have more than 3 or more items which are positive, there is a high chance that you will have sleep apnea. So these individuals should definitely be advised to undergo a sleep study. If you have a score less than 3, the probability is lower. So it's a useful screening questionnaire to see if a person needs a sleep study or not. What about sleep studies? Fortunately for us, the field has evolved, the technology has evolved. About 9 out of 10 studies that I recommend nowadays are home studies, simply because if your pre-test probability is high, right? So when you look at a person, everything checks the boxes, you feel this person almost certainly has sleep apnea. A home sleep study is as good as an in-lab sleep study. If your pre-test probability is low, supposing there's a very skinny person, doesn't make sense, doesn't necessarily look and you're confused, then maybe a lab study has some value because usually there's a technician observing you through the night. You can look for parasomnias, you can look for other abnormalities in an in-lab study. But 9 out of 10 times a home sleep study is good enough for most of us. So a home sleep study is what we usually call a type 3 study. You need at least 4 channels, pressure transducer, snoring index, respiratory effort, and saturation monitor. What you don't generally have as a routine in the home study is your EEG leads. So you aren't necessarily able to do a sleep stage scoring very accurately. Although some people do offer home PSGs also nowadays. So how do you read a sleep study? So first question is, did the patient sleep well or not? Because you don't have EEG, so you can't really score sleep, so you need to get that information from people. So what I would do is if I feel somebody strongly has sleep apnea, but the sleep study comes back normal, then I definitely want to know whether the person slept well or not, you know. And sometimes people will say that I could not sleep so well because of all the leads, etc. You might want to repeat a study in that situation. Position is one thing you must look at on a sleep study. You know, are the apneas predominantly on the back? Are they equally on the back or the side? Because in some people, in a small subset of individuals, maybe about 10 to 15% of people, most of the sleep apnea is on their back. And if you can just get them to sleep on their side, you've solved their problem. It's a small subset, but it's a subset which can manage without a CPAP machine. DSATs versus arousal. So when you score sleep apnea, and arousal is also scored and DSAT is also scored, and they have different implications in terms of symptoms. Hypoventilation is something a little more nuanced. In patients with COPD, in patients with neuromuscular diseases, hypoventilation manifests different from sleep apnea. And of course, you want to know how sleepy is the patient, whether the patient has restless legs. All sleep problems are not sleep apnea, right? So you need to take a little more history if it doesn't fit in perfectly. So let's move on to the treatment of sleep apnea. So mild OSA is if you have 5 to 15 events in an hour. So basically you take all the events in an hour divided by the number of hours you sleep, and you come up with a figure of roughly in an average hour, how often is a person stopping to breathe with their oxygen levels going down more than 3%. That's the definition of an event. Moderate is 15 to 30, severe is greater than 30. We have very strong evidence that moderate to severe should be treated. We have a little less strong evidence that mild should be treated. So if somebody has mild sleep apnea, does not have a huge cardiovascular risk, you can try a lot of things like weight loss, positional therapy. There are some devices that can be tried. But again, unfortunately for us, because most of the patients we see are quite severe, we get very few people in the mild category. The treatment for moderate to severe OSA is CPAP, right? A lot of people will talk about a lot of different things. There are dental devices, there are mandibular advancement devices, there is ENT surgery. People will say a lot of different things, but if you look at the evidence, most of the evidence is in very mild sleep apnea. Either in mild sleep apnea or in people who are intolerant to CPAP, who then people will try different things, right? For most people with moderate to severe sleep apnea, OSA is the treatment of choice. Another reason to prescribe OSA is that it's pretty much side effect free. It's air which is being blown under pressure. There are no real major side effects, no chemicals, no drugs, no surgery involved. And once people do get used to it, once you address their concerns, most people adhere reasonably well. Adjunctive treatment should be offered to all patients. So everybody is going to ask you whether, what if I lose weight, doctor? Isn't that good enough? Maybe the snoring will go away. Unfortunately, that's not the case, right? The numbers do reduce. So there's a 10% reduction in weight causes the AHI to reduce by about 26%, right? So if your AHI is about 40 and your weight is say 80, you will have to lose about 8 kilos and it will go from 40 to about 30, right? So from the severe end of the spectrum, it will still stay in the severe end of the spectrum. And we all know how difficult it is to lose 8 kilos of weight. It's not something that's easily done. So these are useful statistics that you can tell your patient if they ask you whether weight loss will make it go away. Smoking cessation helps in consolidation of sleep, so it adds one less factor to poor sleep quality. There's no real direct strong relationship between smoking and sleep apnea. Alcohol and sleep apnea are strongly correlated, right? So if you look at the sleep study of somebody who's just had alcohol, the first half of the night tends to be much worse than the second half of the night. As alcohol drops down from the system, the sleep apnea gets better. So the advice for people who have sleep apnea, don't want to use a CPAP, is that at least keep a 2-hour gap between your last drink and falling asleep so that the alcohol gets out of your system and it doesn't affect the sleep apnea so much. You have to be careful with sedatives and sleep apnea. They are already sleepy individuals. You then give them sedatives. It can worsen the sleep apnea. Plus, they can be really groggy during the day. Someone who's elderly, etc., you have to be careful. It can lead to a lot of accidents. So be very careful about using sedatives in sleep apnea. Caffeine and other stimulants, when they go to bedtime, this is part of what we call sleep hygiene. You have a sleep problem, you have a sleep disorder already, you at least try and optimize everything else that could improve the quality of sleep, which all falls under this umbrella of sleep hygiene. So again, if you want to read up about sleep hygiene, lots of documents available online. Most of it is just common sense stuff. Exercise in the morning, not at night. Try and avoid caffeine as much as possible. Avoid backlit devices as much as possible close to sleep time, and some other tips like that. How do I go back? Okay, sorry. So this is the original paper published in 1981. So it's a good 40 years since the first paper was published on the treatment of sleep apnea with CPAP. This was the patient. This was his oxygen levels up and down throughout the night, really bad, going down to 60%. And this was post-CPAP, completely flattening out and normalizing. This was when CPAP was first discovered and first reported. Now, the next question people will ask you is, fine, you've told me that there is a link between sleep apnea and cardiovascular disease, but will the treatment of sleep apnea actually improve the odds of me avoiding a cardiovascular event? And this is an old study from 2005, so it's a good 20 years old. They took 1,300 men from a sleep apnea clinic, patients with an AHI greater than 30 per hour, those with an AHI of 5 to 30 plus daytime somnolence, 10-year follow-up, so long follow-up, those who were on CPAP versus those who were not on CPAP. So if you look at non-fatal cardiovascular events and fatal for cardiovascular events, snorers were definitely higher than those who didn't have snoring. Moderate OSA, 57% greater risk of an event. Severe OSA, 300%, right? So that's 3 times greater risk. If you use CPAP, that risk fell lower than if you had mild to moderate OSA. So clear signal that CPAP reduces your risk of having cardiovascular events. What about fatal cardiovascular events? If you use CPAP, your risk is very close to controls who did not have sleep apnea. 1.05 is a 5% increased risk, but if you look at the confidence intervals, it's non-significant, right? So there's clear sign that treatment is going to improve things. This is the same data in a graphical form. If you had severe sleep apnea, this is your cumulative mortality over time. The red bar is severe sleep apnea. Cumulative probability of any cardiovascular event increases with time. The blue bar, the blue line down here is if you are on CPAP, clearly showing you that CPAP lowers the probability. This is a more recent publication, again from 2024. It's a systematic review. They've combined all the studies that have looked at treatment with CPAP. And this is the bottom line, right? So this is the relative risk. This is in favor of using CPAP. This is in favor of using control. If you use CPAP, your risk of any major adverse cardiac and cerebrovascular event is significantly lower, so 0.6. So 40% risk reduction if you use CPAP. If you look at only cardiovascular events, there's about a 25 to 30% reduction if you use CPAP versus control. So we have reasonable amount of literature to say that number one, it's associated. Number two, actually treating the sleep apnea can alter your future cardiovascular risk and outcomes. So summarizing, I think we shouldn't ignore snoring. I think we need to sensitize people more and more about the fact that snoring, even snoring in itself, right, is something that we need to watch out for. The louder the snoring, the greater the probability of sleep apnea. If the partner says that the person snores loudly and they have seen them stop breathing, so snore, stop, suddenly start breathing and snore again, that's a very strong indicator of sleep apnea, so should get tested. There are strong links between sleep apnea and both cardiovascular as well as cerebrovascular events, a strong link with strokes as well. So young hypertensives, for example, you must. So somebody who's 30 years old and has hypertension, you must screen for sleep apnea in your checklist. Just as you would screen for renal artery stenosis, you would screen for pheochromocytoma maybe. Do not forget sleep apnea in that list of tests that must be done in young hypertensives. Strong link with stroke, somebody who's had a stroke, somebody who's had a TIA, for example, and you want to prevent the next stroke, do not forget sleep apnea as one of the things you need to look for. You need to have a high clinical suspicion, so that's true for cardiology clinics, for diabetology clinics, for any disease which is part of the metabolic syndrome, so obesity, bariatric clinics, etc. You must have a high clinical suspicion and have a low threshold for testing. So again, the beauty of it is testing is very non-invasive. There is no poking, there's no blood test involved, there's no radiation involved. You just need to do a home sleep study in your own bed. So it's not that difficult to convince people to actually get tested. Home testing is pretty much the way to go in terms of comfort as well as in terms of all the information needed. And CPAP is the definitive treatment for a majority, while we do offer adjunctive treatment to all. So it's not like we don't counsel people about losing weight, about exercise, about sleep hygiene, smoking cessation, how to manage their alcohol consumption, etc. But CPAP still remains the definitive treatment. Thank you.
Thank you, sir, for that informative lecture. Now I would like to call upon stage Dr. GPR, sir, Dr. Spruti, madam, Dr. Ram Chavan, Treasurer MCVP, Dr. Sharad Dadish, sir, Treasurer AMA, Dr. Seema Tiwari. A huge round of applause, please. Thank you, Dr. Pinto, sir. Yes, yes. Now is the time for the announcement of our lucky bumper draw. And the winner is congratulations. The lucky winner will receive the award from the auspicious hands of from Dr. Pinto, sir. Thank you. Now I would like to call on stage MMC observer Dr. Bakul Mehta, sir, for felicitation. Yes, yes. Thank you, Dr. Bakul Mehta, sir. Our next speaker needs no introduction. Dr. G.P. Ratnaparkhi, sir. Listening to him is always a treat. We always wait to listen for his lectures. Let us listen to his wise words. Thank you.
Hello, hello, hello. I know everybody is tired. Really or no? No? क्या बात है? जितना नो आएगा उतना लंबा मैं लेक्चर खींचूंगा. But one thing that today there were 2 Padma Shri people who were felicitated by our Guru Guru. They were so happy. Not because of me, because of the very decent crowd, very great audience in front of me. So clap yourself for it. And out of that, I told one Padma Shri with Magsaysay award is just like a Nobel of Asia. Madam Nilima is so impressed with the crowd, so impressed with the conference. She wants to speak 2-3 words regarding you all or regarding problem on my side. I don't know what she's going to tell. But she is working for a very poor people, ladies poor in an area like Nagar, which is very neglected. So I will call upon Dr. Nilima Madam, Padma Shri and Magsaysay Award winners. मुझे सिर्फ एक ही बात उनके लगी, इनको देख के लगता है क्या इतनी बड़ी लेडी है ये मैगसेसे अवार्ड नोबल लेवल की, कितने सादे हैं. आई मीन सादगी में भी क़यामत की अदा होती है.
धन्यवाद सर, बहुत बहुत धन्यवाद सर आपका. सचमुच आपके बारे में तो सर बात करनी है और डॉक्टर साहब सब लोग सामने बैठे हैं. तो ये बहुत बड़ी बात है। मैं आप लोगों से ये कहती हूँ कि जब मुझे पता चला, डॉक्टर शेरेकर इन्होंने मुझे फ़ोन किया कि ऐसे ऐसे क्राउड है और आपको आना है, मेरी बहुत दिल से इच्छा जाग गई कि मैं बात करूँ, क्योंकि आज हृदय का दिन है, हार्ट का दिन है, और आप दिल वालों से बात करने का मेरा दिल कर रहा है। बहुत सारी चीज़ें हैं जो पता नहीं, कुछ चीज़ों से गुजर रही हूँ, तो मुझे लगता है कि सही जगह होगी तो ये जगह है। मैं कहीं भी बुलाते हैं तो 2-2 साल में लोगों को नई तारीख डेट देती नहीं थी प्रोग्राम जाने की। यहाँ तक कि पद्मश्री जब गवर्नमेंट ने कहा कि हमें पद्म पुरस्कार के लिए आपकी जानकारी दो, तो हमने कहा नहीं, मुझे नहीं चाहिए, क्योंकि पुरस्कार मिलते हैं, फिर लोग आते हैं, बुलाते हैं आपको, और आप काम से डाइवर्ट होते हो, अपने फोकस से डाइवर्ट होते हो, मिशन से डाइवर्ट। तो मैंने कहा कि अभी ना दे, 4-5 साल मुझे और काम करने दे। तो उन्होंने कहा लिख कर दो, तो मैंने लिख कर दिया उनको। उन्होंने कहा कि ये बेवकूफ़ है, दे देते, उन्होंने दे दिया। उसके बाद मैं 3-4 मिनट लेना चाहूँगी। बचपन में मैं गांव में जब थी तो मैंने आसपास के लोगों को, मुझे ऐसा लगता है यहाँ जीवन, ये जो प्रवास है जीवन का, इसे पार करने के लिए नैया भगवान ने सबको दी है। नैया माने नाव, और ये नाव किस चीज़ की है कि पढ़ने का अधिकार है ना। नाव माने नाव नहीं, पढ़ने का अधिकार है, खाने का, अन्न मिलने का, सपने देखने का, हमारे जीवन को सफल बनाने का एक जरिया ये नैया है। पर ये नैया सबके लिए भगवान ने बनाने की क्षमता सबको दी थी। फिर कुछ लोगों के पास ज़्यादा नैया है और कुछ लोगों के पास बिल्कुल नहीं है। वो नैया मुझे भी मिली थी। मतलब मैं गांव में थी, पर मेरे पिताजी स्कूल टीचर थे, तो मुझे पढ़ने का मौका था, मुझे सपने देखने का मौका था। तो मुझे लगा कि ये नैया मुझे मिल गई है। पर जब मैंने देखा कि मेरी सहेलियाँ वो नहीं पढ़ पा रही हैं, उनकी शादी जल्दी होनी, मजदूरों की, किसानों की बेटी थी। एक महिला मेरी माँ के सामने बात कर रही थी कि मुझे भूखे पेट नींद नहीं आती, इसलिए मैं पेट को टॉवेल बांध के सोती हूँ। तो मुझे लगा ऐसा क्यों है। फिर मैंने अपनी सहेलियों से कहा कि मुझे ना इनके लिए कुछ करना है। तो था कि इनके लिए मुझे नैया बनानी है। देखिए, अपनी नैया हम खुद बना सकते हैं, हम अपनी पढ़ाई कर सकते हैं, पेट भर सकते हैं, लेकिन वो करने का मौका नहीं है, या क्या है, दिक्कतें क्या है, ये कुछ लोगों के पास क्यों नहीं है। तो मैंने अपनी नैया में बैठने का मना किया कि मैं नहीं जाऊंगी, मैं इनके लिए नैया कैसी बनती है, क्यों नहीं बना सकते ये लोग, इनमें क्या, इनमें प्रॉब्लम है, क्षमता में प्रॉब्लम है, क्या ये ढूंढना है। तो ये अंडर प्रिविलेज लोग और अंडर प्रिविलेज लोग, इनके लिए मेरा को करना था। तो फिर अपनी खुद की नैया को मैंने तोड़ मरोड़ दिया। मेरी सहेलियाँ बोलती थी शादी होगी तू चली जाएगी, तो मैंने कहा कि मैं शादी नहीं करूँगी, 13 साल की उम्र में तय किया मैं शादी नहीं करूँगी और ये काम करूँगी। पर ये जब काम किया, मैंने पढ़ाई जरिया तो था, पूना को एमए क्लिनिकल साइकोलॉजी करने के बाद, तो मैंने ये कहा कि अरे ये लोगों में दिक्कतें क्या है, क्योंकि एक तरफ काम की ज़रूरत है, दूसरी तरफ काम नहीं है हाथों को, ऐसा है, ये कॉम्बिनेशन कहाँ है, प्रॉब्लम कहाँ है, सोच कहाँ है, बात करने का तरीके में प्रॉब्लम है, क्या है। इन लोगों के लिए जब मैं 8 साल डॉक्टर कलबाग विज्ञान आश्रम पाबल, मुंबई के ही थे वो, विज्ञान आश्रम पाबल के, उनके साथ 8 साल रही मैं 8 साल पूरे भारत में घूमकर मैंने पहले स्टडी किया। मैं वहाँ डिप्यूटी डायरेक्टर थी और मैंने लिस्ट बनाई थी कि क्या नहीं करना है, कि सरकार का पैसा नहीं लेना है, क्योंकि अगर ये देखना है कि प्रॉब्लम कहाँ है, समस्या कहाँ है, तो इनके साथ रहकर, इन्हीं की तरह जीकर हम अपनी खुद की नैया बना सकते हैं, क्योंकि हमारे खुद के लिए खड़ा हो सकते हैं। ये करना था, इसलिए सरकार का पैसा नहीं लेना है, नहीं तो नंबर गेम, टाइम गेम, पेपर वर्क, इसके पीछे दौड़ेंगे तो नहीं चलेगा। कोई भी पुरस्कार के लिए अप्लाई नहीं करेंगे, पब्लिसिटी नहीं करेंगे, वगैरह वगैरह बहुत सारी चीज़ें रहेगी। और इन लोगों के साथ रहकर मैंने काम करना शुरू किया, सरकार का पैसा नहीं। बम्बई के कुछ लोग हैं, बहुत अच्छे लोग हैं, केयरिंग फ्रेंड्स, जैसे रमेश भी कचोलिया, ये जैसे लोगों ने मुझे बहुत सपोर्ट किया था। लेकिन इन लोगों के लिए काम करने के लिए जैसा जैसा लगता गया, मैं वो काम करते गई। उद्योग करना, व्यवसाय करना, मतलब लोगों की ज़रूरत थी कि हम लोगों को पैसा नहीं है लोगों के पास, तो उनको बहुत ज़्यादा ब्याज पर कर्जा लेते हैं। तो किसान बोले कि हमें कर्जा दे दो दीदी, हम आपके पैसे वापस करेंगे, कर्जा। और महिलाएं बोलती हैं हमको हाथ को काम दे दो। हम लोगों ने पहाड़ियों में जहाँ बिजली नहीं थी, वहाँ पर हजारों घरों में बिजली लगाई। कहा था लोगों को कि आपको केरोसिन का जितना खर्चा आता है ना, उससे थोड़ा ज़्यादा खर्चा आप हमें इंस्टॉलमेंट में दे दो, क्योंकि फ्री नहीं देना था ना किसी को, वो इंस्टॉलमेंट में दे दो। तो वो एक, फिर पहाड़ी के नीचे के लोग बोलते हैं कि हमारी खेती गिरवी है साहूकारों के पास 30-40 साल से, तो हमें वो चाहिए। तो हमने कहा देखो आपने साहूकारों से पैसे लिए थे ना, तो साहूकारों को पैसे वापस देने पड़ेंगे। उन्होंने अन्याय से नहीं लिए, आपकी जरूरत थी इसलिए आपने खेती रखी, तो वो खेती छुड़वाई, खेत में कुआं बनवाया, पाइपलाइन किया, न जाने क्या, ट्रैक्टर लिया, बैल जोड़ी लिया, गाय दूध का व्यवसाय करने के लिए, बाकी सारे किसानों के लिए शौचालय बनवाए, जिन लोगों के बच्चों को पढ़ाई नहीं करवाते हायर एजुकेशन उनके लिए किया, बेटियों की शादी, मकान बनाए, कितने लोगों के घर नहीं थे, बहुत सारी चीज़, वाटरशेड डेवलपमेंट के लिए खुद का अर्थमोवर मशीन लिया, वो काम किया, ये सारे काम किए। इसमें एक्सपेरिमेंट मैंने बहुत किए। 27 साल का प्रोग्राम 2000 में मैंने बनाया था। एक्सपेरिमेंट बहुत किए और एक्सपेरिमेंट के लिए बहुत ज़्यादा खर्चा, क्योंकि उद्योग व्यवसाय सोचना था तो एक एंटरप्रेन्योर की तरह सोचना था। तो बल्क प्रोडक्शन, कुर्तियाँ बनाते हैं ना, कुर्तियाँ काट के देते हैं हम लोग, आप सिर्फ जोड़ दो, आपको ज़्यादा एक्सपर्टाइज होने की ज़रूरत नहीं है, सिर्फ जोड़ दो। मिर्च, मसाले, अचार, सब कुछ। गोधड़ियाँ, हमारी गोधड़ियाँ एक्सपोर्ट, क्विल्ट होती है ना पैचवर्क के, वो एक्सपोर्ट होती थी, बहुत सारा अच्छा से चलता था। और फिर क्या होता है कि जिन लोगों के लिए हम काम कर रहे हैं वो लोगों ने थोड़ी परीक्षा लेना शुरू किया। उन्होंने कहा कि अरे ये दीदी कुछ बोलती नहीं है, इसको अगर पैसे अपन थोड़ी देर से देते हैं ना तो ये चिल्लाती नहीं है, ये बोलती नहीं है। तो कहा कि दीदी हमारे गांव में तो बारिश ही नहीं है, 200 गांव में काम करते, तो हम तो नहीं दे सकते, क्या बोलेंगे किसान को। ठीक है भैया जल्दी दे देना, क्योंकि मैंने भी तो तुम लोगों के लिए दूसरों से कर्जा लाए, दे देना। तो एक गांव का सक्सेस होता है तो दूसरा गांव कहता है अरे हाँ 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 हमारा भी ऐसा है, हमारा भी ऐसा, करके सारे लोग रुक गए। महिलाओं की कर्जा उद्योग व्यवसाय के लिए जिस गांव की महिलाएं घर से बाहर नहीं निकलती थी, उस गांव की हजारों महिलाएं मार्केटिंग करती थी, पूरे महाराष्ट्र में, बिहार में जाके भी मार्केटिंग करती थी। हमने कहा कि हमारा प्रोडक्ट हम ही बेचेंगे, और वो सक्सेसफुल रहा। लोग जो कंपनियों को मैंने वर्ड दिया था, उनसे लेके मैंने लोगों से उठाकर मैंने कंपनियों को दिए और इनको कहा कि भैया आप लोग जल्दी देना, नहीं दिया लोगों ने। कोविड आया, प्रोडक्शन बंद, सेल बंद, सब कुछ बंद। और फिर क्या हुआ कि इनका पैसा देना था वो नहीं दिया गया, लोगों का जो लिया, परेशान करने लगे कि दीदी हमें पैसे चाहिए, आपका अपना काम कुछ भी करो। 4 साल से आज मैं बहुत लड़ रही हूँ, बहुत ज़्यादा लड़ रही हूँ, न जाने कहाँ कहाँ जाके कुछ काम करके लोगों का लौटो। मैंने कहा कि आपका सबका एक एक पैसा मिलेगा। मैं एक बात कहती हूँ, मैंने नगर डिस्ट्रिक्ट में काम शुरू किया, तब 25,000 महिलाएं मेरे नेटवर्क में थी, डायरेक्टली और इनडायरेक्टली। और यहाँ नगर में 2,500 महिलाओं के लिए मैंने काम किया। मैं उस वाकया को आपको, मैंने उनको क्या काम दे, मेरे पास तो पैसा भी नहीं है, मैं तो उल्टा मेहनत में हूँ, मैं इनको क्या काम दूँ। आप छोटा मोटा कोई भी काम शुरू करें, आपको पैसा लगता है। मैंने कहा मैं इनके लिए पैसे कहाँ से लाऊंगी। मैंने एक सिंपल सा काम निकाला, जो गोधड़ी बनाते हैं ना, सिंपल टाके, वो अपन एक कपड़े पर डालते हैं और उसके हम जैकेट बनाएंगे, वो बेचेंगे। और वो जैकेट उन लोगों ने बनाया, सिखाया गया, बताया गया, सब कुछ किया। ये पूरा 80% माल पूरा इन लोगों ने खराब कर दिया। फिर मैंने कहा अरे ये खराब हो गया, लोग क्यों लेंगे, लोग नहीं लेते हैं ऐसा माल, आप दुरुस्त कर दो। अब देखिए हम जिनके लिए काम करते हैं उनकी तरफ से बहुत सारी चीज़ें बहुत ज़रूरी है, तो हमने कहा आप दुरुस्त कर दो। बोलते नहीं नहीं, दुरुस्त अगर करना है तो हमें और पैसे दो। आप क्या करें, काम छोड़ना चाहिए था, काम बंद करना चाहिए था। मैं उन लोगों को बोलती हूँ कि आप लोग मकान में रहते हो, मैं कहती हूँ कि अरे आप लोग घर में रहते हो, घर बनाया आपने, मैं भटक रही हूँ, आपको नहीं लगता पैसे देने चाहिए। और उनको बोलती हूँ कि आपने खेती में पानी मंगाया, बोरवेल किया, कुआं बनवाया, आपको नहीं लगता है कि आपने आपका उत्पन्न बढ़ाया ना, आपने वह पैसे वापस करने चाहिए। बच्चों को कहती हूँ बच्चों आपकी एजुकेशन तो होने वाली नहीं थी, फिर आज आप लोग नौकरी को लग गए हो, आपको नहीं लगता आपने वापस देना चाहिए। कहते दीदी अभी अच्छा पैकेज नहीं मिला, हमें हमारा घर बनाना है, लड़कियों की शादी हुई है, किसी को नहीं लगता है, बोलना नहीं। फिर इन महिलाओं को बोला कि अरे आपके लिए आपका माल बना कर मैं बेचने जाती हूँ, आपके गांव तक आती हूँ, 2,500 औरतों को, उनके गांव में जाके माल देती हूँ, उनका बनाया हुआ माल लेती हूँ, बेचती हूँ, ट्रेनिंग देती हूँ, सब कुछ खर्चा करती हूँ। तो ये इनसेंसिटिविटी क्यों है? पर ये ऊपर वाले ने अच्छा किया, क्योंकि हमें जो एक मॉडल, रेप्लिकेबल मॉडल ढूंढना था 27 साल के प्रोग्राम में पूरे देश की औरतों को, तो उसका मॉडल मुझे मिल गया कि ट्रीटमेंट कहाँ करनी चाहिए। जो चीज़ होती है अच्छे के लिए होती है, थोड़ा सफ़र हो रहे, लेकिन फिर मैंने कहा कि आप कैसे करें। मैंने डोनेशन को कभी बढ़ावा नहीं दिया। मैंने लोगों से कहा कि आप पैसा देते हो ना, आप वापस लो, मैं काम करती हूँ, उसका मुनाफा होगा तो मुनाफा भी लो, चाहे तो आप ब्याज दो। वो भी मैंने कभी अपना रवैया नहीं रखा। लेकिन ये औरतें ये कहती हैं कि नहीं नहीं, हमारा पैसा कब दोगे? हमने कहा अभी रुको, मैं आपका माल तैयार कर रही हूँ, दुरुस्त कर रही हूँ, उसे बेच रही हूँ। नहीं नहीं, ऐसा होगा तो हम पुलिस केस करेंगे। हमने कहा जरूर करना। मुझे बुरा नहीं लगा। मुझे ये पता चला कि इनकी मानसिकता कहाँ है, इनकी सोच कहाँ तक जाती है। मैं कहती हूँ कि ताई, आपके लिए जो काम कर रही है, मेहनत कर रही है, तो उसे आप ऐसे करोगे तो फिर कैसे कोई कैसे आएगा आपके लिए काम करने को? कुछ महिलाएं समझती हैं, कुछ नहीं समझती हैं। पर बाद में पता चला कि ये भी मजबूर हैं, 2-2, 500 रुपए के लिए मजबूर है ये औरतें। क्योंकि हम तो बहुत तड़ा गड़ा के लोग बोलते ना, उनके लिए काम कर रहे हैं, तो उनको 200 रुपये 500 रुपये भी बहुत जरूरी है। फिर लगा कि नहीं, इनकी गलती नहीं है, तो एक्सपेरिमेंट तो करने थे। एक्सपेरिमेंट किए हुए, अच्छा इनको अगर मैं काम ना दूँ तो क्वालिटी कैसे आए? और ये लोग काम ना करें, प्रैक्टिस ना करें तो क्वालिटी कैसे आए? तो उनको काम देना भी जरूरी है, तो प्रैक्टिस तो वो लोग अपने ही काम पर करने, जिसका नुकसान होना है। तो मेरा एक कहना है, मैं कभी कभी बहुत ये इससे जा रही हूँ, मैं आप लोगों से एक विनती करने आई हूँ कि क्या करें। मुझे बाद में पता चला कि हम लोगों से कुछ मांगेंगे नहीं, पर हमारा काम लोगों तक पहुँचे, ऐसा तो कुछ कर सकते हैं। मैं बस एक बात कहने आई हूँ आपको। हमने एक लिंक बनाई है, तो उस लिंक में अगर आप लोग ऑनलाइन रजिस्ट्रेशन करते हैं तो आपको व्हाट्सएप में नहीं, ईमेल में हमारे काम के बारे में जो भी चल रहा है, एम्पावर हर करके मैं अभियान चला रही हूँ, कैंपेन चला रही हूँ, मूवमेंट चला रही हूँ। इन सब चीज़ों से जो मैंने आपके सामने रखी, उससे मैं त्रसित नहीं हूँ। वो मैं ऊपर वाले का कुछ तो भी ये है कि प्रैक्टिकल मैं दुनियादारी सीखूं और उस हिसाब से मैं निर्णय लूँ, क्योंकि पूरे भारत में हर कॉर्नर की औरतों को काम देना है। रेप्लिकेबल मॉडल, ये हमारा पर्पस था। तो आज कर्नाटका में काम कर रही हूँ, गुजरात में काम कर रही हूँ, महाराष्ट्र के बहुत सारे डिस्ट्रिक्ट में काम कर रही हूँ। अभी सबसे सर से बात हुई, जम्मू कश्मीर में काम करने जा रहे हैं, यूपी में काम करने जा रहे हैं। तो ये मॉडल करने जा रहे हैं, लेकिन उसके पहले हमने कहा कि ये मॉडल को पक्का करते हैं। तो इसलिए मैं सोच रही हूँ कि आप लोगों तक इस काम की जानकारी आते रहे, आप लोगों को पता चले कि अरे अच्छा यहाँ पर काम शुरू हुआ, महिलाओं को ये रोजगार दिया गया है, अच्छा ये भी है। तो हो सकता है कि आपके आसपास कुछ ज़रूरतमंद होते हैं, तो आप भी कह सकते हो कि हमारे यहाँ ऐसे भी काम शुरू कर सकते हैं, क्या हो सकता है क्या? विश्वेश्वरैया टेक्नोलॉजिकल यूनिवर्सिटी ने अभी सर्कुलर निकाला है कि वो सारे उनके 212 जो कॉलेज हैं, वो सारे कॉलेज में हम लोग कैंपेन चला रहे हैं। उसके लिए भी बहुत सारी मेहनत लेनी पड़ती है। तो मैं आपसे विनती करने आई हूँ, क्या आप उस लिंक पर अपना ऑनलाइन रजिस्ट्रेशन करेंगे? उसको 150 रुपीज़ सिर्फ फीस लगती है, क्या आप करोगे? बस ये पूछने में आई हूँ। थैंक यू, थैंक यू, थैंक यू। मैं अपना नंबर देती हूँ, आप लोग लिख लीजिएगा। नंबर देती हूँ मैं अपना 9699 2969 हाँ, 9699832969। मैं इसके लिए पात्र हूँ या नहीं, ये आप ये कर सकते हैं। मुझे मैक्से से जब मिला तो जितनी भी $50,000 की राशि मिली और आज तक जितने भी अवार्ड्स मिले उसकी धनराशि मैंने डोनेट ही करती आई हूँ। मैं कोई पगार नहीं लेती हूँ। मुझे यहाँ रमेश जी कचुलिया, इनकी एक जो संस्था है, तो वो मुझे 10,000 रुपये महीना देती है कि भाई तुम अपनी बीमारी के लिए, अपने कपड़े के लिए, अपने खाने के लिए कुछ तो तुम्हारे पास होना चाहिए। इसलिए वो मुझे 10,000 रुपये महीने का खर्चा देते हैं। और दूसरी बात यह है कि मेरी माँ, उन्होंने गांव के जितने बुजुर्ग लोग हैं जिनका देखभाल करने वाला कोई नहीं, उनके लिए 17 साल से खाने का काम चलाती है। और वो एक दिन भी बंद नहीं रखती थी, और वो कहती थी कि बेटा आस लगी है, एक दिन भी छुट्टी नहीं होनी चाहिए। तो इसलिए ऐसा हुआ कि जब, और किसी से डोनेशन भी नहीं लिया, उसमें काम करके कमा कर, हम लोग मिडिल क्लास फैमिली है, लोअर मिडिल का, काम करके कमा कर महिलाओं को रोजगार देके उसी में से बुजुर्ग लोगों को खाना देते हैं। तो जब वो गई तो पहले बुजुर्ग लोगों को खाना गया, उसके बाद अम्मा की जो भी अंतिम क्रिया थी वो हुई। तो इस तरह से ये उद्दिष्ट रख के आज भी वो काम चल रहा है, मेरी बड़ी दीदी चला रही है, छोटी बहन चला रही है, तो इस तरह से है। तो बस आपका जो भी है समय बहुत अलग है, जो सोचते हैं उस तरह से नहीं होता है, तो अलग समय से गुजर रही हूँ, इसलिए मुझे ये कहने की जरूरत पड़ी। मैं बहुत बहुत दुआएं आपको देती हूँ, और थैंक यू मैम, थैंक यू। हाँ, संस्था का नाम आप लोग वेबसाइट देखोगे www.bngvn, भगिनी निवेदिता के नाम से है, BNGVN, ये वेबसाइट .org देख लीजिएगा। उसमें हम लोग वो भी नहीं अपडेट रखते थे, फिर लोग बोलने लगे देखो अपना वेबसाइट रखो, तो हमने अभी 1 हफ्ते पहले जो हमारा मटेरियल था वो सारा अपलोड कर दिया। तो वो से सर मैं माफ़ी चाहती हूँ, मैंने बहुत ज़्यादा समय लिया है आपका, पर मुझे ये मौका चाहिए था और वो आपने दिया, बहुत मेहरबानी आपकी। और सर बात है, एक बार मैं आपसे मिलने आई थी तो मैंने आपका काम देखा, तो मुझे ये पता चला सर, तब तो आप कुछ बता ही नहीं रहे थे आपके काम के बारे में, मुझे कुछ आइडिया ही नहीं आ रहा था। तो सच है, काम करने वाला बोलता नहीं है सर। तो आज आपका देख के तो मुझे पूरा एक्सप्लोर हुआ क्या हो आप, और मुझे बहुत सारी आइडिया आ रही है। तो मैं मतलब ये जो है ना सर, ये देने वाले का जो नेचर होता है ना, वो क्या होता है वो पता चल जाता है सर। तो आपको बहुत बहुत शुभकामनाएं, और आप सबका बहुत बहुत आभार। मैंने एंट्री बीच में ही एंट्री कर लिया, मैं माफ़ी चाहती हूँ, धन्यवाद।
In short, Magsaysay Award में you get $50,000 from the organizing team. That entire $50,000 she spent on the human female empowerment. बाकी तो क्या exactly model मुझे ज़्यादा समझा नहीं, but she is doing extraordinary work. Okay, और ऐसे ही लोगों को मैगसेसी या पद्मश्री मिलता है, वो ऐसा मुझे समझा है ना। Okay, अभी भी वो फीमेल एम्पावरमेंट, ऑलमोस्ट मोर देन 25,000 फीमेल्स को उन्होंने एम्पावर करने के लिए जो कुछ करना है वो किया। व्हाट आई अंडरस्टैंड, मेरी सब 2 बार 3 बार ही उनकी मुलाकात हुई, बट शी इज डूइंग ग्रेट जॉब। आई थिंक वी शुड सपोर्ट हर। ओके, दैट इज, यू आर अ बेटर जज। सेकेंडली, नाउ लेट अस कम टू आवर एकेडमिक सेशन। लास्ट 2 रात से मैं सोया नहीं, और दिन भर यू हैव सीन दैट आई एम रनिंग अराउंड, तो मुझे क्या बोलना है लेक्चर में मैं सब भूल गया। ओके, so when you don't know what to speak, then it's better to ask the question. Okay, so that once you start asking the patient, सामने वाला बैक फुट पे जाता है, बराबर ना? Okay, so मैं तो भूल गया क्या बोलना है मुझे। Anyway, last year also I have spoken on the same topic, that is heart failure. Okay, and in that everybody was very keenly listening to me. So, and everybody understood, okay, because there are hardly any question. Even Anil doesn't have any question, means there is no question. Okay, even apne Ghatkopar wale boss doesn't have any question, means there is no question. The lecture was so lucid, you didn't, either you didn't understand anything or you understood everything. Okay, so first question, what is heart failure? There are 18 definitions of heart failure. Okay, उसमें एक क्विज हो सकती है मेरे, बट इस सिंपल, आई एम मेकिंग यू वेरी सिंपल दैट हार्ट फेलियर फेल हो गया, मतलब हार्ट इज फेल टू गिव अ एडिक्वेट ब्लड सप्लाई टू द मेटाबॉलिज्म टिश्यू। सिंपल, कॉम्प्लिकेटेड क्यों करना है ना? इट इज अ फेलियर ऑफ द मायोकार्डियम टू सप्लाई एडिक्वेटली टू द मेटाबॉलिज्म टिश्यू, और it can do it, heart can do it, but on an extremely tremendous pressure. What in medical college in diastolic pressure and वगैरह वगैरह वगैरह. So either under pressure, जैसा मैं आज under pressure lecture दे रहा हूँ, मुझे मालूम है यार कब खत्म होती कॉन्फ्रेंस और रत्नवार की बोल रहा है, बट अंडर प्रेशर लेक्चर दे रहा हूँ और आप अंडर प्रेशर सुन रहे हो, मुझे मालूम है। ओके, तो ऑप्शन नहीं ना, मुझे भी ऑप्शन नहीं था, तीन कंपनी ने मेरा लेक्चर स्पॉन्सर किया है, ठीक है। सो इट इज अ फेलियर ऑफ द मायोकार्डियम और हार्ट टू फुलफिल द रिक्वायरमेंट ऑफ मेटाबॉलिक टिश्यू, सिंपल, ठीक। दिस इज व्हाट अनदर universal definition. There are three components of the heart failure. One, there has to be sign and symptom. Second, there has to be some structural or functional abnormality of the heart, and ultimately producing either systemic congestion or pulmonary congestion, maybe subtle, छोटा सा. If there is छोटा सा subtle, BNP will rise, nothing will happen. If there is abnormal, then there will be breathlessness or systemic congestion, means giddiness and all this. So these are only three components of the heart failure. It has very high prevalence, 2 out of 1,000. And unfortunately, because of you all, the heart failure incidence is increasing. I am blaming you, तुम हाँ बोल रहे हो, because you are treating the patient nicely. You are making them to survive more. Okay? As soon as patient comes to you, treat nicely. The patient लंबा जीता है. As soon as he crosses 65, 70, there is a natural stiffness of the heart. That is known as diastolic dysfunction. When heart becomes stiff, it is a diastolic dysfunction. I am making you very simple. I am not going to bookish knowledge. Sir, barabar na? Perfect. So it has very high prevalence, 2 out of 1,000. As the age increases, it may be 5 out of 1,000. High mortality rate. Almost 23% patient dies within 1 year who has established heart failure. Huge mortality. And cost. India is a poor country. We have seen that. Madam is working for poor people, agreed. So we cannot afford to have failed heart and population with failed heart, right? So classification basically systolic failure versus diastolic failure. More precisely, if LVEF, which is done by echocardiography, LVEF less than 40 is a heart failure with reduced LVEF. So called as HF or EF, HEP, REP. Second is between 40 to 50, and third is 50 onwards. Okay, so reduce EF, mid-range EF, and preserve EF. So these are the three categories of heart failure. Fourth is there, where there is LVEF is low, you treated the patient nicely and now LVEF improved to normal. So that is heart failure with improved LVEF. Clear? Perfect. What is acute and chronic? Chronic means more than 3 months. The symptoms are more than 3 months, and acute means within 3 months. Mortality very high. I already mentioned that. Hospitalizations in 1 year is almost 30%. Are Indians are different from Western population? Yes or no? Yes, because we have early occurrence of heart failure. 1, male to female ratio. Good news for females. Females suffer less for heart failure. Male suffer more. In Western countries, it is 50-50. In India, it is 70% male and 30% female. Good news for female, because males are taking more care of females. Not vice versa. All females are staring at me. At least they are awake. Etiology, again, ischemic heart disease is the commonest disease. In India, rheumatic heart disease adds 8 to 10%. So 90% heart failure are because of ischemic heart disease, 10% may be rheumatic heart disease. Similarly, in Western population, as their age is more, 80, 90 like that, they have degenerative valvular heart disease. Again, so 90% ischemic heart disease, 10% valvular heart disease because of degeneration. Diabetes is the commonest risk factor, and we have higher mortality. Our mortality of heart failure is twice of European country. Double hai, okay? Poor country, double mortality problem. So we have to, not to treat, we have to prevent it. Treatment, we are there to treat, but you have to prevent it. Prevention, very easy. Avoid stress. You can nicely snore. That is avoidance of stress. Okay. After lunch. Control of obesity. Control of diabetes. Regular exercise. Control of fat and salt. Control of blood pressure. Relaxation. Avoid smoking and alcohol. इसमें से अपन एक भी नहीं करते, है ना? हाँ करते? ओबेसिटी बग अंदर खींच रहा है. सो इसमें से अपन कुछ भी नहीं करते, बट दिस इज टॉट इन एवरी लेक्चर एंड वी नेवर लिसन टू दैट. So you have to treat hypertension, you have to treat diabetes, you have to treat atherosclerotic heart disease. And now we will switch to the heart failure. Whenever we treat heart failure, there are three aspects of heart failure. Treatment one, we have to reduce the mortality. We have to reduce hospitalization because that adds cost. And third is, we should have quality life. Only three aspects. Mortality, मरना नहीं चाहिए, खर्चा नहीं होना चाहिए, and quality of life should be better. These three aspects. So, तीन aspect पे काम करने वाला medicine चाहिए. So, what happens in heart failure? There is a less LV function. So, the compensatory phenomena starts in action, right? So, what is the compensation? As soon as pumping comes down, sympathetic activity increases, RAS system get activated. In RAS, there is angiotensin 2, which is a very detrimental molecule, and another molecule recently focused is a aldosterone, which is also a bad molecule. Right? So we have to target on a sympathetic activity, we have to target on aldosterone, we have to target on angiotensin 2. So RAS system and sympathetic system. There is a good peptides which are secreted from the heart, which are protective, but they are negated by neprilysin. Chemical locha wala aadmi. So there is some chemical locha happens that adrenal system get activated, RAS system get activated, and aldosterone system get activated. To neutralize that, peptide get activated, but peptides are neutralized by the body mechanism. So our therapy, which is standardized for the heart failure, are against on this basis only. So what are the pillars of management of heart failure? A for ACE inhibitor, ARBs or ARNI. I am saying ARNI first. This is what the literature. So ARNI, that is acting on the RAS system. It acts on the peptide system. It increases the peptide level to have a positive effect. It depresses the angiotensin 2 to negate the negative effect, right? Beta blocker, activation of sympathetic activity is there, so we have to negate that. MRA, that is aldosterone, is a very newly conceptual molecule which is detrimental for the heart. So aldosterone antagonist. And now recently SGLT2 inhibitor. What happens? Ultimately this chemical locha produces myocyte damage, interstitial fibrosis, apoptosis. Matlab, apoptosis means programmed death of the cell. So apoptosis. So we have to change that. We have to obtain hypertrophied myocyte. Hypertrophy jade dikhte hai, kaam nahi karte, like that. We have to change that. Interstitial fibrosis, we have to change that. And apoptosis, the death of the cell, we have to change that. So this SGLT2 or MRA, through their pleomorphic effect, produces these positive effects. And if you give these four molecules, that is ACE inhibitor, ARBs or RNA or beta blocker or MRA and SGLT2 inhibitors, you can reduce the relative risk by 75%. This is the only quadruple combination which gives reduction in 75%. Only 25% problem hai boss. And absolute reduction means 26%. मतलब कि 75% people will survive like a normal person. Normal person जैसा survive होता है वैसा 75% if they are on these four things. Because relative risk, absolute risk is very tricky words. But if you treat the heart failure patient, who otherwise will have symptom, who otherwise would have died like that, will have a normal life. Almost 75% will have normal life. And number to treat is just 4. Every 4th patient will be surviving. If you give this combination 4 pillar, patient will survive 8 years more than expected. 8 years. अरे बॉस 8 साल कितने बड़ा होता है. आईसीयू के लोगों को पूछो. एक एंजियोग्राफी मेरा डॉक्टर का एंजियोग्राफी कर रहा था, रीनल एंजियोग्राफी. ही हैज ही हैज एनाफिलिक्टिक शॉक. उसका पहला कैसा गजू मला वाचव. बॉस that time you realize 8 साल जीना और because he BP is 10, 20. Okay, as soon as I put a dye, BP falls 20. But it's good that he was in cath lab. He was in my hand. Both the things are important. Okay, okay. Because cath lab में कोई दूसरा रहता प्रॉब्लम था. अनिल हंस रहा है. Anyway, we have given adrenaline like anything. Patient came out, okay, and he every year comes to, and he was a professor of surgery. हमारा जे का ही था. He survived. कभी मिलता, मेरा सीनियर है, पर पैर पड़ता है बेचारा. आपने बचाया, मैंने कुछ नहीं किया. कुछ लोग यही प्राइवेट में होता था, आपने ये सब किया ऐसा बोला ना. Die reaction is not in my hand. This happened. So बोलने का तात्पर्य है कि surviving 8 years more is a benefit of all these 4 drugs. Okay, so these 4 drugs you have to give in all the patients. Diagnosis of failure is simple. Send the patient for echocardiography, of course to Guru Krupa Heart Center only. Okay, I will start the medicine, you follow the patient. Perfect. Right? You have to adjust BP pulse according to thing. If you do that, you can make 8-year survival. But what is the scenario? What is the scenario? This is the scenario. 90% of the patients are on the diuretics. Diuretic like Lasix have no mortality benefits. In acute set, agreed. In acute setting, agreed. On a chronic basis, Lasix or short-acting diuretic have no mortality benefits. Okay, Arni, hardly 10% patients were on Arni. जिसका 40% reduction in the mortality, only 10% are on Arni. This is the Indian College of Cardiology का data है बस. Anyway, let's see another data. This is Kerala. Kerala is supposed to be most literate state of India, right? Where 100% literacy is there. So Kerala is standard. What is the use of these 4 standard drugs? Only 25%. In spite, I am telling that you are going to survive patient 8 years more. Mortality is going to reduce by 75%. Still only 25% patients are on this standard therapy. क्या problem क्या है? मेरा लेक्चर नहीं सुना क्या? आप लोग लिखते हो, बाकी के लोग को बोलो, लिखो या लेक्चर सुनो. Anyway, and this is Trivandrum, is the capital of Kerala. Same data, only 25%, 24% patients are on this fantastic 4. What we call in cardiology is a fantastic 4. I don't know why. Why you people are afraid of that? I am blaming you because, before blaming you, this is not your problem, this is an international problem. In UK, in US, even Sweden also, 50% are discontinuation rate. 50% लोग लेते नहीं after 1 year. ARBs, ARNIs, 30% patient after 6 months, after 1 year, stop the medicine. Arey Baba, you have to continue the medicine lifelong. Then only the life will long. You have to continue the medicine lifelong, then only the life will be long. And this is what you are doing. Physicians here and there, they are same. Because you people are afraid of treatment. You people are afraid of losing patient because patient बोलता है बहुत 4 medicine नहीं, एक कम करो. एक MRI, ultrasound inhibitor, वो पहला उड़ जाता है. वो last to start and first to day. आर्नी महंगा है, उड़ जाता है. Beta blocker, you people are resistant. You people are afraid to upgrade the things. I'm speaking all this on my experience. एक पास आपके पास patient गया, pulse 80, BP 145/90. आप कुछ नहीं करते, कंटिन्यू आल करते. लेट दैट हार्ट रेट 80 कम टू 65. करते हो इतना? नहीं करते हो. हाँ, आप बोलने के लिए करते हो, हाँ हाँ बोलोगे, नहीं करते. माय कलीग्स आर नॉट डूइंग दैट. Bring the heart rate to 65, then only you get the result. If you give beta blocker and the heart rate is above 80, you will not get the result. I am shouting because you should remain awake. You should be awake to treat the patient nicely. Beta blocker is useless unless you bring the heart rate below 70 to 65. 60, no problem. 65 is the ideal level. There is a clear-cut data of beautiful trial that if the heart rate is above 70, the mortality is high. If the heart rate is below 70, mortality is low. So first, up titration of beta blocker. Secondly, ARNI. कितना डोज चालू करते 50 mg, half BD. And hardly anybody from family physician or for physician, hardly anybody increases. Maximum 90% of Indian patients, 90% of Indian patients are on 50 mg of ARNI. Dose is कितना है? 200 mg twice a day, boss. You will get maximum result if you give 200 mg BD. Of course, her patient will not tolerate, agreed. In that case, being 200, BP 85 है, patient घूम रहा फिर मस्त मजा कर रहा है. You try to reduce, why? He's doing all activity, watch for urine output, watch for creatinine. If his urine output is fine, creatinine is fine, accept BP of 85 also, no problem. Do not stop the ARNI. So these things are very important. This fantastic four will work when this small thing will be taken care. Agreed? And this is the scenario. This black color is the patient who are on this crazy four or fantastic four. And this red color, they are the patient who indicated that. There is no contraindication, but still they are not on ARNI or for fantastic four. This is a criminal management of patient. Whatever, cost is not a criteria. Life is. Agar aap, next slide is there. Counseling is very important. Tell that if you don't take this medicine, you are going to die. Okay? If you say lightly, kuch nahi hota, to wo sab band kar deta hai. So this is the red color which the things are indicated. There is no contraindication. Kidney is normal, everything is fine. But still, people are not taking care. You people are not giving. You means not you. Those who are not listening my lecture. बाहर के लोग. ठीक है? तो बाहर के लोग जो सुनते नहीं अपना, वो ऐसा करते हैं. ये ब्लैक कलर जो लिख रहे हैं, दिस ऑल योर पेशेंट. एग्रीड? तालियां बजाओ खुद के लिए. एंड पेशेंट आता, मेरा लेक्चर सुना, यू आर इम्प्रेस, अरे चलो कल जाके पेशेंट को चारों लिख दिया. परसों पेशेंट बोलता है बीपी थोड़ा सा अच्छा नहीं लग रहा. ओके, ये गोली कम कर दे. नहीं सर थोड़ा सा बजा दे, ये गोली कम कर दे. हाँ, सो दैट इज अ कैजुअल वे. हाँ, कैजुअल अप्रोच. एंड सेकंड अप्रोच, स्टाफ नर्स को देने का, इसको ये गोली देने का. वो लोड ही नहीं लेती. लेने का मतलब लेने का. अगर ऐसा किया, सो वन group of say 1,000 people were treated with full dose guideline medicated treatment, and 1,000 people were treated like, क्या बाबू क्या हो रहा है तेरे को, यूरिन कम हो रही है, ये कम कर दे. क्या बीपी तेरा कम है, नहीं 100 है, चक्कर आ रहा, ये कम कर दे. That is usual or casual approach of ours. So doctor medicated group 1,000 and only nurse, आपको monitor by one doctor, nurse कुछ नहीं लेना है, मतलब लेना है. ऐसा ये स्टडी है, स्ट्रॉन्ग हार्ट फेलियर स्टडी. द कैजुअल अप्रोच एंड हाई केयर अप्रोच. व्हाट इज द रिजल्ट? सिग्निफिकेंट इन डिक्रीज इन द मॉर्टैलिटी. क्या हुआ, ऐसा क्यों कर रहे हैं? मेरे फोटो नहीं आ रहे? ठीक है, मैं कैमरा में नहीं, मैं लोगों के दिल में है. वाह, क्योंकि दिल का डॉक्टर हूं ना. ओके, सिग्निफिकेंट रिडक्शन इन द मॉर्टैलिटी एंड मॉर्बिडिटी. फाइन. तो आप बोलोगे अरे वो साइड इफेक्ट बहुत होगा, है ना, फुल डोज देंगे. तो साइड इफेक्ट देखो, साइड इफेक्ट, द फैटल साइड इफेक्ट, दिस इज द इंपॉर्टेंट थिंग. द फैटल, द फैटल साइड इफेक्ट्स आर ओनली इन 5% पेशेंट एंड 6% पेशेंट इन द यूजुअल केयर पेशेंट. गॉट इट? तुम जो कैजुअल बाबू ये मत लिए, ते मत ले, ऐसा वाला ट्रीटमेंट लोगे, तो 6% साइड इफेक्ट प्रोफाइल है. एंड नर्स जैसा ये लेना मतलब लेने का है, कुछ नहीं चलेगा. साउथ इंडियन लोग बोलते हैं ना, नर्स लेने का है मतलब लेने का है. ओके मैडम, तब वो अप्रोच विल हैव अ लेस side effect profile and more mortality benefits. So that's the indication from this heart failure trial that you have to give appropriate optimum dose of Fantastic 4. सीक्वेंस कैसा भी दो, आरनी, बीटा ब्लॉकर, एमआरए, इधर डालो, उधर डालो, आज ये डालो, but within 1-2 months, all patients should be on this particular Fantastic 4. Then only you get a fantastic result. And in spite of this fourth treatment, Fantastic 4, still there is 14% increase in the, not increase, there is remaining mortality 14-15%. So where are we lacking? Or any additional molecule? Yes. If there is, in spite of all these four things, if there is worsening of the heart failure, we have to search for some other molecule. We have to continue these four things. So that molecule is known as Verquio. Okay, this is what the Victoria trial, which shows Verquio is a molecule which acts on a cyclic GMP, which increases the coronary vasodilation, reduces the myocyte hypertrophy, and inflammation is reduced. And listen now, very carefully. This molecule, Verquio, okay, reduces 10% mortality and hospitalization. You will say, "Arey, 10%? के लिए इतना लेक्चर सुनना है तेरा?" But mind well, there is already 75% relative risk reduction by this Fantastic 4. This is additional 10%. It become 85%. Got it? समझा? बाबू समझे क्या? समझा? समझा पड़ेगा. ठीक है? So additional 10%. See, after Fantastic 4, there is very limited scopes for drugs. So additional 10%. So don't go and very 10%. It's a significant reduction. And with only one trial, they have approved, the USA FDA approved this molecule. So this will cancel because of time constraint. This is the Fantastic 4, that is SGLT2, DAPA, paradigm trial is for ARNI. The results are equal or even better than all these things. So you have to add this molecule. Better you ask me to add this molecule without any side effect profile. Victoria trial has shown that Verquio, given with adequate dose, there is no side effect problem. Okay. So when to add this Verquio molecule? Because you all know this Fantastic 4, so you will start that. What next? Send to me. I will say, okay, I will add Verquio. You will ask me, what is Verquio? I will say, okay, it is a metabolic drug which will improve the nitrous oxide, improve the LV function. But कब डालना है? When to start that molecule? We have to start if patient cannot take all four molecules. दो ही ले सकता है. Add करो ये. Safe molecule. If in spite of optimal dose of Fantastic 4, there are symptoms, add this molecule. Okay? Or if there is side effect profile of one of the molecule, add this. So Fantastic 4 must be given. Now this is a Fantastic 5th one. Okay? Or any problem with Fantastic 4, you add this molecule. So this is about the treatment of heart failure. ARNI, beta blocker, MRA, SGLT, and Verquio. That is and then, in spite of all these 4 or 5 medicines, there are certain things where we have some lacunae in the management because we don't titrate the medicine. एक बार लिख दिया कि it is not, feel it, forget it. We have to follow the patient properly. Okay? Beta blocker, हमने दे दिया, metoprolol दे दिया. कितने लोग metoprolol, heart failure patient, you are all senior people. Patient of LV function 20, 30, 35% come to you on metoprolol. कितने लोग will change the things or continue करेंगे? Will change or will continue? Evaporating has other indications. Optimized dose. पर कौन change करेगा? Metoprolol continue करोगे या बंद करोगे या दूसरा चालू करोगे? Continue, very good. Continue वाले हाथ ऊपर करो. Okay. Discontinue वाले हाथ ऊपर करो. दूसरा चालू करेंगे. दो ही हाथ. बाकी लोग क्या करने वाले? ओके, जिन्होंने कंटिन्यू बोला है दे आर ऑल रॉन्ग. जिन्होंने डर डर के दो ही हाथ ऊपर हो गए. क्या बोल क्या हाँ वही बोला, दो ही हाथ दिखे मेरे को. ओके, ये हाथ मुझे दे दे ठाकुर. हाँ, only there are two hands that they will change the metoprolol. Yes, you have to change if the patient has diagnosed heart failure patient, you have to change the metoprolol. Although guideline mentions that you can give metoprolol, you can give bisoprolol, you can carvedilol, but I am saying that there are 4 trials. There are 4 trials which have shown that carvedilol is better than metoprolol. Not in mortality, in morbidity also. So when there are 4 trials which are showing that carvedilol is better than metoprolol, then why to continue that? It is not hypertension. If patient has only hypertension, no heart failure, I will say okay, continue, no problem. But those who raise the hand, for them, please change the metoprolol to a bisoprolol or to carvedilol in a heart failure patient. समजलं? Take home message. उद्यापासून सर्व मेटाप्रोल बंद करून टाकायचं. दिस लेक्चर इज नॉट स्पॉन्सर्ड बाय कार्डिओलॉल. डिस्क्लेमर आता नीचे. दिस पार्ट इज नॉट स्पॉन्सर्ड बाय. ओके, इवन bisoprolol is also another good molecule, but there is no head-to-head comparison with biso and carvedilol. Carvedilol has additional alpha blocker activity. So when there is alpha blocking, there is a vasodilation. Okay, so heart failure patient, carvedilol or bisoprolol. Nebivolol has also good trial in a senior patient known as senior trial, but nebivolol still not recommended as a drug of choice in heart failure patient. Okay, second, go on increasing the beta blocker till you get the heart rate of 65. If you stop at 80, you are doing negligent practice. Sorry, I am using very harsh word, है ना? Harsh word, absolutely. Okay, because you are dealing with the life of the patient, boss. Got it? अगर 80 ब्यूटीफुल ट्रायल हुई थी इवाब्राइडिन की, समझते इवाब्राइडिन की, that miserably failed. More than 50 नेशन में होता, huge trial, miserably failed इवाब्राइडिन की ट्रायल. Then they do sub analysis. उसमें देखा heart rate if above 70 it is failing, but heart rate below 70 it is having a great result. Then the SWIFT trial came, then other trial came. Now evaporating is one of the good molecule in heart failure. ठीक है? So heart rate is very much important. Take home message, right? So bring the heart rate between 60 to 70. 65 is very simple. What is sinus bradycardia? Heart rate below 55. So you can bring the heart rate up to 60. Then MRA, ultrasound. I am telling you, ultrasound is a very detrimental molecule. Produces lots of faltu inflammation, prothrombotic effect, myocardial fibrosis, all these nonsense things are produced by aldosterone. So you have to give medicine to block the aldosterone. फिर पहले क्यों नहीं करते थे? पहले नहीं करते थे because what happened? RAS inhibitor दिया, for example ACE inhibitor, ARB दिया, so it will suppress the angiotensin 2 also and aldosterone also. So no, aldosterone has some escape route also. So we have to give not only ACE inhibitor ARBs, but we have to give some molecule which are going to affect the or block the aldosterone. Clear? So this, although aldosterone is a part of RAS system, but we have to treat these two molecules differently, that is angiotensin 2 and aldosterone. Got it? MD guy? सीख रहा है तू? MD में? It is very soothing when your son listens to your lecture and says, Daddy, you spoke well. Very emotional. My both all three daughters, one daughter-in-law, daughter and son, they are listening to me and Papa, masta bolta hai na? Even same expression in your face also. Anyway, ये जो पंच आते हैं ना, तुमको अवेक करने के लिए और कुछ नहीं है. Okay, so counseling is very important. क्या होता है? As soon as patients start feeling better, they stop or they try to reduce the medicine. Human psychology. अपन लोग भी एक simple URA हुआ, hardly anybody takes 5 days antibiotic. 2 दिन 3 दिन लिया, अभी जान दो, छोड़ दे. ये ह्यूमन टेंडेंसी. वी डोंट वांट टू टेक मेडिसिन. सो टेल दैट, काउंसिल दैट, अब हमारा ये सॉर्ट ऑफ नॉन क्यूरेबल डिसीज है, you have to take the medicine. Unless you treat the medicine, you will survive. Tell frankly, but in a decent word. डराओ मत, but make him realize. So counseling is very important. Smoking, okay, थोड़ा सा पीता हूँ, थोड़ा सा नहीं, एक बार हार्ट फेलियर हुआ, थोड़ा सा स्मोकिंग is also poisonous, okay? तो slow poisoning. So stop smoking. Alcohol, आज अंगूर की बेटी से है ना, कुछ तो भी दारू बोल रहा था, कोई दारू का ना, okay? Absolute stop. It depresses the myocytes. Okay, वो HDL1, HDL2, HDL3, कार्डियोप्रोटेक्टिव, फ्रेंच पैराडॉक्स वगैरह फालतू बातें नहीं करने का. Okay, 1 peg a day keeps doctor away. बिल्कुल नॉनसेंस है ये. Okay, तो कोई अल्कोहल, कोई बियर, कोई nothing is going to protect your heart. Okay, it may relaxes you for a moment in the night, sometimes in day, Sunday also. But these things are faltu. It is never a protective of the heart. Okay, stop alcohol. Immunization. Heart failure patients generally have lungs congestion. Lung, when they are congested, they are prone to develop infection. Once they are develop the infection, that is the commonest cause of mortality in elderly. Most of the patients die because of the pneumonia. So they should be given immunization properly. Diet has to be properly. Heart failure management is not a one-man management. You have to have cardiologist who doesn't have time, who has to have physician, again he doesn't have time. So you have to have a combination of dietitian, physiotherapy, counselor, cardiologist and physician. Okay, then only patient can survive 8 to 10 years. Okay, because patient, because of congestive heart failure, there is less appetite. So भूख लगती नहीं उसको, तो less लेता है तो less protein, तो again affect on the heart. So adequate diet, properly designed diet, fluid to be restricted. On one side you are giving MRI, you are giving diuretic, on the other side you are asking patient to drink the water. क्या मतलब है? So restrict the fluid. आजकल क्या होता है, सवेरे उठने के बाद मैं 4 लीटर पानी पीता हूँ, 2 लीटर पानी पीता हूँ. योगा वाला है, with due respect with yoga. Yoga is a fantastic science, know about that, but it is not to be generalized. Okay? कितने पेशेंट आते हैं, सर मैं उठ के 3 लीटर पानी पीता हूँ. अरे अच्छा है, इसलिए पानी की किल्लत आ रही है ना? अन पेशेंट मतलब मैं दम लगता है मेरे को, फिर मैं लैसिक लेता हूँ. अरे ऐसा क्यों करता है? So restrict the fluid. If the lower the LV function, lowers the water intake. Otherwise, so a normal person also reduce intake to 2 liters. In a normal person, age more than 50, hypertension वगैरह, no, less water, right? Salt less. India is a country of spice, right? सब में अभी नया फैशन, फ्रूट की डिश में ऊपर नमक डालते हैं. अभी वो स्वीट है फ्रूट, उसको नमकीन क्या, दिस इज व्हाट एंड द रिक्वायर्ड सॉल्ट इंटेक इज 3 ग्राम, 2.8 ग्राम्स. मोर प्रिसाइज 2.8 ग्राम्स. 3 पकड़ो, नहीं 3 बोला ना जनरलाइज होता है, 2.8 बोला ना, अरे क्या नॉलेज, इसको परफेक्ट बोलता है ना. Okay, so 2.8 ग्राम is a requirement. अपन सिर्फ उस पे डालते हैं फ्रूट पे, okay, या चम्मच साइड में लेते हैं ना अपन इंडियन डिश में. That is itself is the quota of your entire day. So restrict the salt. क्या है, ठीक है. Exercise, ask them to walk. There has to be some circulation, blood flowing here there. बैठा रहेगा तो हार्ट बैठेगा, सब कुछ बैठा रहेगा, ठीक है. कब उठ जाएगा समझेगा नहीं, तो मत बैठने दो उसको, थोड़ा एक्सरसाइज करो, बोलना बैठे बैठे थोड़ा चलो हल्का. Ask them to do some activity that will not only improve the circulation, improve the appetite also. So properly designed exercises. Again, you require exercise or yoga physiotherapies for this. Okay, you have to aggressively treat the risk factors. And anemia is a very common things occurring in the heart failure because of GI condition, nutrition less, and because of satya dekho. Anemia is a independent risk factor. Yes, पहली शिंक उसके लिए थी, and we have to treat that. शिंक दूसरी उसके लिए थी. So you have to treat the anemia. Anemia previously used to be treated by erythropoietin, but nowadays we don't recommend the erythropoietin as a treatment of anemia and heart failure unless your kidney disease is there. But we are giving intravenous iron. Mind well, oral iron will not act or act after 1-2 years. Tab tak Ram Nam. So patient should be investigated nicely. Not only hemoglobin, just HB to normal at 12.2 है. क्यों दूँ? No. Check the ferritin level. Check the transferrin level. If transferrin level less than 20, you have to straightway give IV iron. And that is only a molecule is known as. तू सारा सर्जन है कि कार्डियोलॉजिस्ट हो गया? कुछ भी बोलते रहता है. Okay, so give ferrous क्या बोल दे? हाँ, ferrous कार्बोक्सी मल्टी. वो डिफिकल्ट वर्ड है, इसको वाला तू बोल बाबा, है ना? वो बोलते ना, एडल्ट 60 इयर्स का आता है डॉक्टर के पास, निमोनियाचा तुम्हाला त्रास झाला होता पूर्वी? हो, लहानपणी तर स्पेलिंग नव्हतं आलं मला. Anyway, like that. So anemia is an independent risk factor. 1, it has to be treated. 2, it's not to be judged from the total hemoglobin. 3, you have to do the iron study. 4, and give IV iron therapy, preferably injectable only, and the good part, only 1 injection per month or 2 months, right? So that is what the oral therapy is not effective. So this is what the take home message. So iron deficiency is common, and intravenous carboxy maltase, likha baba, is the only drug of choice. So dear friends, so Fantastic Four, you people are fantastic, so start Fantastic Four immediately. 5th Fantastic Person is standing in front of you, send for very good. I will start that because he has niche indication for that, and you have to treat the patient entirely, body weight, appetite, weight कितना है, पानी कितना पीता है, खाना कितना, नमक कितना, all these parameters you have to check it properly. All these factors you have to treat properly: diabetes, hypertension, obesity, and all these things. And when all these things fails, send to Dr. Ratnaparki, Guru Krupa Heart Center. Then further management, I will do angiography, I will do angioplasty, open the artery, make the heart normal. If not, I will say send to a surgery. Surgery means cardiovascular. तू ऐसा कान मत खड़ा कर. Not a general surgery, cardiovascular surgery, for bypass surgery. If there is a MR, because in fact papillary muscle dysfunction, MR is there, patient goes into failure. So valve replacement, permanent pacemaker, what we call the biventricular pacing, cardiac transplantation, and ventricular assist devices for time being. So these are what the various treatment. Bypass surgery, cardiac transplant is doing very well in India, in Mumbai also nicely. Till you refer or you get a heart nicely, okay, दिल देने वाले बहुत मिलते हैं ना, लेकिन जब actual दिल लग जाता कोई देता नहीं, okay. So till that time you get the heart, we can have ventricular assist devices. These are the diagrams of devices. The cardiac resynchronous therapy, if there is LV function is very low, is the end stage heart failure, not responding to our Fantastic Four or Fantastic Five, but you have to give adequate optimum dose of Fantastic Four, 5 before sending patient for biventricular pacing. Agreed? So, and the indication that there has to be LVBB. If patient has RBB, straightway discarded. कितने पेशेंट मुझे भेजते हैं, अरे इसका क्योंकि ऐसे लेक्चर सुनते हो, अरे पेसमेकर डालने का, पेशेंट है RBB, इसको क्यों नहीं डाल रहे रत्न की? Okay, तो RBB है, it is gone, no indication. LVBB है with QRS more than 130, then only it is indicated. Okay, this is what various indications of biventricular pacemaker. So dear friend, this is what the treatment of heart failure. Thank you very much. Again, as like last year, everything was so lucid, so no questions. Yeah? Thank you.
Thank you, sir, for that amazing lecture. To felicitate Dr. GPR, sir.
Next lecture, we are already running behind. Thank you very much.
We will move to the next lecture.
We'll continue. Of course, not tired. Fantastic. You are a great people. You people are great. Amazing. Please, ताले बजाओ मेरे खुद के लिए भी मेरे लेक्चर के लिए भी. कहाँ अनिल भरा है ना? Anyway, चलो fine.
चेक करूँ.
Bumper draw. Last है ना? हाँ. आहार, विहार, विचार and आचार. मेरा को पूछो नहीं. मेरा सेंटेंस है. आहार, विहार, विचार एंड आचार. आचार मीन्स जो आपके विचार है वो आचार में आना चाहिए, उसको विचार बोलते हैं. वैसे हरि वरी करी, यार मेरे 3 पेपर में आज आर्टिकल आया, सब इसमें लिखा है. ओके, सो हरि वरी करी, यू हैव टू बरी. ओके, हरि मतलब घाई मत करो, वरी मतलब ज्यादा चिंता मत करो, करी मीन्स मसाला मत खाओ, यू हैव टू बरी, हरि वरी करी. कविता होगी ना? यस, थैंक यू वेरी मच. आई विल नॉट get felicitated myself because already I have taken enough time of you all. Thank you very much.
Our next speaker, Dr. Sanjay Ratnaparki sir. He is a senior pediatrician and owner of Chiranjeev Pediatric Hospital, Yavatmal. He is trained in hypnotherapy, yoga and meditation, skiing, scuba diving and paragliding. Today he will talk about the neuro-experimental model of healing heart. Please welcome Dr. Sanjay Ratnaparki sir.
Hello, how are you? Tired or fantastic? So you are listening to Fantastic 6. Are you ready to listen to Fantasy 6? Yeah or no? Yes. So this is for the first time which is happening. When you listen to a cardio conference, we always get bombarded. The only drugs are the treatment for heart. Yes? Is it heart gulam of drugs only? Can heart be healed? Does heart have its own healing potential? And that is what neuro-experimental model is. So let's start with this. मेरी उम्र के नौजवानों दिल लगाना ओ दीवानों, क्या कभी तुमने प्यार किया है? मैंने भी किया है. The love is the first neuro-experiential model you experience. Yes or no? क्या होता है? दिल में कुछ कुछ होता है, सपने आते हैं और बड़ा अच्छा लगता है. हाँ या ना? So now looking into your body, heart remains in the body. Just like a tomato soup, there are crumbs. And it is governed by brain. When you attend any cardio conference, you feel only the world is heart, but heart is in the body. And imagine when you are in love, there is a classical expansion happening in the body, which is being felt inside, and that is a very So what we are talking about the states, the first state, please listen, this is very, very important, because heart is the slave of the states. And heart is suffering because of persistently remaining that state for longer duration. To understand this, are you ready to make an experiment? Can you put your hand in front of mouth and just blow it forcefully? Just do it. Follow. And see what happens. What is your experience? Do it. What is your experience? Can you share? Your hand is feeling warm. And we have misconception that kidneys are only our X-ray organs. Lungs are our base X-ray organ. They release the heat because your hands are feel warm. Skin is the X-ray organ which is releasing lot of sweat. That is another very important organ. But we only think kidney is the organ. Now why it is important? Now let's take another experiment. Put your hand again. Do it practically and blow very slowly. See what happens. Experientially, see what happens. Have you noticed some difference? Have you noticed some difference? What is the difference? Yes. When you blow slowly, it become cool, and when you blow fast, it become hot. This is, and we are what? We are heat producing or energy producing human beings. And simple changing your breathing can give good rest to the heart. Simple changing your the breathing. And you will be very surprised to understand this experientially. We are going. So what we have learned, this sympathetic expanded state like this here, when you feel good expanded, where circulate good, what we are talking love. Okay, and then you get married, and when you get married, you start something, a constrictive stage, and this happens. And then what happens? Okay, you are feeling the place. Now, initially you are expanded, just like picnic board. Then the life doesn't become that smooth. Something goes. Another animal is coming with the same fierce environment, and then start. जैसे को तैसा मिला, बड़ा मजा आया, मारू की तोड़ू की तेरी टांग तोड़ू की बता तेरी मर्जी है क्या? And that fight reaction is stored in the body. And imagine, go within yourself. If you are in constantly fight mode, and if you are not discharged, then that reaction goes within body as a brain, neuro experiential understand, and you remain in that mode for longer, probably years duration. Go within. This neuro experiential model is telling you in what state you are. And if you are in constant fight stage, what happens? You are in a constant sympathetic activation. And when you are constant sympathetic activation, heart start, thak, 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 thak. And therefore you are getting the blood pressure. Because you are not released. If I jump 2 or 3 times, I will definitely get a blood pressure. But it becomes normal. But if you are constantly in fight state, okay, maru ki todu ki list state, and if you are not able to release, the blood pressure persists, and we are giving only drug for a year together, we have never changed the state. Is it not important to understand? Yes? Yes, thank you very much. And then again what happens? You get another mode. मुझे मेरे बीबी से छुप जाओ, झगड़ती है, ये लड़ती है, हमेशा बात करती है. And you start, you are immediately in the flight mode. You are constantly running away from situation and you are not released again. So if human biology works on very simple principle, either you escape or escape is not possible. If you escape, healing happens, and if escape doesn't happen, healing doesn't happen, and therefore you remain in persistent flight state, and because of this persistent flight state, your heart starts racing, and therefore you get tachyarrhythmias, and you are giving lots of medicines for years together. You don't heal because you don't change state. Are you convinced of this very simple thing? So technique is how to release the state, how to change the state, and this is the state of coherence which people are working now. Incoherent state, persistent tachycardia, or persistent arrhythmias, because you have never changed your. When you say beta blockers, what does beta blocker do? It enters sympathetic. Yes. So you also have inherent power within yourself to antagonize that sympathetic system. Are you clear about this? And then we go on to, so this sympathetic expanded when you feel good, sympathetic constricted when you fight, and sympathetic constricted when you feel fight. These are 3 states. Are you convinced of this state? 1, 2, 3. Sympathetic expanded, sympathetic constricted, fight, and then flight. Let us go to other area. You grow with the experience, you learn, adjustment in your life, but it becomes too suppressive that you cannot accept, and then you say, Then you say very important, समझौता गमों से कर लो, समझौता गमों से कर लो, जिंदगी में गम भी मिलते, and then you become sad or you become violent inside. Externally smiling, but internally violent. And when you are externally smiling and internally violent, what happens? Okay, your another system get activated, that dorsal vagal system, where your heart is being compressed. If you see yourself, your body always goes in a state of expansion and de-expansion. But if you remain in SAB mode all the time, your whole body gets constricted and you are violently inside. And when a dorsal vagal nerve gets activated, your heart becomes bradycardic but not released. And remaining in high dorsal vagal state for a longer duration are going to get bradyarrhythmic disorders, and therefore heart disorder is coming. Again, you can change your state like this here. So this is the removing compression and coming into stage of coherent state is the answer for this. Okay, and then again as you progress in life, the sadness comes. और नहीं बस और नहीं गम के प्याले और नहीं, and person becomes sad like this here. Person cannot cope up with the environment and the stage comes, depressive state comes, heart going in depressive mode. This become more for longer duration, and again the person loses the interest in surrounding, and that cause another low dorsal vagal state where you are going to get a heart disorder. There is the reason for failure. There where because heart cannot compare, because heart have not taught how to change the state. And if you can change your state voluntarily by proper training, it is possible that you can heal your heart. Are you convinced of this very interesting thing? But because we are not taught, we are taught only drugs are solution, but we are not taught your internal body is designed for healing. Okay? So, what we have learned? Sympathetic expand state when you feel good. Sympathetic constricted when you feel constantly agitated. Sympathetic restless state, again sympathetic constricted, we are feeling anxious. Then high dorsal vagal state, everything compressed inside with increased muscle tone, tightness body, where your body is working more. And sympathetic, means parasympathetic given up state, compressed state, it has lost everything like this here, a sad mode, where heart is also working for that. But in another state, parasympathetic expanded, that achieving a relaxed state in the mind and body, so that you can maintain a coherence internally, can change your life. Okay, getting trained yourself can change your life and can change your attitude, and that is the exact reason why I am going to coming like this here. So learning to change the state, because you remain with you 24 hours, and if you learn this ability to change, understand this orientation and change yourself internally, it is possible you can heal yourself, and this is what a model is. Now, is there anyone in the audience who is having mild blood pressure? Can come forward and I can say how this can be done. That was the intention to bring this. Anybody? Anybody in the audience who is having mild blood pressure? Anyone like this? Just a physician better one, and come forward, just. And how the things are being done. That was the intention of bringing this, what is called a neuro-experiential model. Are you convinced of these stages? Yes or no? Clear? Any confusion? You can ask me any question. Sir, please. आराम से बैठिए. सबके सामने बैठे. Anybody you can ask me, because up till now, this is not taught in any of the conference here. Or if simple meditation would have caused, it is not. Swami Vivekananda was the greatest person in the field of meditation, but he still could not, because this is deep subcortical way. So, animals, they don't get blood pressure. They are mostly threatened. But why we are getting this? The reason is that our neocortex inhibition, the things, subcortical things work differently and neocortical things work differently. Okay, are you getting my point here? So we are analyzing and changing the perspective of looking at yourself. Sir, welcome please. Is it possible to remove the shoes and feel your ground? May I know your name, sir? Can somebody give mic to him? Only I taking 10 minutes only to just develop how the thing can be done. Is okay? Huh.
Jai Prakash.
Jai Prakash. Sir, please give a big hand for Jai Prakash to come here. Okay. Huh. Sir, as you came here, from here, how do you feel in your body at the moment? Normal. How do you say it is now? What is happening? Now close your eyes for some time and see what is happening inside you. What is happening inside you?
Nothing. Normal.
Nothing. And notice your breathing. Notice your body.
Pardon?
Notice your breathing. Notice your body for a moment. And gently open the eyes, slowly, and look around the people. Very slowly look around. Look around the people. How are you feeling now? You are normal. Now, sir, we say normal many times, but most people when they come from here, they feel what is the palpitation, restlessness, because we are accustomed to some new environment. But those are used, they may not see. But sir, let me ask you, any experience recent time which was slightly triggering to you? Any since when you notice your blood pressure?
Since long.
Since long? How many days?
More than 30 years.
For 30 years. Would you like to tell me about your any experience which was slightly overwhelming to you? Something which was disturbing you? Anything?
Nothing in particular.
But at the moment, how is your mouth going? Is it dry or moist?
Normal.
Huh?
Normal, not dry.
No. When you say normal, it's different. But if you touch your tongue to the hard palate, how do you feel? Is it dry or is it moist?
It's dry.
Dry. So, dear friends, of course, we don't have that much time. So, intention when a person to call here is notice the body dynamics. Okay, what is the body dynamics? If you just close your eyes for a moment, your breathing is not normal many times. Your breathing is many times irregular. But moment you come, it having innate tend to become normal. So, normal means resting a peaceful rate. Now, if I ask you to tell me any event in your life which was challenging to you, is it possible to tell me? Any event? Something, at present not, you may not remember, but something which made you excitable or made you something, or what, how is your nature, by the way?
Normal nature. Normal nature.
Normal. What are the things which you like the most?
Pardon?
What are your interests? What do you like most?
Nothing in particular, just normal life.
So most of things we tell normal. But if you ask the people to go what are your challenges, and if that image comes, some disturb, body get disturbed automatically in form autonomic dysregulation, and that you go into those stages which I was telling you. And that remains for some time and then gradually it become down. Is making sense something? So the way, from today, the way you get dysregulated and time it's required to regulate you is the optimal time, and your body is having inherent capacity to deal that. And that is how a healing starts. If you are become aware of your disturbances, then things can come to your own orientation and you can make the changes. So this is the meaning of what I mean Of course, this is a very, because it is not possible to have a longer session. But if you get a longer session, body is going to respond in the form of sweating, in the form of tightness, in the form of breath holding, and in the form of emotion, they come like this here. And when they come, titrating those emotions can heal yourself, and is a very, very important way to heal you. Are you getting my point clear? So, but that can be evaluated in a person. Up till now, most of the time, we are not aware of these things. But if you pay attention very closely, you can pay attention to your breathing, your muscle tone, even sweating, your this. These are the release phenomena which happens in the body. Okay, so be aware of this so that you can get. Okay, so give him big answer. Thank you.
Okay.
Any question you want to ask about this? Because it's very short process, I could not take it in detail. But understand the state in which you are in always, and you can gradually down-regulate state. Okay? See, simple yoga is not going to solve the problem. It is the ability to expand our dysregulation and bring into coherence. That is the most important. Okay, that is the most important. So, understanding your state in which you are. Okay, thank you, sir. Thank you, sir. So, how the healing happens? Ability to understand your state, in which state you are, and developing ability to bring into the coherent state. That is the secret. Thank you.
Thank you, sir. Mike.
Yeah.
Mike. Mike. Hello. Thank you, Dr. Sanjay Ratnaparki, sir, for that extraordinary talk. For felicitating Dr. Ratnaparki, sir, I would like to call on stage Dr. GPR, sir, Smruti Madam, Dr. Ram, Dr. Dadish,
Hello.
Dr. Seema.
He was already felicitated 2 times by both the chief guests. I will felicitate by just touching him the feet. Bada bhai hai, okay, always keep us blessing, okay? Hey, chota bhai Ram. Okay, chalo, thank you.
Thank you so much. We will now move on to the felicitation.
No, हाँ, felicitation, हाँ. अभी देखो बहुत important announcement. जब भी मैं स्टेज पे आता हूँ कुछ ना कुछ दिखे जाता हूँ. अभी ये सर किधर गए? हाँ. डॉक्टर ब्रह्मा भट्ट सेम दिखते तुम दोनों. हाँ. ब्रह्मा भट्ट का लेक्चर के बाद there are 3 bumper prizes and 12 नहीं हंसने का क्या इसमें है नहीं मैं मजाक नहीं कर रहा हूँ हंसो मत. So there are 3 bumper prize, okay, and almost कितना 10-15 सादे प्राइस. हाँ तो इतना सहन कर क्या चाहिए आपको 18 अरे हो टोटल 18 एक आपको अगर आप लकी हो तो ओके. बट जो आखिर तक यहाँ बैठता है उनको मिलता है हमारा एक्सपीरियंस है. ओके लास्ट टाइम मैं लास्ट में था एक बचा वाला मैं मुझे मिल गया तो मिलता है. सो 18 sort of what lucky draws are there. So please don't go. Already you have invested your time. Okay और 15 मिनट में कुछ प्रॉब्लम नहीं है. Gifts are waiting there also. More gifts are waiting here also. So if you are lucky, please. And those who are present in the hall, they will only get the things.
Yes.
Barabar, madam?
Yes.
Okay. Before that again, see you people have seen so many people are just running around here, ये ला रहे, वो ला रहे. उनको एक छोटी सी आप शाबाश की दोगे? क्या कंजूस यार, हाँ बोलो ना यार. आपको कहाँ देना है? ओके तो शाबाश की देने के लिए लिस्ट बताओ फटाफट.
Dr. Deepak Desai.
All president, all secretaries come on the stage. This delay.
President AMA Dr. Ashok Singh, President MCP Dr. Shashank Shah sir.
आज accept करता हूँ delay हुआ because both the chief guests came on a different time. So entire procedure we have to. Normally last year both the guests that Govindaji and Sudesh Bhosle came on the same time. So we could curtail that 1 hour. Huh? So please bear with us. Okay, every time this may not happen. Okay, so this is all for your entertainment only, with a good blend of knowledge and entertainment. This is all done for you only. They are all my family friends. Okay, I will not say patient, but they are all family friends. So I brought them for you people, not for myself. Okay, so please bear with us.
Thank you. Dr. Lalit Chordia, sir. Dr. Mukesh Biyani, sir. Dr. Anurag Bhate, sir. Dr. Meghna Bhate. Dr. Manoj Patel. Not there. Dr. Pooja Joshi. Dr. Shilpa Bansal.
And last felicitation of my all staff, my extended family member of Guru Krupa Heart Center and Guru Krupa Diagnosis Center. Last 2-3 months, they were all working hard for this conference. Okay, sending letters, calling phone, going to MMC office, calling these gentlemen, giving checks, bringing checks, all these things. So my entire team of Guru Krupa. Okay. Okay. So under the leadership of course, Dr. Ram Chavan, Dr. Anil Kumar, and manager Vinita Kadu, Meena, Niyati, all these things, and 4 people, they were all running around. Dinesh, Nilkant, Swapnil, Mitesh, all these people are running amount for you people, right? So entire team Guru Krupa. या लवकर. And this is the last felicitation. So you can breathe a sigh. You can take a breath of sigh. Time for first bumper draw. मैं निकालू, चलेगा? किसका निकालना है? 12. सो सर ने बोला मेरा निकालो. हाँ, मैं आपके तरफ देख रहा हूं और मैंने मेरा निकाला. डॉक्टर प्रदीप कक्कड़ है? नहीं है इसलिए ताले बजा रहे हो?
नहीं है इसके ताली बजती. पढ़ दो, पढ़ दो.
चंद्रशेखर यादव.
वाह, बम्पर.
चल ना. Still there are 2 bumper कि 3 bumper?
3 मध्ये 1 गेलं, 2 ना?
नहीं, 4 होते. एक जब बचा के रखा था मैंने ये लड़की के लिए, है ना? तो there are still 2 or 3 bumper and 14-15 moderate price.
Congratulations, Dr. Yadav. Now we will move on to our next and last lecture of the conference. Our next speaker, respected Dr. R.J. Brahmbhatt, is a director at Kama Institute of Sexual Studies and consultant at Nanavati Super Speciality Hospital, Sexual Medicine. He has many prestigious awards to his name. Please welcome Dr. Brahmbhatt sir on dais. He will talk about erectile dysfunction, equivalent to heart disease.
फॉरवर्ड बैकवर्ड एंड दिस वन इज फॉरवर्ड है इधर है. 1 मिनट. फॉरवर्ड बैकवर्ड. ग्रीन वाज दी फायर फॉरवर्ड. ओके मैडम, थैंक यू वेरी मच. आराम से, आराम से, आराम से. एक ही रखना. नहीं नहीं नहीं, एक सेकंड. फुल चाहिए मेरे को. ये नहीं चाहिए, ये नहीं चाहिए, सेकंड नहीं चाहिए. तो पूरा ही रख. नहीं नहीं, फर्स्ट पे आ जा. अभी उसको फुल चाहिए. फुल स्क्रीन.
फुल स्क्रीन हो जाएगा, दिख जाएगा आप. वो टीवी पे दिखेगा.
मेरे को ये नहीं चाहिए.
मीन्स
नॉर्मली होता है ना, समझ में है ना? आपका पर्स कौन सा है? बस. गुड इवनिंग फ्रेंड्स. गुड इवनिंग. गुड इवनिंग. That's very good. I can imagine just now, I'm not joking, in my smart watch the message came. You have not slept last night. Can anyone tell why sexologist does not sleep at night? Any guess? Haji? Patient's call. Oh my God, that I'll tell you at the end. Anything? Anybody? Haji? No. Partner, she was with me only. No, it came that last night I just finished AGM. I have been Where is Dr. Ram? And where is Dr. Ratnaparki? Please come here. You can't run away. नहीं नहीं इधर आइए, इधर स्मिता के बाजू में बैठिए. हाँ नहीं वही उसके लिए रत्नापारकी को बुला रहा हूँ. Because he has made, these are the two people who has made my life miserable. So please give them a first big round of applause. और नहीं आज तो डर क्या लग रहा है सूर्य रत्ना. What has happened, you know, that okay, free, sorry. और चौथा भी उधर बैठा है. वो अच्छा, now listen to me very carefully. ओ बेटा इधर आ जाओ तुम भी. I don't want to go because सुबह से बिठाया मुझे, अभी मेरा चांस है. बरोबर है? Right. So I don't know from where to start, but let me start. That मैं जब पहले बोलता हूँ ना, फर्स्ट नाइट को सबको दुख 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 होता है. और मेरी फर्स्ट नाइट की बात कर रहा हूँ. आज आप लोग की जो स्थिति है मैं जान रहा हूँ व्हाट इज हैपनिंग टू यू. फर्स्ट नाइट सब विधि हो गई, रिसेप्शन हो गया. आई वेंट टू माई होटल रूम, यू नो, टाई बाई था, कुर्ता लगा दिया, जरा गजरा बजरा बांधा. एक दिन 2 ग्लास दूध पी गया. और मिठाई का भी कोई पैकेट देके गया था रत्ना जैसा, तो वो भी उसमें से खा लिया. एंड अगेन आई एम गोइंग रेस्टलेस, इधर उधर इधर उधर. तो आई थॉट नॉक आया. ऐसे दिल की धड़कन दुर 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 वो आया थे कि ये अंदर. तो उतने में देखता हूँ तो चोटी वाला गौर महाराज आया. बोला कि अभी अभी मुहूर्त में पता चला है कि आज रात को वो नहीं आ सकती है, कल सुबह को आएगी. तो आपकी हालत सुबह से बैठे है कि अब डॉक्टर ब्रह्मभट्ट कब आवे कब आवे. तो यही मेरी जो हालत थी वो फर्स्ट नाइट को, तो आज आपकी हालत है कि यू आर ऑल वेटिंग एंड दे सेड दे विल वेट फॉर मी. I'll start with the thing about 15 days back. Ram called me up. इसे मैं राम बोल रहा हूँ. मैं बोला राम तो आया तो बहुत अच्छी बात है. Then he said, I'm speaking from Juhu Gali. At one end of the Juhu Gali is Ratnaparki and Ram. Other end I am there. And in between you can think BMW showroom is there. So either he is earning more or I do not know. But all of you see that he is earning much more, and that's why the BMW is put over there only. Now, Ram called me that on 29th, sir, you are coming. I said, where? He said, at Lalit, and there is a talk. I said, wait a minute. And believe me, whenever call comes from Ram, so I just started looking at my diary. I was at Delhi last week. Monday I came. Immediately after the Monday, I went to Pune. And I was in Pune and I knew that 29th there is something. How many of you have seen Zapurza Museum? So my talk was there. And I said, Hatke, because it's a cultural center. So I said, what I'll give over there? Osho, sexopher of 20th century. Because Pune में है और ओशो की बात ना करो और सेक्स में तो कैसे चलेगा? And that's why I said, I will be there. But when the request came from our friend, that you will have to be here, and I said, I will never say no. Because there is one person. Let me have disclaimer. Neither Ratnaparki has got sex problem, nor I have got heart problem. Am I right? But he is one person whom I cannot refuse. He gave me Lifetime Achievement Award for Andheri Medical Association. It is nobody but he. And that's the first time I heard his voice. He said, I'm a Ratnaparki, and I was surprised. I have never heard about him. And whenever he calls, see, look at this. It's a festival. And I don't think that I will miss a chance of attending such festival. But I said, I'm there, what to do? Last night, AGM lasted up to 11 o'clock. Then there was a dinner. Then there was some music, Lavani. The whole night I had not slept. And I told Ram, I said, you know, I'm worried. If there is a traffic jam, what I will do? He said, Dr. Ratnaparki said, if you need, we'll send you helicopter, but you will come here. And I was here 5 o'clock in the morning, I got up and sir, I am here the first person to enter. So let's start with our talk. And it's going to be very interesting. All of you are sitting here. I am not going to disappoint you. Let me tell you, your personal life and professional life, both will improve. And he put one more thing. He said, my 3 children are there. So ये सेक्स में उनको बाहर निकाल दूं के बैठा दूं? No, no. वो बोला बैठा दो because the other day my son took my phone and I said, please, don't open any videos and messages and WhatsApp. He said, Papa, I have already opened. Those are all 6-month-old. We have already got them. And I was worried. And I had prepared an answer for me. From morning you saw सबको रत्ना क्या बोलता है? छोटा करना, छोटा करना, छोटा करना. और सेक्स पे लोग क्या आते हैं? लंबा करना, लंबा करना, लंबा करना. तो I said, मैं केरी तो हालत एकदम खराब थी. So बच्चे, don't worry. This is very normal. Whenever I have a problem, I know there is somebody who can treat me, and that is Dr. Ratna Parkhi. So, okay, now let's start with the today's topic. And it's going to be a very, very interesting thing. Because every day in the morning, Ram will call up. Dr. Raj, please cover this. Please cover this. Please cover this. I said, shut up. In sex, we don't cover, we uncover everything. So I'm going to uncover, and let's start with the today's talk. So I start with the Kamadeva, the god of love. And second person I remember is Vatsyayana. His Kama Sutra, I had presented a paper in 1983. Till today, every year I have been invited and I talk about it, and it's like a full of pulse. And Ratna and Parkhi. So he knows where the pulse are. And the Ram, Kamadeva is the god of love. So let's start. My today's topic, as you saw, what was the heading? ED is equivalent to heart disease. And can anyone tell me why this word ED has come? What was the, initially what word we used to use? No, not enforcement director. वो आपके पास आएगा enforcement. Can anyone tell for impotency? We were using the word impotency. So Ratna doesn't allow me. He said, I'll give you a complete, long time, whatever time you want. But there are 2 things. You will have to keep my whole audience erect. And second, he said, you will have to quiz. He is master of the quiz. He said, you answer me. Okay, how person is important? I said, very simple. First of all, his main organ is not working, which he called penis or ling. Good. 1 mark passed. What about the second one? Because his recent studies are very much. So I said, sir, second one is, somebody's middle finger is also fractured. And the third, he said, 2 passed, but what about the third one? I said, first one is the organ which is not working due to some disease. Second is middle finger is not working. And third cause of impotency, because the tongue is, which is burnt tip of the tongue. Okay? So please, only children are laughing, not all senior people. So you ask them, they'll tell you the details of it. So ED is equivalent to heart disease, or penile attack is equivalent to heart attack. So we start with it. Kamdeva. Now, whenever there is a heart attack, there is an emergency. We are walking in or going out, and suddenly, and then the ambulance is there. So it is SOS, save our soul. And I can understand. My wife, she had a problem. And believe me, what you call the golden hour, if you go and then you are saved. Otherwise, it's a very difficult task. But have you ever thought, first of all, people are worried that where to go and whom to talk. They do not know whether can I talk to my family physician or what. And let me tell you, I have started my life from a family practitioner. 10 years I have done a family practice in Jugali, and then now I am the senior most and only surviving trustee of the 40 years organization, that is CSAPI, Council of Sex Education Planned Parenthood Federation. All of you must be reading the midday. Dr. Vatsa is no more. Dr. J.V. Bhatt is no more. Dr. Prabhu is no more. Dr. Dastur is not more. C.L. Javeri, gynecologist. So I'm the youngest one, and I will be entering into 8th decade of my life. So this is 40 years I have been just working on a sexual thing. And it is my mission. Tomorrow morning I am going to Bangalore, then Mysore and Chandigarh. I am coming back on 7. But I said, this is my family, and whatever I am going to give you will help you in a big way. So we treat it as an emergency. Erectile dysfunction, we used to call it a impotency. But that is a very, very derogative word. And that derogative word has been removed. Now nobody has a right to say that you are impotent, you are napunsak. The correct word is ED is defined as a persistent inability. Not that Saturday night, after the drink party, after the quarrel with the wife, if one is not able to perform. Nowadays what happens, all younger people comes to me, sir, I have got an ED, as if they have got a PhD. And from where they get diagnosis? Just reading at the Google. And the moment Google Guru says, Google is a wonderful thing, but at the same time, people rather going to a family physician, rather going to a doctor, they just go there. So it is a persistent, minimum between 3 to 6 months. At every occasion, if person is not able to perform, to achieve. So first of all, he should get a desire and then achieve it. Then he should be able to maintain it. There should not be any premature ejaculation, shigrapatan, and he should be able to perform, and not only perform, the partner should be satisfied. And let me tell you one message. Go today, take one piece of paper and another piece of paper, those who have a partner, give it to them. Say that what you want to enjoy in the sex and what she wants to enjoy, and at the end when you see, you will be surprised and shocked. That after 2 children, 3 children, you never knew what my partner knows. My wife will know whether I take a cup of tea in the morning or a coffee, I take a bread butter or a khakra, I take 1 teaspoon of sugar, but as far as the sex is concerned, we do not talk. So most important part is a communication between your partner, and that is what is required. So ED is persistent inability to achieve or maintain erection for the satisfactory performance and satisfaction of the women. Most of the time people uses their wife as a sleeping pill. Moment they feel like having sex, they think there is an erection, they perform, and then she has not reached an orgasm, he goes to sleep. Now all of you have seen that when you start the gas on, it lights immediately. But you put a tawa over it, it takes a time. If you switch on the light, light will come. But if a istri is there, usko garam hone mein time lagti hai. So that is another thing which carry home message, that it takes time for a woman to come up, and she should get a lubrication and she should be ready. She has to worry tomorrow children's exam is there, or Sasu Ma has brought somebody, or something is happening. So her worries are there. So when you enter your bedroom, enter like as if you are entering in a temple. Take a good bath. Think everything, all the things out. Just think about that here what I am seeing is just like a God between each other. That is another thing. And there are many women. People think that multi-orgasmic, they reach orgasm many times. Yes, they have a capacity, and that's why we call women a Shakti, not the men. But as far as the man is concerned, today he has performed, in a young days he will be able to perform after an hour or 2 hours. But as the age advances, it will be tomorrow, next week or next month. And with now lot of illnesses, it still goes down. So this is one thing. And as far as the women is concerned, there are 33% of the women which have never reached an orgasm. So they just remain like this. And these are the people come to your clinic. They say, madam, मुझे कमर में दर्द होता है, white discharge है, आजकल गुस्सा बहुत आता है. And we do not know, and nobody has taught you how to take a sexual history. And that's why this all problem occurs. So the National Institute of Health Consciousness has removed the word impotency from 1992. So all the people sitting over here, from today onwards, you will use only word erectile dysfunction. In my same Juhu Lane, there was one fellow, he was not getting erection. in spite of giving the medication, and a young fellow, 6 months of the marriage, and he said, I am not getting and I have become, impotent. But his wife said once, because there was a fight between her and mother-in-law, she said, you said this much to your mother. And what he said, I can't tell. Father was not there, father had died. He said, she is a God for me. So he said, you are a chakka, you are a pavaya, you are a... And that word killed that fellow. Whenever he used to go near her, that thoughts were coming. And today, I am seeing what I started 40 years back and what I am seeing today. The whole society has changed. You cannot imagine where we are going to and what will be happening, and you just scratch your head. There are many divorces are there. Why? Because we society have failed. This mobile phone is a wonderful thing, but we have started thinking what is in the Western world. Premarital sex is common, live-in relationship is common, extramarital relationship is common. There is no end to it. And I was told that when girls, they want to get married, what they ask, boy, not that what you are earning, what you have studied, घर में dustbin कितने हैं, and how many elderly people are there. So we are going to a different things over there. So when I talk about sex, it is the religion, it is mythology, it is sociology, it is also legal aspect, and last but not least, how medically it will help you people. Now, this is a very important study which you see over here. Now, Massachusetts male aging study, 40 to 70 years of male. And what was the thing? 1,290 and 8 years they have done. And what they found, that 52%, means 52% people sitting over here has got some sort of a sexual problem, erectile problem. It can be mild, moderate or severe. And by the end of 2025, 300 million will be having erectile dysfunction. So all of you just see that by the end of next year, you will be getting some case. But at the same time, there is some good news about it, that at 45% will have a complete erectile dysfunction, 15%, but not necessary occurrence of the aging process. Person can be happy and can have sex even up to the age of 90. If you are sexually fit, then you are physically fit, and if you are physically fit, then you are sexually fit. These are the words you must remember. Now, let's go to the further. Very important for all the women over here to understand that you saw that initially when you got married, by the time you change the clothes, your husband used to get an erection. The moment he used to touch him, he used to get an erection. And now that is not occurring. So why? It takes a longer time for man to get an erection. It doesn't get instant. Direct stimulation is required. She said, all these days I have not done a stimulation. Why today direct? She thinks that whether he has become, interested in another woman, whether I am not attractive, whether he is becoming gay, and all sort of a thing. Shorter duration. The erection comes, but if it is not stimulation, then it will go down immediately. Desire to ejaculate goes away. He may ejaculate, he may not ejaculate. And if the prostate operation has been done, then he will have a retrograde ejaculation. It becomes less forceful. Volume decreases. The consistency, it becomes just like a watery or maybe a drop. And as I said, refractory period lengthens, means today he had, maybe tomorrow, maybe 1 week, maybe 1 month. So these are the things you must keep it in the mind. Now, very, very interesting slide for all of us, because as I said, I was a general practitioner. Endocrine disorder. I remember when I started my practice in 1970, anybody with sexual problem, give 100 milligram of Equavarone. फिर उससे भी अच्छा नहीं हुआ है, I'll give you depot preparation, 250 milligram. And we thought it will give an erection. It has hardly any role. It is on the contrary creating more problem. So if you want to use, somebody is insisting, rather than taking testosterone in the hand, take some multivitamin, B complex, Macalvit of your choice. Let it have a placebo effect that you are giving something. Because If you give a testosterone from outside, the younger people, it will affect the spermatogenesis. And elderly people, you should first examine the prostate. And before you do the testosterone test, you have to go to a proper good laboratory. In the morning, either 3 samples, which we don't do it. Take it, and if it is below the 283, then and then you think about it. But that is not giving help as far as the erection is concerned. Let it be very clear, this message to all of you. So only 6%. And in that, thyroid problem will be there. Prolactin you must do. High prolactinemia, erectile dysfunction, infertility, visual disturbances, and headache. This is, hyperprolactinemia, and they will have less amount of desire. As age advances, like a menopause, like andropause is there, testosterone goes down. Again, that is the time you will find the desire decreases. Second is multiple spinal injury. Nowadays, we see many road accidents are occurring. And that is an L4 and L5 is the center of the erection. Radical surgery. Suppose the prostate has been removed. Now, whenever any of your client goes for a prostate operation, you get the report, you got a PSA, you got a study of the sonography, biopsy is also being done. They say it has to be removed. The surgeon does not have a time. He will remove it. Operation will be fine. When he tries next time, he will see he will have a good desire if it is before that, and if his partner is ready, he'll get an erection. He'll say something is coming out, like ejaculation, but nothing comes out. And then he is tense. Next time he is watching whether I'm getting something is coming out, again tense. Third time he will not get erection. Why that is happening? Because it's a retrograde ejaculation. After the prostate surgery, the sphincter is lost, so instead of semen coming out, it goes behind. And if you want to study, ask them to give a first sample of urine after 1.5 months, after when they have a coitus. Take it to your pathologist, tell them centrifuge, and you will find that there are sperms. So this is very important message, that you tell them beforehand that what will happen. Now here this is very important for all of you. Diabetes mellitus. 40% of the cases are having diabetes mellitus, and we say every 5th person sitting over here may be having mild, moderate or severe diabetes. And vascular diseases, with whole day we are talking about a cardiac problem. So in the end, it is what is common in diabetes and what is common in vascular. And I'll tell you in a minute. And you are treating both the cases every day. Now nitric oxide, this is called signaling molecule. Once you whistle, then and then things happen. These are the 3, Robert Pursgert, Luis Ignero and Farid Murad. They were at different parts in USA. And simultaneously in 1998, they were given a Nobel Prize. And if you understand this slide, you will understand the complete erectile dysfunction. Now you see over here, what is this inside? It is very, very fine. What do you call it? Inner lining. Same thing, all the vessels have got an inner lining. And that is called endothelium. And what happens in the endothelium? The smaller artery. This is what it has been written, nitric oxide, a miracle molecule. Winner of the Nobel Prize now opens up the blood vessel to 62% with just 1 dose. So the penile artery is small, moment desire occurs, nitric oxide, and it becomes, if you see in the morning, when you are giving a gardening, you put a pipe, you put on the tap, and the pipe will become like this. It's a hydraulic. Same thing is opening here, that all the blood vessel, penis is flaccid, it enlarges and it becomes a tight. Younger days, just by thinking it will become like this. Middle age like this, and lower done as about 70, 80, it will be like this if they have diabetes, blood pressure or any other thing. So this is a signaling molecule which is there. Now, normal blood vessels, and it is dilated blood vessel. So this point you have understood, that during sexual thing, nitric oxide is liberated. Now what happens? The major shift of endocrine, so you must think the common factor is endothelium. Diabetes, in case of diabetes, nerves are damaged, blood vessel is damaged, and endocrines are damaged. Next is blood pressure, again the blood vessels, dyslipidemia, lipid goes inside and that creates the arteries, becomes lumen, becomes small. Smoking. First thing, all the young patients of yours, if they are not leaving the smoking, tell them that there are chances you will have erectile dysfunction. And instead of putting, it will kill you, instead of that, on a cigarette packet, they say it will cause erectile dysfunction. I tell you, 70% of the young people will stop smoking. And lastly, age. So as the age advances, our arteries becomes, thickened, and you do not have a good circulation over there. So common factor is endothelium. Now this it is shown at the age of 20, 100% nitric oxide. And what happens? That thickening of artery, inflammation of artery, and lastly, rupture. And here you see over here, very beautifully it has been shown, that this is the arterial wall, this is a plaque, which you have been listening from morning, and this is the blood clot. That makes the lumen smaller and smaller, and that's why this problem occurs. Now, diabetes, hypertension, hyperlipidemia, and heart disease, all of you are treating every day these cases. You are very comfortable in writing any hard drugs, beta blockers or anything. When it comes to the drug writing for a erectile dysfunction, you are worried. Because you have read somewhere that sildenafil citrate will cause a heart attack. So you are worried, and that worry I am going to see that removed from you, and I will see that all of you start doing a good practice. So diabetes, hypertension, hyperlipidemia, and heart disease. Now, very important, endothelial dysfunction, why it occurs? Again, I am saying hypertension, diabetes, smoking, LDL, homocysteine is still a doubtful, and estrogen deficiency. All of them causes, endocrine dysfunction. With that, lipid deposition, vasoconstriction, and thrombosis occurs. It's a very, very simple thing. Now, ED can be an early sign of underlying cardiovascular disease. Suppose a young person enters in your clinic, 35, 40, erectile dysfunction, you are happy. Recently, some medical rep has come. He has given you either sildenafil, tadalafil, vardenafil, maybe apomorphine, maybe another drug. Newer drugs are coming every day. So you write it down. No, put your pen down. Same thing is the diabetes. Anything comes to you with the diabetes, put your pen down. Take at least 10 to 15 minutes of counseling that person. And you will be doing wonders in your practice. As I have been recently, 3.5 hours, I conducted a workshop on communication and counseling. Nobody has taught us. We are God. Bol diya na ye likh ke, to le lo. Don't do that. Try to understand, listen your client. And then if a diabetes is there, you tell them that it can create so many problems. What you should do? Every year get your eye checkup. Take care of your skin. Take care of your brain. There can be, chances of, strokes. Take care of your heart. And the kidney can be damaged. And the last and most important part, which we are worried to talk, it also causes a sexual dysfunction. It can cause erectile dysfunction. Then person is more worried that, I have to. And what do you know? You know much better than me. Diet, exercise, stress removal, and at the same time, the fourth one is a meditation you try to do, and one more thing, drugs. So all those things you put together. So it is a very interesting study over here, that 64% of the men who were hospitalized for myocardial infarction had ED. So we sitting over here, we missed it. If we would have told him 3 years, 4 years back that this is a warning sign, please take care, and then it would have been better. And secondly, 57% of the men who had a bypass surgery also had a prior ED. So just becoming aware of it, asking 3 or 4 questions in family practice. Nowadays fever are there, you know what type of fever. Second is take a blood pressure, you learn today. Third, ask about the diabetes. And fourth, you try to put this question. You don't have to go every time. When I see my wife, she's a family physician, newer things are occurring, experts are doing something different, and you think carpal tunnel syndrome, how many times you are going to see? But diabetes, blood pressure, every third patient. So try to learn 2 common things and you will be doing much better service to yourself. Now this is a very important slide. See, artery size has been shown. Now 1 to 2 millimeter. Penile artery are smallest. Juhu lane will be first blocked, then SV road, and then the highway. So penile artery are 1 to 2 millimeter. If that is blocked, you see over here, the lumen becomes smaller, less amount of blood, one will have erectile dysfunction. Coronary is 3 to 4. So here you will have a cardiac diseases. Carotid 5 to 7, TIA or stroke. And femoral 6 to 8, claudication. They say when I'm walking, particularly diabetic people, if anybody, any diabetic person gets, if he has to amputate his leg, I think we are responsible. It's a criminal thing on us. And I've got one case who came from Gujarat. They wasted 4 months. And then she came here. She got something from Japan. She said, with those flowers, I will feel better. Tell your patient, you continue whatever our medicines is there. You can see all the Jambu Ras, Ayurveda, whatever you want to do it. But you must see that you are under control. If you leave your steering, means if you go up to before Lonavala, you will come with an accident. But if you hold it, you will be able to go from Kanyakumari to Kashmir. So again, a message I am giving for any diabetic patient, any blood pressure patient, take some time. And they will pray you like a God that these are the people who has changed my life. So this is, you have understood very well. Now come down to what you have to be history taking. Nobody has taught you how to take a history taking. And normally I ask the people to come here, somebody becomes a client and role play, and you do not know how to utter this word. So first of all, you have to be very comfortable with yourself. आपने चाय पिया के कॉफ़ी पिया, सुबह कितने बजे उठते हो, पहले स्नान करते हो, आप बिस्कुट लेते हो, खाकरा लेते हो. In the same tone, you have to ask about the sexual life. And I'll show you 4 questions and it will make all the change. So medical history you take it, psychosocial history you take it. It will be sex में है, मेरे को बोला long it is. Don't worry, if you want to go Madam Katek के साथ अब जा सकते हो. Do you want to stop me here? I can stop here. No, let me take an audience poll. You want to stop me? Now loudly, I can't hear. Don't worry, okay? कितना बजा है अभी? 7 मिनट में कर लेंगे, okay? So medical history, psychosocial history, male history separate, female history separate, and then there is a combined history. A male said कि I cannot perform with my wife, but I am able to perform with a girlfriend. Don't tell that. Otherwise, the World War III will be there. Now, physical examination. And I will tell you, the female patient who are sitting over here, how to do a physical examination. For you, it is difficult. You see, best of the gynecologists are male. Female does not mind. But male, if you ask them that I want to examine you, finish. His dur-dur-dur will start, tachycardia will be there, perspiration will be there. His whole self-esteem is in the penis. He cannot throw a lady and say that I am impotent or I do not have any erection. And lastly, laboratory test. Now, one thing you must remember is smoking, depression. There are many drugs, and particularly antihypertensive, antidepressant, anti-androgen. These are the creating problem. So if Dr. Ratnaparki has written something, you find that in the history that this is erectile dysfunction, don't stop it. Say that I would like to talk to Dr. Ratnaparki, let me talk to him, and say, sir, this is what is happening. And there are ways and means how to manage it. But you must remember, these are the 2 drugs. Every 3rd person I find today is in depression. And if you learn depression well, you will be one of them, your next door practitioner. Now, lifestyle. All of us sitting over here, including myself, we tell our patients, today, where was my sleep last night? 6 days, 7 days I am out. So I have purposely avoided going to the sweet counter. Salad, I don't take it because even 5-star you get, your voice is changed. And I am 1 week before, if I have to give a talk, I don't take any cold things or any kacha thing or chutney. Because I owe my voice to you. If मेरा आवाज बिगड़ गया तो क्या करेंगे हम? So, type 2 diabetes, hyperlipidemia. Today you learn about sleep apnea, heart disease, hypertension and osteoporosis. You are dealing with them. So how can you not ask one more question? Now you have to remember, where is the place for sex in Mumbai? In one small room there is hardly a parda. One side father, mother and marriageable sister. Other side, and somebody who was here, he went away, he had sent his compounder to me. Same story I am telling you, one side parda, father, mother and daughter, manageable daughter. Second sign, on the, what you call, palang or on the bed, elder brother and his wife, and below the bed, younger brother and his wife. Can you imagine what sex life it is? It's very, very painful. So you should know, and being a family physician, you know that what is their condition, you know their which life they are coming. Now sexual history, I'll make it little more easier than this. What I'll do easier one. पहले तो desire होना चाहिए. Even if I have a desire, I cannot have here sex. Because medical grounding होना चाहिए, nobody should be there. So, and she should be ready. So first is the desire, then the blood circulation starts, then you will have erection depending upon the mood and mood of your partner. Then before ejaculation, there comes the penetration. And ejaculation may either it is immediately, that is what we call premature ejaculation or sigrapatan. Second is a delayed ejaculation. Third is an ejaculation. And lastly, retrograde ejaculation, an orgasm. So these are the 4 questions you have to ask. It is just 4 questions and answers. 2 things you must do to all the patients, blood glucose, HbA1c, and in a selected cases, I am telling you, you should not do it routinely, testosterone, LH, FS, and prolactin. When you will do, when you examine the patient, he is infertile, his semen quantity is less, if you touch the testis, it's a very small one, he doesn't have mustache, beard and other things, secondary sex character, then and then. And that also from a good laboratory, not from an ordinary laboratory. Otherwise, results are very, very wrong. Vitamin B12 and vitamin D, I will request you to do. Most of the people, we are all deficient as far as the vitamin D is concerned. So just try to do and you will be benefited, yes, my patient, and then you can write it down and sleep studies. Now, this is what I have done, Dr. Raj, home sildenafil test. Previously, I was the first person who started in 1986 to give intracavernous injection. Give an injection in the penis, ask them to stimulate, and then the erection will occur. So you'll know that how much it is perfect, mild, and no erection. But you cannot do over here. How many of the doctors have got that chance that they have got like Vicky Donor has special room? No. So I converted into home sildenafil test. Sildenafil is a Viagra of any of your choice. If there are no contraindication, that I'll tell you 50 to 100 milligram, you tell them that you take it at home. 3 times you take it, today, after 2 days, after 1 week. Switch off your phone. Either you like to watch something, or you're on a mobile phone, or on a video. Stimulate yourself. Your partner should be not there, because if she's there, then there is an anxiety. And once you get an erection, top and side view, you may not show your face. Keep it on and show it to me next time. This is a very easy test and it has been accepted everywhere. Now, how do you do? As I told you what you have to do, you are more relaxed at home. So you see the length, circumference and everything. Now, here is a penis which is flaccid. It's not erect even. This is a proper erect. But proper erect, sometimes it is slightly left or slightly right. So I said 3 times you do it, it's like a Olympic, best of the 3 we will take it. This is, you see, one small thing. Just examine all male, you just see prepuce, if it is very tight or if a diabetic person, he's not getting erection because there is no place of an erection. And last condition, after the age of 45, many people, their penis is bent. They have masturbated too much and that's why there is a plaque which is developed, so it goes on one side. This will immediately, so blood test, blood sugar test you have done, history you have taken, 4 questions and this is that the things are in your hand. Now, sildenafil citrate of your choice. And there was one brand, I am not saying because Viagra I said this was the first one who came. Very safe drug. FDA is approved. And there was another company which I was a chief investigator, under me 5 people were there, 2 urologists, 2 psychiatrists and 1 physician. And results are wonderful, very safe drug. Don't think that it will have a heart problem. 25, 50 and 100 milligram I was there. One more thing, 5 minutes, 2 minutes mein khatam karta hu. That whenever you tell the patient to take this, you say that you masturbate. If they just take up tablet and go to sleep, nothing will happen. That nobody tells anybody and patient said next day morning I was finding there was some erection. So tell them to masturbate. Second is a tadalafil, very safe drug. And the only problem with spartalapin, it should not be given to young people. It affects the spermatogenesis and it creates a severe myalgia. And where this should not be given, third one is apomorphine. Recently, they say it is a cardiac friendly, but it does not give a good erection. 8 milligram 3 times a day you can give. Now, two messages I want to give you of sildenafil started. Start with the 25 milligram small one, then go to 50 and then go to 100. If they are on a already blood pressure medicine, start with the smallest dose. Or if they are on the sildenafil, then I will ask the cardiologist to start with a smaller dose. Tell them to take, and what is there? It should not be with any nitrates. Because if they are with any sublingual, because many friends they give sublingual de diya, there will be hypotension and it will never be, it will be irreversible. You will have to rush to the hospital. So this, whenever you write, tell them that you should not be taking any other, because sometimes your heart patient, angina patient, he is taking morning walk, he is going. He met somebody, Mr. John, he said, why don't you take these pills and you will have a good strong, and he will have this problem. So before you give anybody, write this and find out this. Now, arginine is a good drug. This we will not do. As I said about any nitrates, either oral or other thing. Secondly, vardenafil has a QT interval increases. And lastly, suppose if you have given a sildenafil, it takes 24 hours to go out of the body. Then you can start with the resuscitation. But as far as the tadalafil is given, for 48 hours you should not give any, tadalafil recommended, no nitrite could be given. So this is a very important message. Intravenous injection have come, pessaries have come, pumps are there, inflatable implants are there. So more important is the penis is a barometer of CV risk. When a man has cardiovascular disease, always screen for ED. So sir, रत्न पारकी जी जितने भी ED आए cardiovascular उनको पूछो कि आपको तकलीफ होती है कि नहीं. Second, when a man has ED, always screen for CVD. And a man with ED, no cardiac symptom is cardiac or vascular unless prove otherwise. And this is what you see. वो आया है आपके पास ED के लिए. Major problem is after 3 years, Dr. Ratnaparki will have to give an angiography and he will have to take a further action. This we can save it. Now, exercise ability. After the angiography, many people come and ask what to do. After CABG also they come and ask. And none of the cardiologists has a time to do anything. I'm not blaming them. They should have some counselor. And my first case I remember, 1983. You know New India Society next to us in the Jewel Lane. Somebody abroad, Dr. Mathur operated on him. He collected, poor fellow collected money. His brother was a doctor. Every day he goes, collects money. Then he went over there for operation. And after the operation, there is his wife. They are very conservative family, like you and me, where we have grown. Their father had gone along with that. Next day, Dr. Mathur comes and says, there is one good news and bad news. Good news is your operation went very well. Bad news is your father had died. One who had never left the village, he came to Mumbai, he went along with him and he died. And then now the story starts. 3 years, his banyan had a small hole over here and Rudraksh Mala. This big, during those days, manuals were there. What to eat, what to do, how much exercise, when to have sex, all those, not that sex, all the things except sex. And when I asked him, have you had a sex? He started crying. 3 years I didn't touch my wife. When I asked wife, she said, वो करने गए और मर गई तो मैं कभी मेरे को माफ करूँगी. Now this thing needs to, as I said, first sentence, communication is required. Before that, sorry. This is a very important slide. After operation, if one can walk on a straight ground for a 1 mile in 20 minutes, or he can climb 2 staircases without getting breathless, in that case, with his wife, rather than thinking marathon, say that you slowly start the sex activity. And there is nothing abnormal. It is better to have good sex. What I am saying, what is ED? As I said, endothelial dysfunction, erection and diabetes, erectile dysfunction, early detection, which you can do, exercise and diet, you will be able to prevent early death. Friends, My request to you, ask them lifestyle changes that we have been hearing from morning. Then oral drugs which you can take it. Other problems are serious, you can send it to me. As I said, if you have given a sildenafil or avenafil, within 12 hours you can give nitrate. But if tadalafil is given, 48 hours you cannot touch them. Very important message. Only this is a contraindication. Lastly, I have developed my own style and I take workshop, how to take a history, how to treat the people, how to treat the malfunction. And this is my 1970 Masters at Johnson has started. That time they used to say, couple, leave everything and come and 15 days you be there. And now I go and teach not only in India, Nepal, Bangladesh and also Sri Lanka. You don't require any money and with that you will be with. And fortunately we have got now so many of the sildenafil, tadalafil, avenafil has come out. Newer therapy has come. It is very important the recognition from ED as a warning sign of vascular disease. That a man with ED and no cardiac symptom is a cardiac and vascular unless prove otherwise. So it is very important that if I get a case, I will refer to Dr. This thing. And what is canaries? You know anything? Last slide. Canaries, you know what is it? This bird? Olden days, 2 kilometer, huh? Give me come. 2 mile down and another 5 mile away. And what happens with canary? This is the bird which start fluttering. That means poison gas has come. So if somebody says I have got an ED, just think of the heart and help them out. I told you. I had conducted a workshop that I have told you. Thank you very much. बेटा इजेक्ट कर दो हो गया हाँ बेटा इजेक्ट कर दे वाह नहीं मैं ले ये तू निकाल ले
Thank you, sir, for that informative lecture. To felicitate Dr. Brahmbhatt, sir, I would like to call on stage GPR, sir, Smruti madam, Dr. Ram, Dr. Dadish, Dr. Seema.
Before announcing lucky draw and vote of thanks, I would like to
I would like to call on stage Dr. Anjali Bhojne for felicitation. Dr. Anjali Bhojne. Wait. Thank you, sir. बंपर ड्रॉ आणि हे कोण करणार आहे प्रांजल सर 38 लकी ड्रॉ आणि 2 बंपर ड्रॉ मग ते लास्टला म्हणतो पहिले आधी ओके Now I would like to hand over mic to Dr. Pranjal Ratnaparkhi for vote of thanks.
Who had said yes to extension of Dr. Brahmbhatt's lecture? सब लोगों ने? Because of that extra 20 minutes, we have cancelled all the lucky draw. ठीक है, because we have to empty the hall at 7 o'clock. 7:20 हो गया, वो हमको नोटिस दिया. नेक्स्ट कौन सा में देंगे, चलेगा? Anyway, I am not so cruel. Okay? हाँ, not. So जिन्होंने हाथ ऊपर किया है उनको नहीं मिलने वाला है. वीडियो निकाल रहा. Anyway, before we start all these prizes, lucky draw, Dr. Pranjal Rahul Ratnarki is excited to thank you all on behalf of Guru Krupa Heart Foundation, on the behalf of Ratnaparki family. Okay, so let me hand over this mic to my next generation. You have seen Dr. Rahul, you have seen Dr. Rucha and Pranjal, my, how, 10. So, what love, Ruchapan, what love, affection, support you are given to me, please request to extend all this new generation. My daughter-in-law, Rahul's wife, Dr. Pranjal.
Wow, what a scintillating experience, the 7th CardioCon. What an amazing experience, this 7th CardioCon. And this is all due to your vibrant, dynamic presence. Presence of thousands of great physicians and great humans made a huge difference. Small academic feast made into an extravaganza and festival of knowledge. We all, Team Guru Kripa, Team AMA, MCVP, bow down in front of all of you. Without you all, this event would not have been possible. We wish for all of you to keep same love, affection, and blessings in future as well. This sea of great physicians was fed satisfied academically by 10 oceans of knowledge and experience. Yes, I'm talking about our reputed speakers. Free-flowing rivers of knowledge were fulfilling the satiety of academics. We are all thankful to our internationally reputed speakers. इससे एक दोहा याद आ गया. गागर में सागर भर दिया, कौन प्यासा रहेगा? विद्या का द्वार खोल दिया, कौन भूखा रहेगा? Our chief guests are diamonds in the society and in the cineworld, dazzling and shining stars, superstars in their own field. We are thankful to our chief guests, reputed Shri Arun Govil Sir, Shri Ashok Saraf Sir, Shri Dilip Jadhav, and star from a medical fraternity, Dr. Praveen Soni Sir. You all made a difference and added essence to our conference. Thanks to all of you, respected sirs. Now I extend my sincere gratitude towards my family members, that is members of AMA, MCVP, and Team Guru Kripa. Words are insufficient to express my feelings towards all of you. I can't imagine a conference without you all. AMA under the leadership of Dr. Ashok, President, and Dr. Smita. MCVP under leadership of Dr. Shashank Shah, President, and Dr. Rajesh Tiwari. And entire team clubbed and termed as Team Guru Kripa. Your untiring efforts from last 2 weeks, last entire year, has given rise to this grand, successful conference. Special thanks to our trustee of Guru Kripa Heart Foundation, Dr. Ram Chauhan, a pillar of Guru Kripa, a versatile personality who shouldered all the responsibility and successfully completed it as well, as if it was his own son's wedding. We thank all the trustees of Guru Kripa Heart Foundation under leadership of my Papaji Dr. G.P. Ratnaparki sir for their liberal approach and generous blessings towards this enforce. You all know that team of Guru Kripa is always there for academic activities and helping society in need, truly leading from the front. Again, we thank all staff and family members who were constantly on toes since 2 to 3 months managed and systematically, single-handedly managed all correspondence and financial communications. Dr. Anil Kumar, in spite of busy cardiology OPD in Guru Kripa, managed speakers coordination excellently. We are thankful to all pharma industry for their generous academic grant. The best part of their grant is that they have given more than expected, as if it was their own conference, always in debt of their love and affection. As usual, Sachin and entire team of audiovisual has done excellent job and given very satisfying and smooth experience. Thanks to Sachin and team. Similarly, Hotel Lalit staff and administrator has extended their hands to help make this academic event festive and grand. It was a wonderful conference indeed, but all good things have to come to an end. Rather, I'll say it as beginning of next year's conference. So at the end of this event, I thank all of you. Your divine presence and your divine support remind me of a song saying in Marathi. मागे उभा मंगेश पुढे उभा मंगेश मागे उभा मंगेश पुढे उभा मंगेश माझ्याकडे देव माझा पाहतो आहे. Thank you all. See you again next year with same enthusiasm. Thank you. God bless.
Thank you. Wonderful, beta. Very good. Nice. Okay, nice. Okay, मंगेश म्हणजे देव. तुम्ही आमचे देव आहात, दैवत आहात. मागे उभा म्हणजे हे जे आमची AMA, MCP किंवा जी माझी गुरुकृपा टीम आहे ती मागे आहे. सो समोर देव आहे आणि मागे देव आहे. म्हणून म्हणते ती मागे उभा मंगेश पुढे उभा मंगेश मागे उभा मंगेश पुढे उभा मंगेश माझ्याकडे देव माझा पाहतो आहे. माझ्याकडे देव माझा पाहतो आहे. मागे उभा मंगेश पुढे उभा मंगेश. या मंगेशाला नमस्कार. Thank you very much. Keep loving. It's the end of our conference. Sorry for the delay, but असंच प्रेम, असंच उत्साह, असंच सहकार्य राबू द्या. धन्यवाद, धन्यवाद, धन्यवाद. Okay, now, don't worry. Don't be emotional. अरे आ जाओ टीम, आ जाओ पटापट. या मुलींनो, या पटापटा. कारण भरपूर आहे म्हणून म्हटलं. या रे काटे राम खालून काढू का? बरं खालून काढतो. आप तुम्हारे आज मैं खुश हूँ. जो इच्छा है वो पूरी कर दूंगा, है ना? हाँ चलेगा. सुषमा तुरबाडकर. आए. These are the simple gifts. Bumper will be last. आएगा सुलभा सुरमा काय सुषमा. ए बाप, अरे बाप, वाट लावलीस. बॅग दे. काय मॅडम रिलॅक्स, कुठे जाणार नाही आम्ही. दे. रिलॅक्स, नो प्रॉब्लेम. नाही नाही ते काय काळजी नका करू. पूर्ण वेळ थांबू आपण. हॉलचं भाडं आम्ही वाढवलं आहे आणि ते सरांच्या बिलमध्ये लावलं आहे आम्ही. ओके. हां, सरांनी एक आपल्याला आपले त्यांनी एक चेक दिला आहे मला गुरुकृपा फाउंडेशनला. हां हां घे काढतो. तुम्ही काढा काढा काढा. स्नॅक्स, टी, कॉफी घ्या ना, काढा पट. धनश्री चौधरी. वाव, पळू नका, पडाल नाही तर. घ्या नेक्स्ट. काढा काढा पटापट काटे काढ. हा काढा काढा वेळ आणखी भाडं वाढेल. हा भरपूर आहेत. एक ही चेक मिला अपने को डॉक्टर ब्रह्मभट्ट से. अदिल पटेल. नेक्स्ट काढा. अदिल पटेल साहेब आओ. अरे या ना काय उभे चांगला फोटो बिटो काढा. चांगला साड्या बिड्या घातल्या तुम्ही मस्त फोटो बिटो काढा. या प्रसाद सामंत. अबिद खान. कौन है प्रसाद कि अबिद खान? आ जाओ. सुनील घाग. सुनील घाग है? घाग है क्या? हाँ. इंदल कुमार राजभर. राजभर. निर्मला सावंत. हो. सुजाता पटेल. सुजाता पटेल. यू आर देयर. हाँ. विनोद कांबळे. पुढे. विनोद केले इतक्या टाळ्या. एकदम पॉप्युलर लागतं विनोद. हा हे बघा किती आहे. नाही तर आपण काढत बसून राहणार नाही का मग. पुन्हा एक चेक मागावं लागेल ब्रह्मभट्ट सरांना. अरुण सिंग. अरुण सिंग. त्यांना द्या ना. बघा किती उरले किती बघा. विक्रम गौर. विक्रम गौर नहीं है. विक्रम गौर. विक्रम गौर है. अच्छा सरप्राइज सभी लोग हैं ना. नहीं तो लास्ट टाइम कोई नहीं रहा तो ताली बजाते थे आप लोग. वो मौका नहीं मिल रहा आपको. SS शिंदे 96 अरे आएगा. हाँ बस ठीक है सर. बम्पर है ना. हाँ. नीलोफर पटेल. ऋषभ जैन. ऋषभ जैन. कृष्णा कारेकर. अरे वाह है कारेकर साहब. अत्तार सिंह. कृष्णा कारेकर जी. बस थांबा आता. निर्जा मिस्त्री. निर्जा मिस्त्री. डॉक्टर दिलीप जैन. डॉक्टर दिलीप जैन इकडे. आवाज इधर से भी आया. डॉक्टर वैशाली जैन. वैशाली जैन. दिलीप जैन. वैशाली कुठे झालं. कोण आहे आपकी. नहीं. दिवेश विसारिया. दिवेश विसारिया. दिवेश विसारिया. हाँ गया. कितने बाकी है. बाकी कितने है. शिंदे से रिपीट हो गया ना. ये भी हुआ है. तूने क्या फाड़ा नहीं क्या. डॉक्टर भरत व्यास आहे. कुठे आहे. भरतच नहीं है. खुशी की लहर आनंद मालुसरे, आनंद मालुसरे, सुनील गडकरी, पार्थिव संघवी, क्या बात पार्थिव, लेकिन बम्पर गया तेरा। सतीश खोड़ा, सतीश खोड़ा, ललित शुक्ला, शुक्ला, यस, डॉक्टर है ना, तो डॉक्टर लिखा नहीं, डॉक्टर लिखा नहीं, अच्छा किसने, लड़की ने लिखा। हाँ। डॉक्टर हितेश दुबारिया आहे, नाही गेला। महेंद्र देसाई, किती बाकी आहे? डॉक्टर व्ही कुलकर्णी, मयूर पारेख, मयूर पारेख, कुलकर्णी, वी कुलकर्णी, आ जाओ। दौड़ो मत, दौड़ो मत, अरे ऑलरेडी एक हम कैजुअलिटी है हमारे पास। और द फेमस दिनेश सिंह, डॉक्टर अमय पोतनीस, हाँ पीठ क्यों लगा रहे हो? दिलीप खेताड़े, उल्टा सीधा हो ना तू। दिलीप खेताड़े है, अरे वाह। डॉक्टर वैभव मिस्त्री, हाँ मुकेश रावल, मुकेश रावल, डॉक्टर आशीष यादव, डॉक्टर संजय सिंह, था ना वो, क्या थोड़ा पेशेंस रहता तो मिल जाता ना। नितेश कर्नीरे, कितना बाकी है? 4। लियो, हेलो, महराज मोहिन, ठीक, डॉक्टर पीजे मेहता, फ्रांसिस कोलाको, मिनहास, मिनहास, मिनहास मुनीत, फार्मेसी की तरफ जाके पढ़ना पड़ेगा, हाँ? थोड़ा हैंडराइटिंग इंप्रूव करो। डॉक्टर शेखर अंबाडेकर, खाना तो ना, हाँ। नागवेकर, मनीषा नागवेकर, सुलभा पवार, डॉक्टर ईश्वरी बिरुड, ईश्वरी बिरुड, डॉक्टर JR शाह। JR शाह नहीं, JR शाह नहीं है, JR शाह, डॉक्टर JR शाह। आवाज दो कहाँ हो, मैं फाड़ने वाला था। आओ ऊपर, कहाँ से भैया? दो JR शाह, नंबर बताओ। यस, टाई हो गया। यस, अभी एक कुश्ती करेंगे, जो जीतेगा वो जीतेगा। हाँ चलो आ जाओ, जो कुश्ती करा जीतेगा। 310 एंड द विनर इज, सॉरी और दो है। सुरेश आंकले, अरे वाह वाह वाह, एक। अंजलि चौहान, नाउ इट्स टाइम फॉर बंपर ड्रॉ। हा मग तेच असं मध्ये मध्ये आठवण करायला द्यायची, ते चुळबुळ होते ना, ते शांत राहतात। डॉक्टर जगमोहन दालमिया चोपड़ा, डॉक्टर जगमोहन दालमिया कौन था मालूम है ना? जगमोहन दालमिया कौन था मालूम है क्या? नहीं, उनको क्वेश्चन का आंसर देने के बाद ही मिलेगा। हाँ, जगमोहन दालमिया कौन था? अरे उनको देने दो ना यार आंसर, उनके प्राइस का सवाल है यार। ठीक है, एनीवे चलो ले लो। हाँ मालूम नहीं? जगमोहन दालमिया फर्स्ट इंडियन आईसीसी प्रेसिडेंट था। ओके एनीवे चलो, क्विज मास्टर, मैंने ऐसा नहीं कि सब पढ़ के बताता, मैं वैसे ही बता सकता हूँ। हाँ नहीं, नाराज ना खाओ। नाराज मत हो जाओ, एंटरटेनमेंट चाहिए कि नहीं लाइफ में? हाँ वाह, हाँ दो, हाँ ठीक है। हाँ ये दो जो बम्पर निकालने वाले हैं, हमारी सौभाग्यवती डॉक्टर स्मृति रत्नपारखी, वो एक निकालने वाले आंख बंद करके, और हमारी समदन जी डॉक्टर स्मिता घाटकर निकालने वाले हैं। क्या? हाँ निकल फोटो। देखा क्या सबने अस्त ऐसा एक फोटो के लिए किसको ही प्राइज मिला, अपन फोटो में आना चाहिए। है ना, तब से मैं देख रहा हूँ फोटो गिफ्ट किसको भी मिलो, फोटो अच्छा स्माइल है, स्माइल दे रहे। वो बेचारा लेने वाला कम स्माइल दे रहा है, इनका स्माइल ज्यादा है। गणेश कंवर बम्पर प्राइज नहीं है ये। डॉक्टर प्रेम यादव नहीं है? ओए अरे लास्ट राजेश भाई घाटकर, डॉक्टर राजेश घाटकर हमारे समधी। श्रद्धा केदार है? नहीं है? यस, कुड़ा है? सच्ची है ना? सब लोग मायूस हो गए ना, उसका क्या? चलो ओके, थैंक यू, रिलैक्स, यू कैन हैव टी कॉफी, भजे एंड गिफ्ट। हाँ बैग दो बेटा, एज यूजुअल। बाय, शब्बा खैर, कभी अलविदा मत कहो दोस्तों, न जाने कहाँ पे मुलाकात होगी, न जाने कहाँ पे मुलाकात होगी।